Morning, everyone. Welcome to the IACC meeting. My name is Dr. Megan Kinane, and I'm the DFO for the IACC meeting for this IACC meeting. And in my day job, I'm the Senior Advisor to the Director of the National Institute of Mental Health. So I want to welcome this new iteration of the IACC. I'm joined by Dr. Jennifer Johnson, who will have a few minutes to talk about herself.
Good morning. I'm delighted to welcome you to this first convening of the new member of the Interagency Autism Coordinating Committee. It's always an exciting time when we have new members join the committee, and it's really wonderful to have you all here. I am Jennifer Johnson, and I'm the Deputy Commissioner for the Administration on Disabilities, and we are in the Administration for Community Living, which is part of HHS. I've had the privilege of engaging with the IACC throughout my more than 20+ year federal career, and I've really enjoyed the opportunity to connect with the committee and to be able to address really pressing issues that the autism community faces. And so I really deeply value the role that this committee plays in helping to shape federal policies and our efforts as well. This committee, as you all know, brings together people with autism, their family members, and other experts who are really working alongside federal partners to identify and advance solutions that best support autistic people to live well. As we bring on new members into the IACC, we are entering into a new chapter in the life cycle of the committee. And as new members, you join a strong legacy of service of those who came before you, but you also bring new insights and energy and a renewed focus on the needs of the autism community. And I'm really grateful that you've chosen to be a part of this work. As part of this new chapter, I want to briefly note that we are in a period of transition regarding the support structure for the IACC. And Diana Diaz-Harrison, who's down to my left, she is the Principal Deputy of the Administration on Disabilities at ACL, and she is also the National Autism Coordinator, and she'll be providing more details on that transition shortly. So I want to thank you again for your service and for your dedication, and I'm very much looking forward to the important work that we will do together.
Great, thank you, Jennifer. And I will start off by making a few housekeeping notes if I can. Starting off, meeting materials can be found on the IACC website, and they've also been sent to the members in advance. Slides, a transcript, and a video recording of the meeting will be posted shortly after the meeting. Closed captioning is available in Zoom for committee members and on videocast for members of the public. A sensory room is available if you exit to the out of the room. It's the first room on your left, conference room C, if you need to use that. Please do not use that room for any noisy activities or calls. We do have another dedicated conference room D, which is a little farther down the hall, I think also on the left. It should be clearly labeled. Feel free to use that room for any calls or noisy activities that you need to do. Restrooms are located off the main lobby. You would have passed them as you came in from the elevators. And please be sure to silence your cell phones. We are going to ask that you keep comments brief during the discussion today because we do have a very packed schedule. And then finally, for those in needing cart services, please scan this QR code. I'll leave this up for a minute. For today's meeting, we are excited to welcome 43 members to the IACC, including 20 new public members and 23 federal agency representatives. At today's meeting, we will have an opportunity to hear from each of the new members and learn about their priorities. Following introductions, we will discuss public comments received by the committee from the autism community, and following a lunch break, we will launch into the committee business portion of the meeting. We will hear 3 topical presentations prepared by members of the committee to address needs in the community. Now I'd like to turn it over to Dr. Matthew Nestle, Principal Deputy Director of NIH, to give a more brief opening comments.
Morning, everyone. Thank you. Welcome to NIH. It's great to see you all here. It's really a pleasure to be here, and I'm grateful to have the opportunity to be part of this meeting today. First, I want to recognize Dr. Diana Diaz-Harrison for her leadership bringing this new committee together. That really took a lot of commitment, so I really want to just extend our thanks for your leadership here and commitment to the IACC. Secondly, I want to thank our NIMH colleagues for arranging this meeting, getting us to this point and bringing us all together here on the NIH campus. Again, a lot of hard work went into bringing this together, so really thank you all for your work. NIH's mission is to pursue really fundamental knowledge and about science, and then turning that into improvements in people's health. And research on autism is squarely in the middle of that mission. And so, I think I speak for all my NIH colleagues that we are committed to that research and continuing that mission. NIH's investment in autism research has grown steadily over time, supporting a broad portfolio that spans foundational science, interventions, and services, with hundreds of projects underway across multiple institutes and centers. Last September, we launched the Autism Data Science Initiative, investing $50 million in autism research. This is one of the most significant autism research commitments that NIH has made in recent years. These projects integrate data across many areas, including environmental exposure, prenatal factors, immune responses, and long-term outcomes, bringing information together in ways that simply was not possible before. A key feature of the initiative is exposomics, looking comprehensively at how environmental factors like air pollutants, pesticides, and maternal nutrition interact with genetics. We need to understand the full picture. We've built in independent replication and validation hubs to make sure findings hold up across diverse populations, because reproducibility is not optional. This is a coordinated effort across NIH, and every research team is working in direct partnership with the autism community. Autistic individuals, caregivers, and service providers are helping to shape this research. That's the right way to do this work. At the same time, and just as importantly, NIH is expanding efforts to leverage real-world data, working across HHS and partners like CMS to better understand all aspects of autism, understanding diagnosis trends, outcomes, access to care, and disparities across populations. Importantly, our work is not only about understanding causes, it's about improving services, support, and outcomes across the lifespan, including for individuals with more complex needs. I'm here today representing NIH leadership. Dr. Bhattacharya apologizes he couldn't be here. He's in Montana meeting with the tribal council, but you have my attention, and your perspectives matter and will help inform how we continue to shape our work going forward. So I'm genuinely looking forward to the meeting, and I'll stop there and let you all take over. Thank you.
Okay, at this time, I'd like to introduce Diana Diaz-Harrison, who I think you've mentioned a couple times already. As I mentioned, she is the Principal Deputy Commissioner of the Administration on Disabilities in ACL, and also the National Autism Coordinator, a role she was appointed to in February of this year. It's truly been a delight working with Diana and getting to know her. She brings, if you know her, immense passion to this work and a deep commitment to advancing opportunities for people with autism across the lifespan. Before joining ACL, she served as the Deputy Assistant Secretary for the Assistant Secretary for the Office of Special Education and Rehabilitative Services in the U.S. Department of Education. And she is the founder of Arizona Autism Charter Schools, which was the nation's first autism-focused charter school network. She also created the National Accelerator of Autism Charter Schools. Her leadership has been recognized nationally through honors such as the Yaz Prize and the National Title I Distinguished School Award. Please join me in welcoming Diane.
Thank you, Jennifer, and thanks to everyone who made this meeting possible, especially our chair, Dr. Sylvia Fogel. It's been an honor to collaborate with her and the team in getting ready for this meeting, which is a long time coming. As it was mentioned, in addition to serving in this autism-specific role, I also serve as Principal Deputy Commissioner for Disabilities at HHS's Administration for Community Living, in partnership with Commissioner Rebecca Hines and Dr. Jennifer Johnson, who is Deputy Commissioner. I come to this work not only in an official capacity as I am a new government employee, but as a mother. And we can move forward with slides. I don't have a clicker. Next one. Before, yes. My 23-year-old son, Sammy, has profound autism and epilepsy. Like so many of the distinguished members of this committee, I know firsthand both the joy and the daily challenges of loving and caring for someone who requires 24/7 round-the-clock support. That experience grounds me and gives so much urgency and meaning to every decision we make here today. As it was mentioned, I also bring professional experience to the role from my home state of Arizona, where I founded educational programs that serve students across the autism spectrum, along with workforce development programs for young adults on the spectrum and a specialized healthcare clinic. Through that work, I've seen what's possible, and I've also seen where the gaps remain. I believe Secretary Kennedy appointed me and this committee because he understands that this moment calls for urgency and action. Our community cannot wait. We must move forward with purpose beyond identifying gaps to create and improve services, research, and healthcare. And we need to do so with coordination, accountability, and speed. Next slide. I want to briefly share the foundation for this role. The National Autism Coordinator, I think if you click one over, the definition will be there, is a congressionally mandated position under the Autism Cares Act, with the first coordinator being appointed in 2016. While housed within HHS, the role is implemented across federal agencies charged with aligning efforts across research, services, and supports for people with autism and their families. A central responsibility of the position is to support the implementation of the IACC initiative and strategic plan in close partnership with federal agencies and with meaningful input from the public. I'm fortunate to be supported by the existing Office of National Autism Coordination, and I'm especially pleased that Beth Tigner, also a political appointee and fellow autism mom, has joined the team. As many of you may know, the Office of National Autism Coordination is currently housed at NIMH, but there is a thoughtful process taking place to relocate the ONAC to the Administration for Community Living, where other disability programs are housed. Looking ahead, and we'll go to the next slide, we are committed to turning strategy into action to support implementation of the priorities we set forth here. We will convene quarterly meetings of the Federal Interagency Working Group on Autism, known as the FIWA. We will also engage directly with individual agencies to ensure that the initiatives we identify are carried out with focus and follow through. To our federal partners in the room, this work cannot succeed in silos. I invite you to partner with us to champion these priorities within your agencies, to find a way to elevate them and to help drive the kind of change that families across this country are waiting for. On World Autism Day this past April 2nd, many of you were there, Secretary Kennedy spoke to families from across the nation and made a clear promise that they are not alone, that we together are committed to building the supports and the safety net that America's autism community deserves. He has selected each of you to serve on this committee because your voices matter, because your expertise, lived experience, and your leadership are essential to shaping policies that improve quality of life for children, teens, and adults on the spectrum. Please know that the work we do here is a top priority for the Secretary and for me. I look forward to working alongside you and to share our progress as we move this mission forward on behalf of people with autism across America. And with that, I will turn it over to our chair, Dr. Sylvia Fogel.
Thanks, Diana. Welcome to all IACC members, federal and public, as well as our guests and observers. Thank you to Secretary Kennedy for the opportunity to serve, to Diana Diaz-Harrison, our National Autism Coordinator, for your leadership, and to the Office of National Autism Coordination and NIMH leadership for organizing today's meeting. And a special thanks to those who submitted public comments. Your perspectives are invaluable. I am a physician with over 20 years of clinical experience. I've worked with hundreds of autism families and caregivers. These families love and deeply value the individuals they support. They celebrate their full humanity and advocate tirelessly in systems that have not kept pace with a community now affecting 1 in 31 children. But alongside that love, especially for those with the most complex needs, is deep exhaustion and a constant, terrifying question. What will happen to their loved ones when they can no longer provide care? I am also a mother to 3 children, including my 17-year-old son, Theo, who has profound, minimally speaking autism and complex medical needs. He requires continuous 24/7 care. From a deeply personal perspective, I understand the challenges facing individuals and families with the highest support needs. I recently came across a social media post from a desperate autism family. Their young teenage daughter, non-speaking, is seen wearing a rubber helmet and large hand mitts, banging her head and hands against any solid surface she can find. After being kicked out of her group home, and after multiple emergency visits without answers or effective treatment, the family turned to social media for help. This family is not unique. Countless families struggle with severe self-injury without appropriate medical evaluation and without access to effective treatments. Some autistic individuals are thriving. Improved recognition and supports have made that possible, and that progress is worth celebrating. In addition to my son, one of my daughters has autism, although hers looks very different. She is articulate, independent, successful, with a wicked sense of humor. Despite challenges, she is able to use her talents across school, work, and life. And yet many individuals like her, with the lowest support needs, also experience real challenges, including with co-occurring medical conditions, anxiety, and loneliness. As a clinician, I've seen a false tension drawn between acceptance and treatment. Focusing on treatment does not diminish a person's inherent value. Rather, it reduces distress and helps individuals more fully express their strengths and talents. But for many families, adequate medical treatment is also necessary to address abject suffering. Many in the autism community are facing intense daily hardship driven by undiagnosed or undertreated medical and psychiatric conditions, safety risks, and increased mortality. Some experience significant physical pain that they can't communicate from conditions such as gastrointestinal disorders, dental issues, or chronic headaches or migraines. Pain that leads to behaviors that are too often dismissed as just part of autism. I have witnessed this repeatedly in my 2 decades of practice. It is unacceptable. And I can't help but wonder if the young woman I saw on social media is suffering from pain from a medical issue that has been overlooked. The needs of individuals across the entire autism spectrum matter, and there is more that unites this community than divides it. But some of today's proposals are specifically aimed at addressing the chronically underserved needs of those with the highest support requirements, who have waited too long to be seen. I welcome robust discussion and debate as we evaluate proposals that address clear and correctable gaps in medical care, safety, and policy recognition, particularly for those with the highest support requirements. These are practical, evidence-based proposals that address a failure of translation, implementation, and coordination. They can be carried out within existing authority and directly align with the statutory responsibilities of the Autism Cares Act of 2024. That law states that we, the IACC, shall monitor autism research, services, and supports across the lifespan, and shall make recommendations to the Secretary, incorporating public input. Importantly, these duties are not optional. Congress did not use the words should or may with respect to these obligations. It used the word shall. We are charged to act. Thank you.
Thank you for these inspiring words from Diana, Matt, and Sylvia. Really appreciate your insights. I will now do the roll call, starting with the federal members. When I call your name, please turn on your microphone and say either here or present. And if I mispronounce your name, please correct me. Jennifer Height.
Here, and it's Kate, Jennifer Haight.
Height, great, thank you. Rebecca Hines.
Here.
Christina Chacon.
Present. It's Chacon.
Chacon. Matthew Maynard.
Here.
Caprice Knapp. Nicole Williams.
Present.
Deidre Essay. Present. Scott Robertson.
Present.
Christy Kavalik.
Present.
Elaine Cohen-Hubel.
Cohen Hubble, present.
Cohen-Hubble, thank you.
Thank you.
Luke Hall.
Present.
Margaret Bush.
Present.
Leah Lozier.
I'm present. Leah Lozier. Thank you.
Lozier, thank you. Marcella Ronyak.
Good morning. Present.
Wonderful, thank you. Matthew Memley.
Present.
Rohan Havra.
Present.
Deborah Tucci.
Present.
Courtney Wimbley. Andrea Beckelmanster.
Present.
Amy Adams.
Present.
Rick Lambert.
Present.
Allison Marvin.
Present.
Clifford Smith. Moving to the public members, Lisa Ackerman,
Present.
Elizabeth Bonker,
Here.
Laura Salini,
Here.
Sylvia Fogel,
Here.
John Gilmore,
Here.
Crystal Higgins,
Here.
Daniel Keeley,
Here.
Hayden Larson,
Here.
thank you. Elena Monarch,
Elena Monarch, present.
thank you. Elizabeth Mumper, Bill Oldham, Jennifer Phillips, thank you. Jennifer Phillips,
Here.
Honey Rinsala,
Here.
John Rodriguez,
Rebecca's here.
Doctor, thank you. Daniel Rossignol,
Here.
Tracy Slutzovic,
Here.
Katie Sweeney,
Here.
Ginger Taylor,
Here.
Lisa Wiederlight,
Present.
Walter Zadarani.
Here.
That concludes the roll call. Now I would like to provide a brief overview of the IACC and the federal government. Is this working? Okay, wonderful. So as you all are probably aware, the IACC is a federal advisory committee that coordinates federal efforts and provides advice to the Secretary of Health and Human Services on autism. As you heard, the committee was originally established under the Children's Healthcare Act of 2000 and then was reestablished under the Combating Autism Act of 2006 with reauthorizations every 5 years. The most recent reauthorization was from the Autism Cares Act of 2024. You can see the current IACC membership. This is the public non-federal members that we just called out. And the current IACC members who are represented by members that we called earlier and will call today. To go over a little bit about what the IACC cannot do, it is a federal advisory committee, so it is not in charge of funding research or allocating federal research dollars. not in charge of direct funding or implementation of federal programs. It cannot set or create federal policy, and it cannot create policy for states or non-governmental organizations. It can also not create medical guidelines. What the IACC can do is to convene at least twice annual. This is the first meeting of this fiscal year. Coordinate federal activities related to autism, gather public input on issues related to autism, develop and finally update a strategic plan for autism, and this is congressionally mandated. Additionally, to develop an annual summary of advances in autism research, which is also congressionally mandated. You monitor federal activities related to autism and make recommendations to the HHS secretary. This is an IACC core values that was established by the IACC from 2021 to 2023. It is able to be revised by this committee should you so desire, but you can see that I think these are in the spirit of the IACC with broad participation, community focus, spirit of collaboration between the federal and non-federal members, responsiveness, excellence, and impact. The IACC typically meets 3 times a year. We are still working on other dates for this year. Typical meetings include time for committee business, which we'll work on this afternoon, and that will include working on the strategic plan and the summary of advances. The IACC is also authorized to get presentations from federal agency or other community organizations, as well as researchers in the field. We do take public comments at every meeting and generally get an update from the National Autism Coordinator, Dr. Diaz Harrison, and updates from IACC members. Again, additional preparation presentations are allowed by other committee members, and that will be up to the committee to decide what you're interested in hearing about. In the past, these are the components that have been discussed by previous IACCs. So with these presentations are all available by videocast. So if you have any interest in what the previous IACCs have heard about, they're available to you. And more information can be found on the IACC website. So now I'll turn it over to Jennifer for the introduction of the public members. You want to go through the protocol?
So we wanted to do introductions now of the public members of the committee. We are again delighted to have you join the committee and share introductions about yourselves. We ask that you keep your introductions to 1 to 2 minutes. We have a full agenda, and we want to make sure that we are able to get through all the items on the agenda. And so again, we ask you to keep to that time frame. If you do begin to run over time, we will provide a gentle signal to you all to wrap up your introductions. And know that there will be additional opportunities to share your priorities and your expertise with the committee as we go through our agenda today and in future meetings. For your introductions, and I wasn't supposed to move, but that's fine, sorry. We ask that you state your name and affiliation, and please note whether you are an autistic individual, a family member, or have some other kind of connection to the autism community. We ask that you briefly highlight any relevant personal and professional experience that you bring, and we welcome a short statement about your priorities for your service on the IAC. And so we will begin with our introductions. So we'll just go through the list here. First, we have Lisa Ackerman.
Hi there. Thank you, Secretary Kennedy, and thank you to this team and administration for making autism a strategic priority. My name is Lisa Ackerman. I'm the co-founder and executive director of Autism Community in Action. I'm the mother of 2, grandmother of 1. My son Jeff is 29 and was diagnosed after experiencing a severe regression at 15 months. At that time, when I reviewed the 22 symptoms of autism, Jeff had 19 of them if he was awake. I'm proud to say with access to medical care and therapeutics, he is a bright light. He's worked so hard to get where he is, and he's thriving, a college graduate, employed, driving, and an accomplished musician. My family's journey continued with my grandson diagnosed with autism. His regression experience was different, but the lessons learned through his Uncle Jeff have made a big difference. Over 26 years, we've worked with 100,000 families, and it's no secret I've been a critic of the IACC, and I'm grateful to be here. It is an honor to serve, and there's three things that I really hope we can accomplish. One, support families. Strengthening the connection through research and care is so important. Second, addressing the diagnostic backlog. The families are waiting 12 to 48 months for a diagnosis across the United States. Third, strengthening special education, waivers, resources, and accountability. These are all critical services families need access to, and we want to help them. I'm grateful to begin this work with this incredible committee, and I'm honored to have the legacy of Dr. Bernard Renlund be my guide. And I just want to say, working forward together to provide the rigorous science, strengthening services, and improving outcomes. My one motivation is to keep working until families no longer need us to fight so hard for answers, and for every person with autism to lead a healthy and independent life. Thank you.
Thank you so much. Next, Elizabeth Bonker.
Hello, I'm Elizabeth Bonker, Executive Director of Communication for All. More than 99% of non-speakers have not been taught to communicate as Caden and I do. Non-speakers are misunderstood and underestimated. We have a motor disorder called whole body apraxia that should not be confused with intellectual disability. I advocate for IACC to focus on three priorities: communication, safety, and co-occurring medical conditions that are urgent needs for non-speakers. For communication, I advocate for HHS to 1, increase access for non-speakers by issuing federal guidance clarifying communication rights found in the Americans with Disabilities Act. 2, give families choice by including Medicaid coverage for typing training and support. And 3, implement the communication section of the Autism Cares Act to focus on full communication for non-speakers and research that makes typing easier, including interventions that mitigate whole body apraxia and improve regulation. For safety, I advocate for HHS to 1, issue guidance on wandering and drowning prevention, including elopement protocols and cameras in classrooms and schools. 2, require law enforcement autism training to avoid autistic people being misunderstood and harmed. And 3, we must stop the shock. No autistic person should be shocked to stop quote behaviors. We are people, not lab rats. For co-occurring medical conditions, I advocate for HHS to focus on how to help autism families with their most urgent medical needs, including seizures, dysregulation, autoimmune issues, whole body apraxia, and gastrointestinal disorders. Life is agony if you cannot communicate, feel afraid, or are not well. We can and should do more for families who face these challenges every day. With communication, safety, and wellness, we can live happy, productive lives. Thank you.
Thank you. Next, Laura Salini.
Hi, my name is Laura Slaney. Thank you. I'm the mother of Jonathan, a young adult with autism who suffered a severe regression when he was a toddler. We didn't know it at the time, but later we would learn that Jonathan also suffered from a primary immune deficiency and other co-occurring medical conditions. And it was later that treating those underlying and co-occurring medical conditions allowed us to alleviate and reduce the symptoms of autism. So that experience has really inspired me to promote a better understanding of how those underlying and co-occurring conditions are contributing to the symptoms and severity in autism. That is one of my priorities for this committee, is that we would promote
research that is very cohort-based and individualized so that we can get better insights and treatments that might be more effective. My experience is as a policy advocate. I was a political scientist before this, and I worked in Illinois establishing numerous laws around autism. I previously served on other statewide advisory councils for autism, including the early intervention, the autism task force, as well as leading the Medicaid waiver subcommittee for the adoption of our waiver here in Illinois. I look forward to working with everyone. Thank you.
Thank you. Next, we have Sylvia Fogel.
I feel like I've already done my introduction, so I'm good.
You yield back, okay. Next, we have John Gilmore.
Morning. So my name is John Gilmore. I'm the executive director of the Autism Network. We're a national 501c4 organization that works on autism, developmental disabilities, and medical freedom issues. I'm also the father of a son, Luke, who is a 26-year-old man diagnosed with autism. His symptoms fit the criteria for a level 3 designation. Luke progressed several times as an infant. At 2 months, he stopped nursing, developed sensory defensiveness. He did not want to be held or touched, and developed asthma and eczema over most of his body. At 1 year, he regressed again. He lost mama, the one word he had acquired at that point, and developed a range of autism symptoms, including appearance of being deaf, staring for prolonged periods, of moving objects like ceiling fans, using his peripheral vision to look at things, flapping, among other symptoms. Both Luke's regressions followed within days of multiple rounds of vaccines. He was diagnosed with PDD-NOS at approximately 18 months. Luke still has full body dyspraxia, severe gastrointestinal issues that need constant monitoring, and OCDs that can control much of his and our family's life. Luke is non-speaking, but fortunately in the past several years, he has learned to communicate effectively using letterboards and keyboards. And, prior to Luke's regression, my wife and I had no experience of autism. However, during college, my wife worked summers at a day camp for people with developmental disabilities. Almost all the campers in the 1980s had Down syndrome, and she does not recall anyone who she would consider as having autism. Today, the same camp, which is blocks from our home, serves a population overwhelmingly composed of people with autism and only a few people with Down syndrome. When Luke regressed, we did not officially know the causes of autism. We had no treatments, no known prevention, and no cure. And the first round of ADDM numbers had just come out, which was 1 in 150 8-year-olds. But they were not sure at that time if the increase was real. Today, 26 years later, nearly 20 years after the Combating Autism Act was first passed, we still don't know officially the causes of autism. We have no treatments, no known preventions, no cures. The latest ADM numbers say 1 in 31 8-year-olds have autism, which apparently is 1 out of 12 boys in California. But we still haven't done the work to say definitively if the numbers have gone up. So we basically have not produced anything new of use to Luke or people with autism in families, as far as I'm concerned. And none of the fundamental questions we had about autism 25 years old have been answered. And I think this law of progress in public is basically a public health and human catastrophe. During Luke's lifetime, autism has been redefined 3 times. His original PDD-NOS diagnosis was scrapped, along with Asperger's. Right now, the label autism includes people with symptoms far worse than Luke's, including seizures, self-injury, elopement, lack of bowel control, and many others. But also includes highly articulate people with no visible disability who have successful academic and professional careers, spouses and children, people who need no care from others really to have full productive lives. The extremes are so wide that today autism is nearly a meaningless label. My hope is going forward, we will be able to identify biological markers for the varieties of autism, identify the causes of autism, do the epidemiology necessary to understand the scope of the autism epidemic, develop effective treatments, develop effective cures, and prevention as well. And I hope we can get started with that as soon as possible. Thank you.
Thank you. Crystal Higgins. Hello, my name is Crystal Higgins, and I'm the Executive Director of the National Autism Association. I was a teacher at a pediatric hospital before leaving to care for my oldest daughter, who was born with a severe TBI and complex medical issues. And it was autism parents I met while teaching who guided us to her most effective treatment. It's clear there are many urgent issues in our community that demand attention. Today, I ask that we confront one of the most critical, one that's a matter of life and death, and one where the data give us a clear path to prevention, the wandering and elopement crisis. Despite how common this risk is and how well documented the fatality profile has become, the response by federal and state authorities has remained inadequate. The consequences are devastating. We're losing an average of 8 individuals a month, and that is likely an underestimate. Children with autism face significantly higher risk of injury and death than their neurotypical peers. To members of the media covering today's meeting, please report on this deadly crisis as you would any other preventable pediatric cause of death. Other causes with less fatalities have triggered coordinated federal campaigns, national messaging, surveillance, and policy reform. These children deserve the same urgency. We have effective ways to reduce these tragedies and support families living in survival mode 24 hours a day, and I plan to present on this later today. If you have met the autism parents I have, they are like no other parents I know. Awake through the night, engineering safety solutions, advocating tirelessly, carrying fears few could comprehend, yet loving with extraordinary depth. There is no greater devotion. These families are not unaccepting of their children. They're fighting for basic human rights, effective communication, meaningful peer relationships, the ability to contribute to society, equitable and non-discriminatory access to effective healthcare, education, and safety. We must align our priorities by triaging the most critical needs. They're tough issues, and they deserve immediate action. Thank you. I'm grateful to be here with all of you.
Thank you. Daniel Keeling. Here. My name is Daniel Keeling. I am a high school senior. I was nonverbal until 2nd grade. My early years involved intense therapies and medical support as doctors worked to diagnose and treat my complex medical conditions. Over time, we identified and addressed cerebral folate deficiency, mitochondrial dysfunction, and abnormal immune system activation. These treatments, along with the discovery of an underlying genetic condition affecting my mitochondria, allowed me to improve significantly. My journey highlights the complexity of autism and shows why science must move beyond simple genetic explanations to embrace a multidisciplinary approach. Most importantly, we need greater investment in medical research and treatments so children can recover before losing precious time. I'm truly grateful to be part of this Interagency Autism Committee and hopeful that my voice and experience can help make a meaningful difference in the lives of individuals with autism. Another area I urge the committee to focus on is providing better support and accommodations for autistic individuals in hot and healthcare settings. Sensory sensitivities can make standard hospital environments overwhelming. Bright lights, loud noises, unfamiliar textures often heighten anxiety and discomfort. Pain perception can also differ. What might feel mild to others may feel amplified to me due to sensory processing differences. Simple accommodations, such as allowing the use of noise-canceling headphones, a mobile device, my service dog, a trusted support person, quiet spaces, or adapted pain management protocols can make a tremendous difference. These changes would reduce barriers, lower stress, and lead to better health outcomes for many autistic people. I appreciate the opportunity to share my perspective as a young autistic adult and look forward to the committee's continued efforts to provide meaningful research, better healthcare access, and supports that empower us to thrive.
Thank you. Hayden Larson.
My name is Caden Larson. and I found many types to communicate. Before I was able to communicate, I was trapped in silence until I was 20 years old. Learning to spell changed everything for me. It gave me a voice, the opportunity to express what I believed in, what I wanted to do. Ultimately, spelling saved my life when I had an infection without a fever during chemotherapy. If I hadn't been able to tell my doctors that I was in pain, I would have died. Because spelling has been such a revolution in my life. One of my primary areas of focus is expanding access to spelling-based communication skills for all non-speakers and ensuring it is taken seriously, researched rigorously, and made widely available. I also want to emphasize the importance of appropriate therapies and support services for all people with autism, making sure they are matched to the needs of the individual, which can vary widely in autism. Interventions like ABA and occupational therapy were helpful for me, especially in developing the motor planning and regulation skills that make communication possible. We need more research that looks at how different kinds of therapy work for different types of people with autism and why. A second important area of focus for me is safety. Too many autistic individuals are dying from wandering. These are almost always preventable deaths, and we still do not fully acknowledge the scale of the problem. I support the development of alert systems, but I also believe we must go further upstream to prevent these tragedies altogether and to spread awareness of the problem through active surveillance. Third, I am deeply interested in medical research. Many of the medical problems I experienced were dismissed or incorrectly attributed to autism. I had frequent stomach pain that got a lot better with diet and special treatments. A lot of people with autism experience unnecessary pain and discomfort, and doctors dismiss their problems saying that's just autism. Autism should not be used to overshadow or minimize real medical conditions that require proper diagnosis and treatment. Finally, I want to address something directly. We cannot continue denying that autism rates have increased to a sad level. Autism is a tsunami, and it represents a growing public health challenge that demands urgency, honesty, and action. We need to figure out the causes and stop the tsunami. Thank you for listening, and I look forward to participating on IACC and to contributing to the good work of this great group.
Thank you. Elena Monarch?
Hi, I'm Elena Monarch. I'm the founder of the Lyman Pans Treatment Center. I've been working as a neuropsychologist and health psychologist for 30 years. For the last 2 decades, I've been studying and treating patients with neuroimmune conditions, such as PANS and PANDAS, many of whom carry autism diagnoses. Like regressive autism, PANS and PANDAS involves sudden changes in a child's neuropsychiatric status, with behavioral regression, extreme anxiety, often in the form of obsessions and compulsions, vocal and motor tics, and sensory problems. PANS and PANDAS can easily be misdiagnosed as a psychiatric condition, but in reality, the child's regression is due to being overburdened with infectious and non-infectious sources of inflammation in conjunction with a leak in their protective blood-brain barriers, allowing immune responses to reach the brain. Despite the severity of regression, when children with PANS and PANDAS are diagnosed properly and the underlying drivers of their brain inflammation are treated, many can recover, and oftentimes their recoveries are dramatic. There's evidence that many individuals with autism show signs of neuroinflammation. In fact, in one postmortem study of autistic individuals of all ages, 2/3 of their brains showed significant markers of neuroinflammation. These types of studies should compel us not to assume, but to investigate. How far back did their neuroinflammation begin? Was there a trigger, an immunological or nervous system event? Regressive autism is a signal, a meaningful clinical signal that demands investigation. When an infant or toddler suddenly regresses, we should have all hands on deck to understand why this happened. Reading through the public comments for our committee meeting today, it was clear that parents would like us to cast a wider net as we look into what predisposes, triggers, and exacerbates profound autism and regressive autism. In line with the public comments, I would like to see a paradigm shift in how we conceptualize regressive and profound autism. The diagnosis should not explain anything away. For example, early and periodic screenings of children with autism should take pain behaviors very seriously. Pain behaviors such as crying and self-harm do not come along with autism. Expressions of pain are physiological clues and cries for help. It has been my clinical experience that investigating pain behaviors and understanding sources of neuroinflammation leads to surprising answers, solutions, and decreased suffering.
Thank you. Elizabeth Mumford.
I am a board certified pediatrician with 45 years of experience. That includes 5 years as medical director of the Autism Research Institute and many years as both a Medical Academy of Pediatrics and Special Needs faculty and board member. I have spent the last 25 years of my career treating children with autism and complex chronic illness. My priorities include a recognition that we actually see autisms with an S. So I want to recognize that we need to support and nurture the spellers like Kate and Elizabeth, as well as taking care of the people that have profound autism. My second priority is to emphasize that people with autism often have significant medical problems with the gut, the immune system, neuroinflammation, mitochondrial defects, metabolics, and detox. And we need to make this more mainstream because pediatricians do not know how to identify the triggers, the antecedents, and the mediators of these problems. So my passion is for medical education, and through this committee, I hope that we can find ways for us to reach the pediatricians that are going to be at the front line and to help them screen for and identify the medical problems, as opposed to just screening for autism and then referring for behavioral therapies. Thank you.
Thank you. Bill Oldham.
Good morning. Thank you. It's a pleasure to join this committee, and thank you for the opportunity to be of service.
Bill, we
Can you hear?
okay.
Can you hear me now? Sorry.
Yes. Thank you.
First of all, thank you for the opportunity to be here. Thank you for the opportunity to serve with this committee. I've had a 30-year career in healthcare and technology as both an entrepreneur and an investor. More importantly, I am the father of 3 boys, 2 of whom are non-speaking and have profound autism with mitochondrial disease. My boys, Gareth and Corlin, are now 21 and 19 and have benefited greatly from medical treatment and ABA, and are rapidly becoming proficient with their letterboards and keyboarding skills to allow them to share their voice with us. In our community, I've been proud to lead the TLI Foundation, which has launched a program called the Autism Knowledge Gateway, sharing thousands of peer-reviewed journal articles to help enhance the quality of information available to both physicians and families for the research that is there. My focus, I'm also happy to serve, by the way, as the board chair for the Autism Community in Action, just helped many families over the years. I'm focused in the area of profound autism. I would love to see us explore better data science projects, defining the phenotypes, allowing for better differentiation between subgroups and diagnostic clusters. I'd like for us to engage data and trial design to collaborate better with pharma to bring more solutions to the families that desperately need them. I'd also like to continue to explore work that allows us to grow our clinician base to improve access to care. I'd also like to focus on what my family is facing now as well, which is lifespan challenges for families to develop solutions to improve the quality of life for both the autistic adult as well as their family and caregivers. I'd also like to specifically thank the members of the public who submitted comments. All 540 pages of those were meaningful and they deserve our attention, and I'm proud to have the opportunity to serve and help our community. Thank you.
Thank you. Jennifer Phillips?
Hi. I would first like to express my deepest gratitude to President Trump and Secretary Kennedy for being such steadfast champions for our children. Thank you. My name is Jennifer Phillips, and I'm the founder of Make a Stand for Autism and the mother of a daughter profoundly affected by regressive autism. On makeastandforautism.org, you can find a full video testimony of that experience. I would like to suggest consideration and diagnostic dysfunction for the segment of the autism population that experiences neurodevelopmental regression. Described in research as a documented loss of skills following a period of typical development, experienced as the loss of your child as you knew them, who will require care for the rest of their life. This was our daughter's experience after falling ill with a common childhood infection at the age of 2. This group represents 30 to 40% of individuals with autism and may carry distinct medical profiles with real implications for prevention, diagnosis, and treatment. Today, we are going to discuss the term profound autism. It has been repeatedly shown that children who suffer a neurodevelopmental regression are more profoundly affected and have worse long-term outcomes than those who do not. In all my years of advocacy, the mention of neurodevelopmental regression has always elicited the largest and most passionate responses from the community. The outcry from these families who have witnessed the disappearance of their children as they knew them is absolutely heartbreaking. Today, I give those families a voice. The Autism Cares Act calls for investigation into causes, including possible environmental causes, prevention, and early detection. This cohort, precisely because there is a distinct before and after, may represent one of the most actionable biological research opportunities available to this committee. Hear this well. We cannot continue to explain away autism regression as autism progression any longer.
Thank you. Honey Renasella.
Thank you. I'm so honored to be here today. I am here as the mother of 25-year-old twin sons with autism, as an autism advocate, and as the executive director of the Medical Academy of Pediatrics and Special Needs. I've spent the last 2 decades in advocating for this community, and my sons alongside that community have taught me that autism is not just behavior. It's a complex whole body medical condition involving neurological, immune, metabolic, and systematic factors, and for many can become life-threatening when those needs are ignored. My voice today is dedicated to 3 areas. First, we need real medical standard of care for autism across the lifespan, infancy through adulthood. Every child and young adult with autism deserves a full medical review of systems, not diagnostic overshadowing. We continue to hear from families who describe clear medical changes, regressions, or loss of skills, and they're never fully investigated, and instead are met with a behavioral diagnosis without comprehensive medical evaluation. This is fixable, and we already have training models that demonstrate how to do this well. Comprehensive system-based care that looks beyond behavior and addresses underlying medical needs. Families have been left to coordinate this fragmented system on their own, and that is not sustainable, nor is it acceptable. My one son's life-threatening seizures have been completely eradicated by the keen eyes of a trained physician. He is now 15 years seizure-free. He is a Make-A-Wish recipient. 15 years. The level of training should be baseline expectation, including programs like MAPS Foundations, which equips clinicians like mine to recognize and then address complex medical needs. Second, the communication access must be treated as a civil right and a safety issue. For non-speaking and minimally speaking individuals, access to their communication method must follow them everywhere, community settings, hospitals, procedures, schools, emergencies, and all through their adult services. Without communication, there's no consent, no acute care, no autonomy, and no protection. Third, we need accountability for outcomes across the lifespan. Children with autism become adults with autism. Families age, and the most medically complex individuals cannot continue to be left behind because systems stop paying attention. This is not about starting from scratch. It's about enforcing what already exists and closing the gaps where systems, particularly for adults, are still incomplete or absent. So the system can then deliver the level of care, safety, and dignity that individuals with autism and their families have always deserved.
Thank you. John Rodakis?
Greetings to my fellow public and federal members and those watching by video. My name is John Rodakis. For the past 12 years, I've run the N of One Autism Research Foundation to identify and fund potential breakthroughs in ASD at many of the country's and world's top institutions. I'm also father to one of the purest souls I've ever met. Every day inspires me to be a better person and to find breakthroughs for him and the millions of other children like him. I have a degree in molecular biology and spent much of my career in medical venture capital. I'd like to share two priorities I hope we can explore further in later meetings. First, I'd like to advocate for a significant broadening of NIH's biomedical research efforts in ASD beyond genetics. While genetics can be very important in ASD, the vast majority of individuals, some estimates as high as 80%, have no identifiable genetic anomaly. This despite the fact that we now have over 1,000 potential autism risk genes. At this point, the evidence is overwhelming. There is more at work than simply genetics. But the vast majority of research funding, both public and private, remains concentrated there. I would like to ask for a deliberate, meaningful, and measurable effort to broaden NIH's research agenda into other high potential domains, such as the immune system, the microbiome, and mitochondrial cell metabolism. This isn't about replacing genetics, but I believe that by broadening our lens, we will discover breakthroughs applicable to the other 80%. A second priority likely falls to the purview of the FDA. At present, there is not a single approved treatment for the core symptoms of autism. I believe part of this failure comes from how we approach clinical trials, but it's fixable. Conventional clinical trials work well in homogeneous populations, but are poorly suited to the highly heterogeneous conditions like autism. Some may say it's a failure of the treatments themselves, but time and again in autism clinical trials, we see a familiar pattern where a subset of patients show a strong, meaningful response to a treatment. However, because that response isn't broad enough across the group, the trial fails to achieve statistical significance. As a result, promising treatments, often with favorable safety profiles, never reach the patients who could benefit from them. I believe this is solvable. We've seen the FDA address similar challenges in other heterogeneous conditions, including cancer, through more adaptive and flexible trial designs. My hope is that we can convene a working group with the FDA to explore trial design that can better account for autism's heterogeneity to help bring safe and effective treatments to patients who will respond to them. Thank you.
Thank you. Daniel Rosenthal?
Thank you. My name is Dan Rosenthal. I would like to thank Senator Kennedy, Secretary Kennedy, for inviting me to serve in this committee. I'm excited to be on the IACC and to contribute to its work. I'm a board certified family physician, currently in private practice with over 30 years of clinical experience. During my medical school and residency training, I saw only a handful of patients with autism. The rate of autism diagnosis is clearly much lower then than it is now, and autism was not a major focus of my medical training. I now live and practice in California, where the latest CDC data shows autism prevalence of about 1 in 13 boys, approximately 8%, underscoring how dramatically the landscape has changed since my medical training. People can debate how much of the change reflects a true increase in autism, changes in diagnosis, or increased recognition. But from a clinical and public health standpoint, one thing is clear. No matter how we look at the data, there are many individuals with autism who need thoughtful, evidence-based care and support. My connection to autism is both professional and deeply personal. Both my children were diagnosed with autism, the first in 2002. That experience changed the direction of my career. Looking back, I believe God gave me future with autism to lead me down this road. In the beginning, we were told our children might never speak. Today, they speak in sentences. My children are now 22 and 25 years old. My youngest is in his third year of college, and my oldest is graduating from high school and is one of the sweetest people you ever meet. Autism is classified as a neurodevelopmental condition in psychiatry, but in clinical practice, many individuals with autism have significant co-occurring medical conditions, also called comorbidities. These medical issues can affect sleep, seizures, gastrointestinal function, metabolism, inflammation, immune function, behavior, communication, and quality of life. For that reason, I believe autism care must include careful attention to the medical conditions that may be present alongside the core features of autism. I have seen how easily medical problems can be missed in individuals with autism. In my practice, I've cared for 3 children whose the appendicitis was initially mistaken for constipation. In the emergency setting, they were sent home, and each later developed a ruptured appendix. One nearly died and remained hospitalized for a whole month. Experiences like these are reinforced to me that communication differences, atypical pain presentations, and diagnostic overshadowing can have serious, even life-threatening medical condition consequences. I was trained in evidence-based medicine, so my passion is reviewing and synthesizing the medical literature, especially through systematic reviews and meta-analysis. In that work, we sometimes review hundreds of papers and synthesize the findings into a single document. I've authored approximately 80 publications on autism, with that first one occurring in 2006. Over the past 23 years, I've cared for about 8,000 kids with autism in my clinical practice. I also served as the president of the Medical Academy of Pediatrics with Special Needs for about 10 years, which is an organization that's focused on training physicians in evidence-based medical evaluation and treatment of children and individuals with autism and neurodevelopmental disorders. So my current clinical and research interests include function and co-occurring medical conditions, also called comorbidities, such as mitochondrial dysfunction, folate metabolism, folate deficiency, seizures, sleep problems, inflammation, gastrointestinal problems, and others. So in my practice, I've seen meaningful improvements in children's and families' quality of life when these medical conditions are identified and treated. One of the most important things I've learned is that many of these medical conditions, especially autism, are identifiable and treatable, and addressing them can meaningfully improve function and quality of life. When we treat these medical problems, we often improve not only the child's daily functioning, but also the entire family's burden, hope, and quality of life. This matters not only clinically, but economically. Published U.S. estimates suggest that the lifetime cost of supporting individual autism is approximately $1.4 million without intellectual disability and $2.4 million with intellectual disability, with major cost drivers including special education services and parental productivity loss. If medical treatments can improve these underlying comorbidities, then the cost savings and caregiver work loss and education support, there could be meaningful savings for families and society. I'm currently involved in several clinical trials in clinical autism.
Sorry to interrupt.
Yeah, I'll finish. So my hope is that autism research and policy will continue to move beyond behavior alone and more fully address the medical conditions that affect many individual autism across the lifespan. Thank you.
Thank you. Next, we have Tracy Slepcovic. Sorry,
Slepcovic.
Thank you.
Thank you. Hello and good morning. My name is Tracy Slepcovic, and I am the proud mother of a 20-year-old son with autism. At the age of 1, my son regressed into a state of autism, not knowing what was going on. And I was told that my son would need care for the rest of his life, and he would not lead a fully functional life. I feel like I'm one of the blessed ones, and I'm one of the lucky families, because with biomedical intervention, my son was able to recover and live a full life. As to where he works, he drives, and he travels the world, and he is not fully disabled. But I am one of the lucky ones. And with that, my son gave me purpose. I am the founder of the Autism Health Summit and Autism Health, which is a 501c3 nonprofit organization dedicated to advancing research, education, and access to care for individuals with autism. I'm a certified integrative health practitioner, an Air Force veteran, and the best-selling author of Warrior Mom, A Mother's Journey in Healing Her Son with Autism. I'm educated in the field of alternative medicine, and I have spent over 17 years researching treatments and therapies to address underlying medical conditions associated with autism and other neurological conditions, which very much benefited my son. A top priority for me is advocating for more comprehensive model of care, one that acknowledges medical needs for individuals with autism and ensures families have access to appropriate care and advanced treatments and therapies covered by insurance. Lastly, I truly feel that we must take a deeper look into the increasing prevalence of autism, particularly cases associated with regression. Families, including my own, are asking important questions regarding environmental factors that may be affecting early childhood development. If we are truly committed to progress, we must be willing to explore these areas with scientific rigor, transparency, and an open mind. Focus not only on support, but also on understanding and prevention. I am honored to be a part of this committee. I'm grateful to Secretary Kennedy for all his hard work, and I look forward to working together with all of you to create meaningful change. Thank you.
Thank you. Katie Sweeney.
Good morning, and thank you to Secretary Kennedy for the honor to serve. My name is Katie Sweeney. I work for the Medical Academy of Pediatrics and Special Needs. I work with the Autism Action Network, and I'm a board member of CoLab, a theater group serving the developmentally disabled population. But I am also a proud mother of my son, Dustin, 28, who has profound autism, stage 3 Lyme disease, is a non-speaker speller, and will require 24/7 care for the rest of his life. For 27 years, my son was presumed to be cognitively impaired. He was not. He was unreachable. He spent 18 years in ABA, speech therapy, special ed, and nothing gave him a reliable way to communicate. As Dustin has since told us, quote, "The time before talking was hell. I was treated like I was cognitively impaired all my life," unquote. Through spelling, Dustin found a way to express himself. What emerged was not impairment, but intelligence. The mind was always there. It was trapped by apraxia, a brain-body disconnect that prevents the body from doing what the mind intends. So let me be very clear. He did not have 27 years of cognitive implementation. He had 27 years of system failure. That brings me to my 3 priorities. First, we must formally and recognize and prioritize those with profound autism and apply a systems-based root cause approach to diagnosis and treatment. The autism diagnosis is based on observed behaviors, not biology, and has become so broad it groups completely different realities. Yet those most severely affected are still approached primarily through behavior. This is not just incomplete, it is harmful. For many, this is a complex whole body medical condition involving neuroinflammation, immune dysfunction, metabolic and mitochondrial disorders, and gastrointestinal pathologies, seizures, and more. If we define autism by behavior alone, we will miss what is driving it and continue managing symptoms instead of addressing root cause. Second, we must enforce communication rights. Communication is a human right, yet for non-speakers, access to effective communication methods like spelling and typing is often denied, not by lack of lived success, but by institutional resistance. When you deny someone a means to communicate, you are not just limiting expression, you are erasing identity, autonomy, and potential. And third, we must confront the reality of adulthood. With autism, much attention and emphasis is on kids, as that's when it typically presents. I say often, they are kids for 20 years and adults for 60 plus more. That is what keeps us parents up at night. Who is going to take care of them, support their needs, safeguard their health, protect them from abuse when we have left this earthly sphere? Individuals like my son who cannot advocate for themselves in traditional ways are among the most vulnerable members of our society. Without meaningful change, vulnerability becomes inevitability. This is not abstract. This is not rare. These are urgent, real-world issues that demand alignment between policy, research, and lived experience, and a willingness and openness to rethink the systems we have built. Thank you.
Thank you. Ginger Taylor.
Hello, I am the mother of a 24-year-old young man who was diagnosed with autism at age 3. who regressed shortly after his 18-month-old child visit. Autism mommy is not for the weak of heart. We threw ourselves into his recovery quickly, and his is a success story. We addressed many things that we're going to be talking about today, his inflammation, his gut issues, and we saw dramatic changes in him even within the first year. So I say we got him halfway back. So I'm very excited for this committee to start looking at the amazing successes like spelling, like medical interventions that we have for kids. I'm also concerned with maternal health. We are unfortunately, largely a group of women who have recovered a lot of kids at a lot of expense, both financially and this includes, autism moms and dads and grandparents. Are my parents and my husband's parents carry considerable financial burden for his recovery. And this needs to end. This is something that parents need to have the resources to take on these challenges. In my own case, we have mothers who are, their children are just coming of age, but we've already lost a lot of mothers to heart attacks, strokes, and cancers. So, and I am in that group that I had a stroke 2 years ago, and so I asked the committee's indulgence. My basal ganglia was damaged in the process, and so I cry a lot. Very embarrassing. And if I lose control of myself, please ignore it, and I will try to rein that in as soon as possible. But there's a lot of sad things we're talking about. And so I hope that I speak for the voice of the mothers who have been doing everything possible to recover their kids, both the tragedies and success stories. And the idea that we're here, we went through his injury, recovering him quickly and realizing how we lost a house, how expensive it is, how there isn't any help, how you have to fight with the doctors to get them to understand gut issues. And this is in 2004. By the end of the year, I met John Gilmore online, and he said, "Hey, we're going to do a passing federal legislation. Come on, let's get going." And we passed the 2006 Combating Autism Act that created this committee, and then watched for 10 years for this committee to ignore the things that we created to do. So I'm excited to be here. I am excited to be with some of the people that have been, some of the doctors who have been so instrumental in helping us recover our son, the advocates who have, broadened new horizons, and the spellers who teach me. So I collectively, I speak for my friends and say, we hope that the government members of this committee will join us with the passion that we've had to serve these kids who are now adults. And right now, in 1978, I guess, Bernie Roman published the first vitamin B study on vitamin B for autism treatment. And in 1983, he published the first diet study on the Feingold diet improvements in autism. And today, the American Academy of Pediatrics has its clinical guidance for autism treatment and pediatric care that reads, many interventions, including many nutritional interventions, do not have evidence to support their use at this time. The idea that, we knew something when I was 9 years old. The pediatricians have not been given that tool. It doesn't serve the patients, and it doesn't serve our pediatricians who want to help the children from them. And this committee has.
I'm sorry to interrupt you. Can you wrap up?
I'm done.
Okay, thank you. Next we have Lisa Wiederlight.
Good morning. My name is Lisa Wiederlight. I want to take this opportunity to share my appreciation for this extraordinary opportunity to make measurable, significant, and positive change for the autism community. It means more than you can know. Thank you. I'm a single parent of a 25-year-old young man who regressed into autism at 13 months. He has so many co-occurring conditions that his last individualized educational plan had multiple disabilities as his primary disability. In addition, he suffers from inflammatory bowel disease. When I was studying public policy in graduate school, I could never have imagined how useful this education and background could be. As my son's proud mother, I have been advocating on behalf of the autism community for translational research, appropriate public policy, innovative and necessary programs and greater accountability for over 20 years. This would include a focus on those for people with autism, their caregivers, and service providers. I run an organization that is focused on creating integrated community living opportunities in which people with developmental disabilities, veterans, and older adults will have access to appropriate housing solutions and supportive amenities that will allow them to thrive. The creation and support of housing for those with autism is an urgent need. In fact, it is nothing less than homelessness prevention. Already, research is showing that people with autism comprise a significant percentage of the homeless population. This is a crisis situation and must be actively addressed as soon as possible across the nation. In my prior work, I helped to co-found the Autism Safety Coalition. Now I am involved in the Maryland Autism Coalition, a public-private partnership which also focuses on safety. As someone who worked diligently to help pass Kevin and Avante's law, which provides federal funds for preventing and addressing wandering in children with developmental disabilities, I know that it is critical we must continue to address public safety for our community. Finally, as a Marylander who is extremely concerned about the implementation of Medicaid waivers in our state, when I'm told, actually, our state is not alone in changing waiver implementations in destabilizing ways in the United States, I'm recognizing a contrast between the rights conferred by the Americans with Disabilities Act and the Olmstead decision, which must be addressed. People with developmental disabilities and their family caregivers are losing the support they desperately need to stay safe, fully access the community, and maintain financial stability. So we must identify what is causing these issues to occur and persist and to solve the problems. I'm looking forward to participating actively in the IACC to make a significant difference in the lives of people with autism and those who love them. Thank you.
Thank you. Walter Zaharodny.
Good morning. I'm Walter Zaharodny. I'm a psychologist, a clinical psychologist at the Rutgers, New Jersey Medical School. I provided care and support to families with autistic children and children with other complex developmental needs for over 30 years. And for 25 years, I've been the director of the New Jersey Autism Study, which is the New Jersey iteration of the CDC ATOM network. I have 3 priorities that I bring to this important committee. 1, identification and addressing of the drivers of the 3-decade-long surge in autism prevalence that we've observed. 2, promotion of early detection and diagnosis of children with autism. And 3, establishing a process for providing lifespan medical needs for the population disabled by autism. Thank you very much.
Thank you. And that concludes the introductions of our public members. I want to thank you so much for sharing information about the experience that you bring to this committee, as well as your knowledge and clear commitment and passion. Megan.
Excuse me, add my thanks to Jennifer for great, really inspiring stories. Now we'll go through the federal community, the federal members. If you can say your name, your title, your agency, a brief description of how your agency mission overlaps with autism relevant activities. And if you'd like to bring any personal experiences to the table, you're welcome to do that as well. Again, I ask you to keep your comments to 1 to 2 minutes. And we'll start with Jennifer Haight.
Hi, everybody. My name is Jennifer Haight. I am representing ACF, the Administration for Children and Families, and I am the Deputy Associate Commissioner over the Children's Bureau, which is one of many operating divisions at ACF that support and work with child and family serving systems. Those systems receive federal funding and are subject to federal regulation, monitoring, and oversight. We at ACF are very intentional about building knowledge about specific and vulnerable subpopulations, such as people with autism, who, so that we can better support their health, their safety, and their well-being, so they have every opportunity to thrive in the ways that many folks at this meeting have demonstrated are possible and have demonstrated that there is still a lot of work to do. I'm very grateful to be part of this group and at this working meeting so that I can build my knowledge and focus on the kinds of actions that will support the kinds of improvements that are necessary and can be actualized through the work at ACS. So thank you.
Thank you. Rebecca Hines?
Good morning. I'm Rebecca Hines. I'm here representing the Administration on Community Living. I'm the Commissioner of the Administration on Disabilities. At the Administration on Community Living, our work revolves around providing opportunities and services for adults with IDD. And specifically, I think our largest, and my colleague Jennifer can correct me if I'm wrong, but is the focus on independent living. So we work across the country, helping to ensure that people have access to services that provide the most independence possible. And my background is actually as a college professor in the field of special education. So it's been interesting to transition into a role where the focus is on making sure that people have the opportunity to go from school to successful independent living. But as someone who has lived in this world for 40 years on the disability side, I very clearly understand the challenges. And my earliest experiences in education were working with students with significant support needs, many of whom were on the autism spectrum with severe and profound needs. So I share that because I think that all of us bring some level of personal experience or predisposition towards topics that we'll hear about from many lenses now. I've seen opportunities, but I deeply recognize the barriers because there are people with a level of need that the general public cannot recognize unless they have been immersed in a setting that included those individuals. So I thank you to our members who are here representing families and to my colleagues at the federal level.
Thank you. Christina Chacon?
Good morning, everyone. I want to thank President Trump and Secretary Kennedy on their autism initiative and priorities. My name is Christina Chacon. I'm the Senior Advisor over at the Agency for Healthcare Research and Quality, also known as AHRQ. AHRQ's mission is to enhance the quality, appropriateness, and effectiveness of health services and access to such services through the establishment of a broad base of scientific research and through the promotion of improvements in clinical and health system and practices, including the prevention of diseases and other health conditions. Prior to joining the federal service, I worked in the healthcare sector for just under 4 years. I have served on many volunteer organizations with individuals with autism, as well as having family members with autism. I look forward to being part of your committee and all the work that we will do together. Thank you.
Thank you. Matthew Maynard?
Good morning. I'm Matt Maynard. I'm with the Center for Disease Control and Prevention and a very recent addition to this group. I'm the Chief of the Child Development and Disability Branch at the National Center on Birth Defects and Developmental Disabilities, which is where CDC's autism activities are located. CDC has 3 public health autism programs. The Autism and Developmental Disabilities Monitoring Network, or ADAM network, generates population-based data on autism prevalence, characteristics, and timely identification in communities around the country. There is also the Study to Explore Early Development, or SEED, which began as a research study of young children with autism, other developmental disabilities, and typically developing children, largely to look at risk factors for autism. Those participants are now followed as adolescents and young adults in order to understand what happens when they grow up, what they need, and what can be done to help. The third program is Learn Signs Act Early, which aims to improve early identification of developmental delays and disabilities, including autism, by facilitating developmental monitoring and screening so children and their families can get the services and support they need as soon as possible. I appreciate the opportunity to participate in this committee. My first experience with autism was 25 years ago when I was in college. I worked with children with autism. Often they had very, very challenging behaviors and minimal language, and working with their families in their homes, at schools, and in the community has had an enormous influence on me and my career since then. And so I look forward to meeting everybody and working together. Thank you.
Thank you. Caprice Snap.
Morning. Thank you so much for having me. My name is Caprice Knapp. I'm the principal deputy at CNCS, which is the Center for Medicaid and CHIP Services. I'm here with my colleagues, Kirsten Jensen and Charlotte Mango, and we appreciate this opportunity. Thank you also to the Secretary, to Administrator Oz and Commissioner Hines for including us in this important conversation. As you all know, we represent 70 million Americans who are enrolled in either Medicaid or CHIP. And our center covers everything from eligibility to benefits, to financing, to managed care, et cetera. And I'm sure you all have experience with your state and how your state has interacted with us. We also administer 1915 HCVS waivers, 1115 demonstrations, and we oversee state plan amendments for states. In a prior role, I was the Medicaid director in North Dakota, where we oversaw autism waivered services, and we had a state-only fund for autism for services that were not covered by Medicaid. We also had an autism registry, and we worked to start a 1915I waiver to provide even broader services. We appreciate the opportunity to come today and learn from you all, and thank you so much, Diana, for including us.
Thank you. Nicole Williams.
Hi, my name is Nicole Williams. I'm representing the Department of War through our Autism Research Program, which is one of 34 now for FY26 peer-reviewed programs that are directed by Congress. So we started back in 2007. So we've been around for quite a while. As I mentioned, we fund peer-reviewed autism research. As of late, our focus has really been on research directed at access to services across the lifespan, transition to adulthood, co-occurring conditions, and then more recently kind of focusing efforts on mental health issues in the autistic community, as well as providing support, I should say research that supports quality of life for current and former military members, as well as adults with perhaps physical, mental, and other quality of life issues. So I'm happy to be back again this year. It's been a great learning experience, and I look forward to working with everyone.
Thank you. Deidre Essay.
Good morning, everyone. My name is Deirdre Essay, and I'm a policy advisor with the Office of Justice Programs of the Department of Justice. In that role, I oversee a number of grant programs that include the Collaborative Crisis Response Intervention Training Program, which prioritizes education and de-escalation for law enforcement officers responding to people with intellectual and developmental disabilities, and other law enforcement responses to people with behavioral health challenges. My office also oversees the Covenant Bond grants. And prior to joining the Office of Justice Programs, I worked as a clinician, including mobile crisis response, skill building, muscular work, and outpatient substance use treatment.
Thank you. Scott Robertson.
Good morning. My name is Dr. Scott Michael Robertson. I'm an autistic person with other significant disabilities, and I'm a senior policy advisor in the U.S. Department of Labor's Office of Disability Employment Policy, or ODEP for short. Thank you, NIH leadership, for coordinating this IACC meeting, and also to our federal partners. ODIP's agency mission is to develop and influence policies and practices that increase the number and quality of employment opportunities for people with disabilities, all disabilities, including people on the autism spectrum like myself and many others. We envision a world in which people with disabilities have unlimited employment opportunities. ODIP runs our research support services for employment of young adults on the Autism Spectrum Project, or the RAES project for short, in collaboration with our federal contractor, Mathematica. Funded since FY 2021, this $2.9 million multi-year project for autistic people aged 16 to 28 originally began after requests by Senate and House appropriations. The RAES project's ongoing survey of youth and young adults on the autism spectrum integrates an emphasis on ensuring participation by varied people on the autism spectrum. It includes autistic people who experience complex communication and verbal language challenges and secondary conditions. ODIP's Job Accommodation Network, or JAN for short, one of our technical assistance centers, also has an extensive webpage on workplace supports and accommodation for people on the autism spectrum in its online A to Z library. I look forward to continuing to collaborate and partner with all of y'all, and I'm very excited to be here. And we so enjoy cross-agency work and the work of all the wonderful public members who are here as well, and the staff. And I'm so glad to contribute and look forward to the rest of this meeting and continuing meetings with the IACC and the great work we can accomplish to help improve the quality of life and health and wellness of all people on the autism spectrum. Thank you.
Thank you. Christy Kavalik.
Hi, I'm Christy Kavlik, representing the U.S. Department of Education. I am within the Office of Special Education and Rehabilitative Services. I serve as the Director of the Research to Practice Division within the Office of Special Education Programs. OSEP administers the Individuals with Disabilities Education Act, or IDEA, which provides grants to states to provide early intervention and special education services for children with disabilities and their families. We also fund national activities to support the implementation of IDEA and the use of evidence-based practices. OSERS also has the Rehabilitation Services Administration, which supports vocational rehabilitation, employment, and independent living. I look forward to participating on the IAC.
Thank you. Elaine Cohen-Hubble. We can't hear you. I think you might be on mute.
We're unable to hear you. Want to move to the next person, and I'll get in touch with you later.
Sure. Yes. Luke Hall.
Yeah, good morning. Luke Hall, coming to you from the United States Food and Drug Administration. I'm looking forward to being here together and learning from you all. I'm a senior advisor in the Office of the Commissioner. We focus on a lot of enterprising work. If you don't know anything about the FDA, our goal is to protect and promote public health across a gamut of commodity groups. We regulate drugs, biologics, we regulate devices, as well as some products like tobacco and veterinary medicine and products as well, which is probably of lesser importance today. But looking forward to come together. Two goals I'll share with you: current administration priorities with Secretary Kennedy's leadership, as well as Commissioner McCary, would be one, food as medicine, restoring the F back in Food and Drug Administration. You might have heard of some of the work going on in the last couple of years, or in the last year, on food dyes. This is particularly important, I think, in this group and with this setting, on the note of food as medicine, as we learn more about exposomics, as we learn more about epigenetics, as well as the microbiome and the determinants of health outcomes that are intrinsic in some of those, and how we can best regulate it as the regulator of nearly a quarter of every dollar in the United States economy. Secondly, patient-focused drug development program. We want to make sure that we're accelerating cures, but accelerating meaningful cures for the patient populations that drug program developers will put into the pipeline. This is really important for us. And we recognize that for conditions like autism spectrum disorder, there is a lot of heterogeneity of patient population. So working together with federal partners, this is super key. Some of our NIH colleagues here, we appreciate that work together, working with researchers, working with clinicians and physicians, but especially working with patients to make sure that the endpoints that we're looking at our clinical trials, the way that we're designing our clinical trials together with partners, as well as the surrogate endpoints and the biomarkers, and as we validate them and as we qualify them, we're doing so with the functional status, the biological process, but especially the patient voice throughout the process. So we need your help. We can't do this in a vacuum with the FDA, and we're excited to learn together and to grow together and to really share and investigate together. So looking forward to working together.
Great, thank you. Do we have Dr. Cohen-Hubble? Yes. Okay, we'll move on. Margaret Bush.
Morning. Thank you for the opportunity to participate. I also just want to say thank you to the advocates and families for sharing their personal stories. My name is Margaret Bush. I'm the Deputy Administrator at the Health Resources and Services Administration, or HRSA. Our mission is to improve access to health care for people who are geographically isolated and those who are economically or medically vulnerable. Within that mission, our autism and other developmental disabilities portfolio focuses on improving care and outcomes for children, adolescents, and young adults. We do this by strengthening the workforce, advancing research, and supporting states in delivering high-quality care, particularly as youth transition to adult services. A major part of our work is training through programs like the Leadership Education in Neurodevelopmental and Other Related Disabilities, or LEN, and our Developmental Behavioral Pediatrics program. We prepare providers to better screen, diagnose, and care for children with autism and other developmental disabilities. We also invest in research to improve services and support. Our work focuses on early identification, developing reliable screening tools, and advancing interventions that support physical and behavioral health and communication. On a more personal note, before coming into this role, I practiced as a nurse for 12 years, and I cared for patients with autism and developmental disabilities and saw firsthand the challenges individuals and families face. Thanks again for the opportunity to be here today. I look forward to the discussion.
Great, thank you. Do we have Dr. Cohen-Hubble? Still can't hear you. Sorry.
Not yet.
We'll move.
I'll pop in.
Oh.
No, this is Amy with support. I'm trying to get in touch with Dr. Hubble. If you could check your email, please. Thank you.
Okay, thank you. Leah Lozier.
Hi, good morning. I'm Leah Lozier. I'm here representing the U.S. Department of Housing and Urban Development, or HUD. I work in their Office of Policy Development and Research. HUD has been a member of the IACC since, I believe, 2019. I have served on the previous iteration of the committee, and I'm looking forward to the work of the new committee. In terms of why is housing here, HUD offers a number of programs, not specific for people with autism, but a number of housing programs for people with disabilities. So I'm looking forward to the work of the committee. Thank you.
Thank you. Marcella Ronyak.
Good morning. Thank you very much. I was hoping my audio was working. My name is Marcella Ronyak. I am in dual roles right now. I am the Deputy Director at the Office of Clinical Performance and Health Impact, and I'm also the Acting Director within the Office of Clinical and Preventative Services at the Indian Health Service. I was on the IACC committee as the IHS representative in previous years, and I'm acting as an alternate to Dr. Hartley from Indian Health Service. Excuse me. I am also a member of the Palo Confederated Tribes in Washington State and a very proud mom, autistic savant. My son is 16 years old and is a senior at the University of Arizona working on a pre-med track, wanting to be an oncologist. So I come to this committee both as a federal employee and also as a proud parent of someone with autism. We honestly have quite the story with my son that I've been able to share with the committee from both perspectives. As a federal employee, looking at how we can strengthen our collaborative efforts. I also started the Interagency Autism Coordinating Committee with Indian Health Service back in 2018. So with that, I to this committee as an honor to also represent IHS, where our mission is to raise the physical, mental, social, and spiritual health of American Indian Alaska Natives. We do provide care to about 2.9 million American Indian Alaska Natives, and we are the 18th largest healthcare system in the nation. Most people don't know that. We're a little secret service behind healthcare that provides services to all of our stakeholders. Our vision is to have a health system that embraces traditional knowledge and practices that can foster living and thriving communities for 7 generations. We have 4 strategic goals, which is 1 is being a leading healthcare organization. 2 is to ensure comprehensive, culturally respected healthcare services. 3 is to optionalize operations through effective stewardship. And finally, 4, to promote proactive intergovernmental and external partnerships. I do have to say it is such an honor to be a part of the IACC committee. And I can say that my son was one who went and testified in front of Congress to ensure that the Autism Cares Act was re-signed in 2020. So thank you so much, and I look forward to continuing to work with the committee.
Thank you. Matt Numley?
I think for the most part, I gave my introduction. Just for a little more background on me, I am a infectious disease physician and internist, and I've been a microbiologist working here for over 20 years.
Great, thank you. Rohan Hazra?
Good morning, everyone. I'm Rohan Hazra. I'm currently in the role as the acting director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development, which is the Child Health Institute, one of 27 institutes and centers here at NIH. I'm a pediatric infectious disease physician by training and have spent actually longer than that, more than 25 years here at NIH. I've been in this current role for just 2 months. So today, in fact, I just realized today is 2 months since I became the acting director. Prior to that, I was the scientific extramural division director at ICHD. And so I just wanted to walk through some of the programs that we have that are very, very relevant to the autistic community and the research portfolio. So first of all, research on intellectual and developmental disabilities was part of our core legislation that Secretary Kennedy actually signed in 1962 to establish the Child Health Institute. So it has been a part of our core mission right from the beginning, right from when we were founded. Our mission is to lead research and training to understand human development, improve reproductive health, enhance the lives of children and adolescents, and optimize abilities for all. And some of our research, we have 2 of our largest branches are our Child Development and Behavior branch and our Intellectual and Developmental Disability branch. And so there we have a lot of work going on typical and atypical development. The Intellectual and Developmental Disabilities branch with 4 other institutes and centers leads the Autism Centers of Excellence program that's been in place since I think 2007. But there are 2 other branches I'd want to also highlight. One is that we know that premature birth increases the risk of autism. And so we have a very large portfolio of research on prematurity in our pregnancy and perinatology branch. And then finally, very relevant to, I think, a number of different discussions today, we have a major focus in our pediatric trauma and critical illness branch on injury prevention. And one of that branch's priorities is drowning prevention. And we actually have a highlighted topic currently on drowning prevention. And so really have research that touches on multiple areas across the intellectual and developmental disability program, in addition to having a specific branch in that area. On a personal note, I have a cousin's son who I've watched from birth. And we actually, my wife and I are both pediatricians, we had suspicions that he had autism much before he actually was finally diagnosed. So he was unfortunately quite late diagnosed, but then has really inspired us with how he's grown. He's now in his late 20s and living in a group home, but able to care for himself and engage in lots of different hobbies. And he's also very musically talented. So just a really inspiration. And I look forward to working with all of you.
Great, thank you. I think we have Elaine Cohen-Hubble back on now. Elaine, can you try to speak?
No, we still can't hear her. Let me have her
Okay.
dial in.
Okay, great. Deborah Tucci?
Yeah, good morning, everyone. I'm Deborah Tucci. I'm director of the National Institute on Deafness and Other Communication Disorders. And the portion of our research portfolio that relates most to autism is our work in disordered language development and communication. And so we've been very involved in that aspect of this committee. And I look forward to working with all of you, especially in that area. We'll also be joined later by NIDCD's Deputy Director, Dr. Judith Cooper. She is a speech language pathologist by training, so she's been involved with this committee for many years. Thank you.
Thank you. Courtney Wimberly?
Hey, everyone. Hopefully you can hear me.
We can.
Good morning. Thank you. I'm Courtney Wimberly. I'm a health program specialist in the Office of the Director at the National Institute of Environmental Health Sciences in IEHS, part of the NIH. And I'm pleased to serve as the alternate representative today for NIEHS Director Kyle Walsh. At NIEHS, I support the director's interdisciplinary research portfolio and help advance program planning, project execution, and alignment with scientific and public priorities. NIEHS is focused on understanding how environmental exposures influence human health and disease, including factors that affect child health, development, and neurodevelopment. And that work is highly relevant to autism research, particularly as we seek to better understand how environmental and biological factors may shape developmental outcomes and contribute to health across the lifespan. My background includes neuroepidemiology research, regulatory coordination, data analysis, and research dissemination. And in this work, I'm especially mindful that research and policy are most meaningful when they reflect the real experiences of individuals and families and remain responsive to needs across the lifespan. I'm grateful for the opportunity to be a part of this meeting and the work that you are all doing, and I look forward to contributing to the insightful discussions that help advance research and improve outcomes for people with autism and their families. Thank you all.
Thank you. Andrea Beckle-Michner?
Thanks very much for the opportunity to be here. I am currently the acting director for the National Institute of Mental Health, as well as the deputy director of the NIH Brain Initiative. So representing the agency, I'd like to tell you a little bit about the research that we support, basically 3 areas at NIMH. We explore fundamental brain mechanisms and processes at the cellular and circuit level. We also have a large portfolio in what we call translational research, which further explores and expands the knowledge base to better understand people with autism and develop safe and effective treatments. And finally, we have a large investment in science that improves services and services delivery for people with autism. It is a pleasure to be here. It's a privilege to serve alongside all of you, and I look forward to our partnership.
Thank you. Amy Adams?
Thank you so much. It's a privilege to be here today, and I really appreciated all of the advocates and sharing their very personal stories. Very emotionally moving, so thank you for your candor. So I serve as the acting director of the National Institute of Neurological Disorders and Stroke. Our mission is to understand the brain and the nervous system and to use that knowledge to improve neurological health for all people. With respect to autism research, our focus includes studies that focus on the brain and nervous system. For example, research on the genetic, molecular, cellular, and circuit level mechanisms. For example, excitatory and inhibitory processes that shape the nervous system development and function in autism. We also focus on translational and clinical work to improve the diagnosis and treatment of neurologically relevant features of autism. This includes work on sensory and sensorimotor aspects of autism, pain experience and mechanisms, which I've heard from many of you today, an association of autism with co-occurring neurodevelopmental and neurological conditions across the lifespan. And I really appreciate the opportunity to contribute to the discussions today and to learn from all of you. Thank you.
Thank you. Rick Lambert.
Thanks for the opportunity to be here, and I want to thank the many speakers for the inspiring and moving words, and especially for your vulnerability. Thank you. So I'm a physician. I work at Samson as a senior advisor there. I have almost 40 years of clinical experience, most of it as an ER doc. I'm also trained in acupuncture, so I do appreciate alternative approaches. And most recently became certified in psychedelic assisted therapy and research, which is my main area of focus at SAMHSA. I'm sure most of you are aware of the executive order regarding psychedelics that Secretary Kennedy and President Trump shared on national TV about 10 days ago. I believe these medicines will eventually be transformative in the field of behavioral health, and I also believe they can have several different applications to autism. I approach this work with the understanding that autism is a form of neurodiversity and that individuals on the spectrum have a wide range of strengths, needs, and lived experiences. At the same time, many autistic individuals face significant barriers, as discussed, particularly in accessing appropriate, respectful, and effective mental health and substance use services. SAMHSA's role is to help ensure that behavioral health systems are accessible, person-centered, and responsive across the lifespan. That includes advancing trauma-informed care, strengthening community-based supports, and improving crisis response systems like 988 so they work well for neurodiverse individuals. For example, there are resources on our website through the National Child Traumatic Stress Network on how youth with intellectual and developmental disabilities experience traumatic stress and how parents and caregivers can support them. I'm here to listen, bring a behavioral health and systems perspective to the community's work. I look forward to working together to improve quality of life, access to care, and outcomes for autistic individuals, their families, and communities. Thank you.
Thank you. Allison Marvin.
Good morning. I should check to see that you can hear me after the previous.
We can. Thank you.
Thank you. Okay, I'm Alison Marvin, and I'm honored to represent the Social Security Administration. The Social Security Administration is an administrative agency that delivers Social Security services and provides support to individuals, including those on the autism spectrum and their families, throughout their life journey. But I'm the branch chief of AI and advanced analytics. My predictive modeling and advanced analytics teams extensively support SSI operations, customer visibility and quality reviews. My AI team is actively working to improve the 800 number and interactive voice response experience. I'm a statistician and health sciences researcher by training, and before joining the Social Security Administration, I was the research manager of the IAN project, the Interactive Autism Network at the Kennedy Krieger Institute. And if some of you remember that, it's at one point the largest online mediated autism registry and research program. And that experience gave me the opportunity to connect with individuals on the autism spectrum and their families. I also was affiliated with the Wendy Clagg Center for Autism and Developmental Disabilities at the Johns Hopkins Bloomberg School of Public Health. I'm grateful for the opportunity I had with these groups that I was able to publish extensively in the field of autism research. I look forward to continuing to represent Social Security on this important committee. Thank you.
Thank you. Clifford Smith. Do we have Dr. Elaine Cohen-Hubble back? No? Okay. I'm not supposed to be breaking until 11.
Can
so
you
we'll
hear
take a
me
break.
now?
Oh, yes, we can. Yay.
Okay, I could not apologize more. Elaine Cohen-Hubble with EPA's Office of Applied Science and Environmental Solutions. EPA's mission is, of course, to protect human health and the environment, and it is current agency policy to protect children from environmental exposure by consistently and explicitly considering early life exposure and potential lifelong health impacts in all of the human health decisions. So these exposures and impacts would do include effects of environmental exposure during early life, beginning with parental reproductive health, continuing through infancy, early childhood, adolescence, and through to adulthood. In implementing this policy, EPA works with our federal partners to identify, evaluate, and use in our decision-making information on environmental factors, including those related to autism. This is, I think, my third round on this committee. I'm incredibly energized hearing the public members' priorities and bias to action. I'm also really, I think EPA is going to really be able to take advantage of information that's being developed through the application of exosomic methodologies. And we heard early in the meeting that there is new and significant funding being put specifically on exosome and autism. So look forward to serving and continuing to just really learn about this community. Oh, and I, like everybody, have dear family members, young adults, all of them at this stage who are part of the autistic community. Thank you. Thank you for your patience.
Thank you, and thank you for persisting and joining us. Thank you to all the federal members and all of the public members for your comments. We are going to have a 10-minute break. We're running a tiny bit behind. I just want to remind you, please don't discuss any committee business during the break. That all needs to be in the public forum. So we'll see you back at 11:10. Thank you.
The comments that we received reflected a broad range of perspectives on research, services, and policy. And in order to assist with the discussion today, our office, the Office of National Autism Coordination, or ONAC, conducted an analysis of themes in the public comments to inform the committee discussion. The results of that analysis, or the methods used for that analysis, 15 themes were developed. Each comment was coded to a maximum of 3 themes, allowing for identification of recurring themes, quantification of topic frequency, and representation of multi-topic comments. A full summary of the analysis and theme definitions is available in the first few pages of the public comment packet that's posted online and that all of the members received by email. So these are the themes that were represented. Sorry, it's a little hard to see in the room, but the most frequently represented themes included etiology and causation, mental health, behavioral supports and safety, individuals with high support needs or profound autism, services access and system barriers, adult services, housing and long-term care, and caregiver impact, economic strain, and family supports. So again, if you look at the public comment packet, you can see all of the categories that were developed and the number of comments coded to each of those. So in summary, the public comments received for this meeting addressed a wide range of topics across the 15 themes. Many of the comments reflected multiple overlapping issues, and commenters provided feedback on research priorities and services needs, highlighting gaps, concerns, and areas of emphasis to inform IACC discussion. So thank you to all of you who submitted written comments. And now I believe we'll hear from the oral commenters.
Yes. We are now going to hear from 13 commenters who are going to provide oral public statements. We're going to begin with those who are joining us virtually, and then we will turn to those in the room who will provide comments in person. For those that are providing public comments, we thank you for providing your comments to us today and being here. And we thank you in advance for keeping your remarks within the allotted time, which is 3 minutes. So we will begin first with Stephen Hillenjansik.
Thank you so much for allowing me to meet with you guys today. So as she said, my name is Stephen Hillenjansik. I am an autism dad. I also want to say thank you to my mentors, Dr. Giannucci, Dr. Adams, Christina Flynn, Peter Lloyd Thomas, to my beautiful wife and family who encouraged me to talk to you guys today. Secondly, I also want to mention that I don't own any Genentech stock, which is important. I have one very simple request, and that is to have the allergy food med Xolair / omalizumab added to the Trump RX website. And so why do you ask that, Stephen? Well, what if there was a drug that would help stop elopement? So you wouldn't be finding kids drowning in a pond or running away and getting hit in the street. What if there was a drug that could help a child with profound autism sleep throughout the night? I don't know. I just have a personal experience. I have 2 autistic sons, one with profound autism, the other one with mild autism. They both have folate receptor autoantibodies, both blocking and binding for you, Dr. Rosenell. They have high levels of microbial metabolites. They have a primed immune system from maternal immune activation, which definitely needs a rebrand because we don't need to be attacking our mothers in regard to autism. Furthermore, they also had a clear genetic full sequencing genome, no autistic genes showed on either of those tests. So our autism journey has started with Xolair for over 2 years now. With that, we have seen increased cognition, increased language, decreased elopement, decreased sleep jagging. My sons are both potty trained and no longer require diapers. And when I mention this, I'm talking about profound autism. I'm not talking about the autism where I can talk to you like you. One of my profound sons, Stephen, is nonverbal, but because of Xolair, he was able to follow directions. Both of them, actually, my younger son Leo is able to go to a private school because of it. My younger son Leo can read a book now because of Zola. Furthermore, they're also very proficient swimmers, and I also attribute that to their understanding and their cognition has increased because of the Zola. So I just want other parents to be able to experience the same joy that I've experienced. To have your child to be able to say, I love you is amazing. Furthermore, it's not based off of total IgE, and I need to underscore that. So usually when you are prescribing Xolair, you need to have a total IgE of 40 or above. My son IgE, Leo, is 11.
Thank you.
Is 11. So another food for thought. In
Mr.
Canada,
Jantic, we're going to have to ask you to wrap up your comments. Thanks.
no problem. Sorry. Long story short, in Canada, Xolair is $450. In America, it's $5,000. So that's why I need it on Trump RF. Thank you.
Sean Blymiller.
Thank you for the opportunity to speak. Dear members of the IACC and autism parents around the world, my name is Sean Blymiller. I'm a father to a 10-year-old non-speaking boy with profound autism named Theo. I'm also a functional medicine coach trained by the Functional Medicine Coaching Academy and the founder of the Pure Living Family Foundation, a 501c3 nonprofit supporting families of kids with autism, pandas, PANS, and epilepsy. I'm a parent who has spent 7 years in the trenches, trying, learning, failing, and finding what works for my son and for our family. I want to share what we've learned and make 3 specific requests of this committee. I would like to call this the Theo Protocol. First, nutrition is foundational. Real organic whole foods matter enormously for children on the spectrum. But for many kids, this is not simple. Theo wouldn't allow food near him. His entire system was rejecting the very things that could help him. The intervention that changed this was a fecal microbiota transplant. I want to acknowledge Dr. James Adams, an autism father and researcher doing remarkable work in this area at Arizona State University. After FMT, Theo's diet expanded dramatically. He now eats almost anything we give him. The microbiome, it turns out, controls our cravings. When you heal the gut, the child can begin to receive the nourishment. Second, even after gut intervention, Theo's autoimmune neuroinflammation remained. Like many children on the spectrum who carries other comorbidities and co-infections that standard protocols do not adequately address. We have pursued a series of stem cell and exosome treatments that show genuine promise. But the cost is a lot and the access is extremely limited, and most families cannot reach these treatments without leaving the country. I have 3 requests to this committee. 1, fund microbiome and gut-brain research for autism. The connection between microbiome and autism outcomes is not fringe science. It is emerging science that deserves serious federal research investment. Families like mine are already using these interventions. The research needs to catch up. 2, create a pathway for families to access stem cell and exosome therapies domestically. I'm not asking this committee to endorse unproven treatments. I'm asking for research funding and grant pathway that allows families who understand the risks and have exhausted standard options to access these treatments safely. 3, recognize spelling to communicate as a legitimate form of communication. My son is non-speaking. He has a mind, thoughts, and things to say. The current clinical standards that govern which communication methods receive recognition and reimbursement are leaving non-speaking individuals without a voice, literally. I'm genuinely excited for the parents that make up this board. Thank you for hearing me, and let's teach our country about systems biology. Thank you.
Sorry, I get distracted by the comments and engrossed in the comments being made. Next, we have Caroline Rogers.
My name is Caroline Rogers. I am a peer-reviewed author who has spent 2 decades investigating what may be causing autism. Today, I am focusing on reduced synaptic pruning, a disruption in normal brain development found in many people with autism, which leads to an overabundance of the neuronal connections that have very high energy needs. While this is a common biological finding, we still do not understand why pruning is reduced or how this relates to autistic outcomes. Several biological pathways that reduce pruning are already under investigation. Each can contribute to excess synapses, and each has been associated with autism. But what remains unclear are the upstream factors that create these conditions. In my article, Mitochondrial Dynamics in Regressive Autism and the Surprising Link to Genius, I outline a conceptual framework that connects synaptic overabundance, mitochondrial capacity, and developmental outcomes. The model proposes that autism arises when the developing brain retains an overabundance of synapses. In some children, where mitochondrial capacity is insufficient, this imbalance can lead to regression. In others, robust capacity may support exceptional abilities. The common denominator is the balance between synaptic load and available energetic resources. This perspective may also clarify why sensory features are so prominent. If complex higher order circuits, such as those required for verbal and social engagement, are paused or shut down, newly available energy may shift toward a lower level sensory pathways. These circuits then become highly active, creating a feedback loop in which active circuits are protected from pruning. This may help explain why sensory hypersensitivity is common among people on the spectrum. I encourage the committee to highlight research that examines the upstream factors that shape pruning during early development, and to consider how synaptic load and energetic capacity interact to produce the diverse developmental trajectories seen across the autism spectrum, including regression, exceptional abilities, and everything in between. Thank you.
Thank you. Candace Edwards.
We can't hear you, Candace.
Thank you for the opportunity to provide public comment today. My name is Candace Edwards, and I'm from Massachusetts and the parent of an 11-year-old child with autism. I want to bring attention to an issue too often overlooked in autism discussions: the use of seclusion and restraint in schools serving children with developmental disabilities. My son was repeatedly subjected to inappropriate and traumatizing restraint and seclusion. I was never told, and I was left completely in the dark watching my child crumble before my eyes until one day he found the words, "Help me." To this day, he lives with the trauma, a PTSD diagnosis, disrupted education, and ongoing mental health needs, and we are not alone. Federal civil rights data shows that while students with disabilities make up about 15% of enrollment, they account for roughly 80% of restraints and 77% of seclusions, and the numbers are even higher in many states. This disproportion demands immediate federal attention. In healthcare and law enforcement, restraint and seclusion are governed by clear federal standards. In schools, however, protections vary greatly by state, leaving children, educators, and families at risk. I respectfully urge the committee to recommend the following federal actions. First, require same-day parent notification whenever restraint, seclusion, or significant removal occurs, especially for children who cannot communicate what happened. Second, improve timely and consistent national data collection. Current reporting is delayed and often misses safe rooms, informal isolation, and repeated removals. Third, establish a uniform federal definition of seclusion and restraint, as proposed in the Keeping All Students Safe Act. Without standard definition, the exact same practice can be officially reported in one state, but completely hidden in another. Fourth, require an automatic IEP or 504 review if a student is removed multiple times in a month. Repeated removals show that current supports are failing and need to be reevaluated. Fifth, fund evidence-based alternatives that reduce reliance on restraint and seclusion, including proactive, trauma-informed, neuroscience-based, and neurodiversity affirming approaches. Prevention is far more effective than repeated crisis response. And sixth, strengthen enforcement and accountability so civil rights complaints are resolved in a timely manner rather than taking years.
Federal law already provides authority through the IDEA, Section 504, and the ADA. What's missing is consistent implementation. The Keeping All Schools Safe Act would help close that gap and establish consistent nationwide protections. Every child deserves to learn without fear and trauma. Parents deserve transparency, and educators deserve better tools and support. Thank you for your time.
Thank you. Aaron Siri?
Morning. This committee has existed for 26 years, and under its leadership, autism has risen precipitously. I'm hoping the longstanding members of this committee in particular can hear what I'm about to say. The National Childhood Vaccine Injury Act of 1986 explicitly provided, quote, the Secretary of HHS will complete a review of all relevant medical and scientific information on the nature, circumstances, and extent of the relationship, if any, between vaccines containing pertussis and the following illnesses and conditions. And it listed only 11 of them, one of them being autism. In 1991, the IOM conducted that review, and it said it couldn't find any studies with regards to pertussis and pertussis vaccines and autism. Fast forward to 2009, the CDC and HRSA again commissioned the IOM to again review all the medical literature with regards to pertussis vaccines and autism. And the IOM again came back and said it could not find a single study that supported that vaccine does not cause autism. It found one study that did find an association between pertussis vaccine and autism, but it threw it out because, quote, it lacked an unvaccinated comparison population, end quote. In 2014, AHRQ again conducted the same review, considered the most comprehensive review as of that time on vaccine safety according to HHS. It again cannot find a single study whether DPAP does not cause autism. It also looked at Hep B vaccines and autism, and again could only find one study, and that study found a 3 times risk of autism amongst those that got Hep B in the first month of life versus those that didn't. That's out of the University of Stony Brook. In 2017, I interacted with Joshua Gordon, the former head of this committee for a long time. Again, asked him, could you provide the studies that show that the vaccines given in the first year of life, 6 months of life, 5 of them do not cause autism? He never provided me a single study. In 2019, we sued the CDC on behalf of a nonprofit, ICAN, for the studies that support that the vaccines given in the first 6 months of life, DTaP, Hep B, HIV, IPV, and PCV, 3 times each do not cause autism. They were not able to provide a single study. You can read the stipulated order for yourself on ICAN's website. That is why today, finally, the CDC's website correctly states, quote, pursuant to the Data Quality Act, which requires federal agencies to ensure the quality, objectivity, utility, and integrity of information is disseminated to the public. This webpage has been updated because the statement, vaccines do not cause autism, is not an evidence-based claim. Scientific studies have not ruled out the possibility that infant vaccines contribute to the development of autism. However, this statement has historically been disseminated by the CDC and other federal health agencies within HHS to prevent vaccine hesitancy. Approximately 1 in 2 surveyed parents of autistic children believe vaccines played a role in their child's autism, often pointing to the vaccines that the children received in the first 6 months of life, the 5 I just mentioned earlier. That reality stands.
Mr. Siri, we need to ask you to wrap up your comment.
Okay. We shouldn't ignore the parents' complaints. We shouldn't ignore the epi studies, and we shouldn't ignore the biological basis for the connection. Thank you.
Thank you. We're now going to hear from individuals who are here in person to provide their public comment. And first we have Kaylee Cooper. You can go to the front podium.
Thank you for the opportunity to speak to this committee. My name is Kaylee, the Government Relations Lead for Concerned Citizens of Self-Direction in Maryland. I am also a parent of teenage twins that were born 3 months early. Both of them have had developmental disabilities since birth, and both have been diagnosed on the autism spectrum. One is now on a 1915 waiver where I work as his caregiver. I'd like to highlight a simple but critical truth. Parents and family caregivers should be recognized as a foundational model of care for both minor children with disabilities and adults with autism and disabilities nationwide. According to 2025 Caregiving in the U.S. report by AARP and the National Alliance for Caregiving, roughly 1 in 4 American adults is a family caregiver. 59 million caregivers are caring for adults ages 18 and older, and 4 million of us are caring for a child under 18. Family caregivers play a critical role in supporting relatives with autism and other disabilities across the lifespan of the individual. Parents and family caregivers provide the most consistent, safest, and most individualized care possible. This is especially true for children with autism and complex medical or behavioral needs. Familiarity, trust, and continuous observation can mean the difference between stability and crisis. No system, no matter how well designed, can replicate the depth of knowledge that a parent has about their child or a family has for their loved one. The Supreme Court established in Olmstead versus LC that individuals with disabilities have the right to receive services in the most integrated setting appropriate to their needs. I agree, and I would argue that the most integrated setting isn't just about location, it's about relationship. A child with autism being cared for by a parent through intense meltdowns that include spitting, biting, punching, kicking, and more. A parent who knows their child's nonverbal cues, their triggers, and their medical history. That child is receiving care in the most integrated, far less restrictive environment than the same child being cared for by a stranger from a home health agency. When states like Maryland cut family caregiver wages or caps their hours, it doesn't just destabilize the individuals and their families. It pushes individuals with disabilities away from their most natural and most integrated support system. This is the opposite of what Olmstead intended. Removing or limiting that continuity of care can introduce trauma, regression, and unnecessary risk. Parents and family caregivers are often the ones already filling in the gaps, and most times they're doing it without financial reimbursement. Allowing parents and family caregivers to act as paid staff in place of strangers prevents crisis situations that too often can lead to emergency interventions or institutionalization. This approach doesn't just benefit the individual or their family, it strengthens it.
Cooper, please wrap up your comments.
As you consider policy and priorities, I urge this committee to recommend federal standards that protect family caregivers as the foundational care model. Thank you.
Thank you. Next, we have Anthony Tucci.
Good morning. It's my distinct pleasure to offer these comments this morning. My name is Anthony Tucci, and I am the proud father of a 22-year-old son who has profound autism and is minimally verbal. We live in New York City. My brief comments will offer two distinct different stories about communication science involving non-speakers and minimally verbal individuals with autism. One is a story of science at its best, and the other story is a story of science and its greatest discontents. Communication science is one of the most powerful tools we have to improve the lives of individuals with autism, especially those that are minimally verbal. It offers a way to understand, support, and help expand human expression. At its best, communication science aligns with communication rights. It affirms that every individual has the right to express themselves and to have their preferences and choices respected. These principles are embedded in the American and Disabilities Act, the United Nations Conventions of the Rights of Persons with Disabilities, and the ethical foundations of clinical practice. But we must also confront some hard truths. One, complex communication challenges are difficult to study and require a multidisciplinary research that is still evolving. Research in this area is slow and significant gaps remain. Non-speaking autistic individuals remain unrepresented in research and in policy. There is progress and it matters. The NIDCD is advancing research priorities for minimally verbal and non-speaking individuals focused on improving communication outcomes and engaging families in settings of research. The Autism Cares Act of 2024 strengthens this effort by supporting evidence-based practices and expanding access to communication tools and interventions. But let's now turn to the other story. A story that does not reflect science at its best, but instead a clear expression of science and its greatest discontents. This is a form of unbounded and misguided scientific advocacy. It resists and acknowledging limits of knowledge and existing research gaps. It seeks to delegitimize communication preferences and choices of non-speaking individuals. It seeks to reinterpret established communication rights and frameworks. The question is not whether we trust communication science, it is whether we apply it as it was intended, with humility and with respect for communication rights. In closing, I respectfully ask the ICC to create a subcommittee and to conduct workshops to strengthen federal research and policy, ensuring both expanded and higher quality communication research, and to address the risks identified in the second story. This is essential to ensure communication science remains what it is at best, a force for human progress, grounded in evidence and guided by communication rights. Thank you.
Thank you. Cody Stevens?
All right, thank you for having me. After a 3-hour drive, I was ready to get this done. All right, so my name is Cody Stevens. I'm a father of a 10-year-old with developmental disorders. I'm also an uncle to a nephew with autism. I'm a family caregiver and an advocate representing thousands of families in Maryland with intellectual and developmental disabilities. I'm also a co-leader of the Concerned Citizens of Self-Direction Maryland and the executive director of the Anchor Initiative, a nonprofit created on the Eastern Shore of Maryland specifically to help support families with disabilities going through crisis. What's happening in Maryland is not just a state issue, as you guys know. It's a warning sign for the rest of the country and a real example of how quickly community-based systems can shift in ways that create unintended and far-reaching consequences. I join you representing over 4,000 families supporting individuals with intellectual and developmental disabilities, including many with autism. These individuals rely on self-directed Medicaid services to live safely, meaningfully, and with dignity in the least restrictive, most integrated settings possible. Self-direction is a model that puts individuals and families in control, allowing them to choose caregivers and direct care with a set budget. For many with complex needs, this is what ensures the stability of care environments and long-term outcomes. At the center of this system is family caregivers. They are not a backup plan. They are the foundation of this care and critical, often underrecognized by the broader care workforce and care economy. Right now, this foundation is being dismantled in our state. Recent policy changes in Maryland have resulted in wage reductions to 30% or more for family caregivers, despite performing the same duties as non-family professionals who continue to get paid a larger amount. At the same time, families are also capped at 60 hours per week per household, where it used to be 80, taking 20 hours away each week. The message is clear. Do the same work for less pay with less time. The consequences are already unfolding as real-time system impacts are taking place, and whispers of waste, fraud, and abuse are constant surrounding leadership running these programs. Families are being forced out of these programs. Providers are leaving, accelerating the workforce attrition and destabilization, and the system is shifting towards reliance on uncompensated care for informal workforce substitution. When family caregivers are pushed out, there is no safety net in Maryland. There are only outcomes such as increased emergency utilization, preventable hospitalizations, and higher rates of institutional placement, all of which represent a far greater downstream cost than the supports that are being reduced. For individuals who rely on routine and trust, the loss of a caregiver introduces clinical risk factors, including regression, behavioral crisis, and long-term decline. If services are reduced further or eliminated, the results will not be theoretical, they'll be immediate and they'll be life-threatening. Families will break, individuals will lose the care that keeps them safe, and the system will undermine the cost-effectiveness and long-term sustainability. This is not just about policy, it is about whether self-direction remains the model built on person-centered decision-making, equitable access, and true program identity. Because when individuals can no longer choose their caregivers and caregivers can't afford to provide this care, self-direction no longer exists. Maryland is...
Stevens, please wrap up your comment.
Yes, ma'am. In the end, we're asking you to pay attention to the gap between policy design and lived experience and how quickly that gap is growing. We ask you to look into the current crisis and consider federal oversight into this matter and to help us get the counseling support that we need, because what happens in Maryland will not be contained. It's already spreading. It can become a blueprint for either protecting lives or for putting them at risk. Thank you.
Thank you. Crystal Erickson.
Chair and members of the committee, my name is Crystal Erickson. I live in Washington, D.C. and come from the perspective of a sibling. My younger brother, Calvin, is 30 years old, nonverbal, with profound autism. He lives in Texas with our father and is still on the Medicaid waiver waitlist today. By the time our family understood the system and that the waiver waitlist often starts at application, they had already lost years of access. Our experience is not unique. I've spoken with other families and disability professionals and hear the same pattern. The benefits exist, but clear coordination and guidance do not. I want to focus especially on the transition to adulthood. Between ages 14 and 22, families face multiple changes at once. School services end. Supplemental security income is redetermined under adult criteria. Families make high-stakes decisions about long-term care and continuity. There is no standardized guidance on what to do or when. Families often learn the rules by luck, through word of mouth, or by missing them. I recommend 3 actions. First, fund benefits navigation models focused specifically on the transition to adulthood, not just employment. Measure their effectiveness through improvements in enrollment rates, time to access benefits, and total dollars and benefits access. Second, direct the Social Security Administration to conduct more targeted outreach on disabled adult child benefits. These benefits are among the highest value support available for adults, yet are widely underutilized by families across the United States. Many eligible families don't claim them because they don't know if they exist or find out too late. Third, direct the Department of Health and Human Services and the Administration for Community Living to publish standardized transition guidance at ages 12, 14, and 17. Adult planning should start as early as possible in a child's lifetime. This should cover, at bare minimum, SSI, disabled adult child benefits, ABLE accounts, and state Medicaid waivers. It should clearly state that waiver enrollment should happen as early as possible given many states' multi-year wait lists, and clarify that many adult benefits remain available regardless of prior family income. These are high leverage actions. They do not require new benefits, but only clearer guidance on how to access them and sequence what already exists. Thank you.
Thank you. And my apologies. I skipped over Stephen Bress.
It's next not to be ignored. So thank you. I would like to thank the entire committee for allowing me to speak. My name is Steve Bress. My son, Michael, is an almost 24-year-old with what's now being called profound autism. He regressed at about 18 months, like many others. And although he can speak, we often have to act as decoders for what he says and interpret for him what other people are saying to him. And sometimes if you want to talk about Mario Kart, you get the right the first time. So anyway, to get quick today, I have 3 items that have come up since the written that are often found in autism that can affect the uptake and release of the drugs. Yeah, just yesterday, my son had an ear operation, so it's kind of current. The support staff was wonderful, but they were a little concerned and confused as why it took him so long to wake up fully. My wife and I weren't really that confused or concerned because everybody in our family with the same genetics has the same profile when going under anesthesia. 6 hours later, he was perfectly able to move. It ended up well. He's doing well right now and being watched by, 2 members of my family. It's an important topic to address. There's very few parents even know to talk to their doctors about it. And in depending anesthesias, it can be a life or death thing. I had to download information for a dentist from the TACA website to teach her how not to harm my son. Then I changed dentists. Anyway, the next is continuity of care. As I've noticed, a lot of us are getting older. So the folks I've been going to conferences with forever have a little more on the gray hair side than they used to, and just a little bit old. We've been doing this for 22 years, so it works out the way. But he's always had a team of doctors and practitioners to help them with the underlying medical conditions associated with autism. Our concern is that if or when something happens to us, the state will substitute their experts for ours, and he will immediately have negative consequences. Excuse me. Since most doctors choose to be ignorant about the underlying medical issues with autism, and they could look at all the research that other doctors would look at, but they choose not to. It's extremely unlikely that they will continue with medicine, supplements, and other treatments that keep my child healthy and reasonably stable. One of the items he gets regularly is helps with his speech. If he doesn't get that for a week, he loses words.
Please wrap up your comments, Mr. Breck.
Okay. That covers that one, and I'll just name it out loud. The last is compounding for supplements and medicines due to food allergies. We can't always get things off the rack that are safe for him to have. Insurance does not pay for it. There are mechanisms that perhaps this committee could recommend that would allow that to happen. Thank you very much again for allowing me to speak.
Thank you. Next, we have Sarah Kiernan.
Hi, I am Sarah Kernian, founder of Inchstones and a mother of 2 children with profound non-speaking autism, Millie, who is 11, and Mac, who is 8. Inchstones is a platform that I built to document what institutions routinely minimize, the daily logistical truth of profound disability, the systemic decisions that intensify harm. I publish through Inchstones Substack and the Inchstones podcast, and the work is ongoing, the work is current, and the work is grounded in what families are living right now. Inchstones exists because families like mine have learned the very hard way that awareness is not the same as safety, access, or outcomes. My work is not theoretical, it is not retrospective, it is not sanitized. Through writing and recorded conversations with families in the trenches, I track repeating patterns that determine whether a child receives communication access, appropriate placement, meaningful education, and basic dignity, or whether they are denied services, warehoused, restrained, isolated, and pushed towards crisis. These are not rare exceptions. These are repeatable failure modes produced by predictable incentives, fractured accountability, and policies that assume families have infinite money, legal literacy, and emotional capacity. What this committee needs and what families across the country are asking this committee to receive is what is often most missing in formal hearings. Ground truth intelligence from families living the consequences now, a clear articulation from families where systems fail at execution, IEPs, eligibility, placement, communication supports, and safety, logically sound, actionable recommendations rooted in what actually happens in homes and schools, a perspective that cannot be replicated by institutional summaries or abstract language. The IACC's mandate is to improve outcomes for all autistic individuals, including those with the highest support needs. That mandate cannot be fulfilled without the voices of the families whose lives are shaped by these exact decisions every day. This committee does not need another overview. It needs truth with operational clarity, the kind that systems often avoid,
because it forces accountability. Thank you.
Thank you. So W. John Martin.
Upon realizing that autism is epidemic, it was important to discern whether there's an infectious component. Now, I've described in the written comments research on viruses causing chronic fatigue syndrome led directly to the culturing of the same type of viruses from the majority of well over 100 children with autism. Now, these viruses are atypical in that they do not normally cause inflammation, the hallmark of most infectious diseases. I refer to these viruses as being stealth adapted. The best studied stealth adapted viruses are derived from the cytomegaloviruses of the types of monkeys that were used to, the kidneys from the monkeys were used to make polio vaccines. These viruses have lost or changed the few parts that the cellular immune system normally recognizes. But they can also incorporate additional genetic sequences from cells and from bacteria. These viruses are now infecting many people and can produce symptoms, especially when the brain is involved. Now, the animal studies have shown that these viruses can pass the placenta and affect the developing brain. They can stay clinically insignificant until the child's brain is called upon to engage in more advanced functions, such as speaking and interpersonal interactions. Now, on a more encouraging note, also described in the handout that I provided, the stealth-adapted viruses can be suppressed by non-immunological means. They can be suppressed by an alternative cellular energy or ACE pathway. This is a form of which the body receives cellular energy different than from the calories in food. And there are various ways of enhancing this ACE pathway. What the IACC committee can do is request government virologists to review the information on stealth-adapted viruses and to help in patients, their parents, and other caregivers understand this alternative cellular energy pathway as a natural, non-inflammatory defense mechanism that can provide benefits to patients. Thank you.
Thank you. Last, we have Carla Harris.
Hello, and thank you for this opportunity to spotlight conditions that imitate autism. My goal is to convince you to take action to ensure these conditions that mimic autism are ruled out or confirmed before a diagnosis of autism is made. 7 key questions for ASD/autism research are outlined in the IACC's strategic plan for ASD. The first question is, how can we improve identification of autism? A review of recent publications show part of the answer must be by first ruling out or confirming conditions that imitate autism. A growing list of studies and reports shows there are more than 10 conditions that imitate autism. Many of them also show that the symptoms that were diagnosed as ASD are reversed when the conditions are properly treated. Examples of conditions that imitate autism include T. gondii infection, excess free glutamate, vitamin D deficiency, and lead and mercury toxicity. As support I offer, the CDC reports over 40 million people in the U.S. are infected with T. gondii from cats and foods. Most of us know ultra-processed foods are a primary source of excess free glutamate. Then, one study found the lower the vitamin D level, the more severe the core symptoms of ASD. Also, a study showed there was decline in the autistic symptoms with the decrease in the lead and mercury levels in blood. These treatable conditions do not cause autism because autism is lifelong. Their symptoms imitate autism, inflating autism diagnoses even faster than genetics, not to mention the impact on elementary school classrooms. So how can these conditions be detected before an autism diagnosis is made? I'm glad you asked. Recent studies and reports dictate ACEP pivoting. That is, pivoting from the current autism diagnosis protocol to an autism symptom evaluation protocol, ASEP. ACEP would include an evaluation for autism, but focus primarily on documenting dietary habits, infection status, nutritional levels, and environmental factors to rule out or confirm conditions that imitate autism. So what needs to be done? Restructure and broaden pediatrician guidelines for diagnosing autism around an autism symptom evaluation protocol. And most importantly, educate parents about conditions that imitate autism. Thank you very much.
Thank you. And that concludes our public comments. I again want to thank all of those that provided public comments and shared your perspective and recommendations to the committee. We are now going to have a committee discussion about the public comments and open it up for that discussion.
First, I just wanted to thank again everyone who made public comments, both here today and also submitting comments online. Your perspectives and contributions are invaluable, and we really appreciate the time, especially those of you supporting individuals with autism who are short on time. So thank you. I want to open up for committee discussion. I think we should focus on sort of what we heard today and also what was in the written comments. I think much of it resonates with some of the priorities and interests raised by the public members, but let's open it up for discussion.
Sorry, and just one logistics note, if you could, when you speak, if you can say your name so that our note takers are able to make sure that we attribute comments appropriately. So if you're in the room, you can raise your hand. If you're on Zoom, you can raise your Zoom hand and we'll open it up to comments.
Can we see the people on Zoom now on the screen?
Yes, we can try to get that pulled up, but I'll just note that Allison Marvin online has her hand up.
Why don't we start with Allison Marvin then?
Good morning. I'm Alison Marvin from the Social Security Administration. I just wanted to respond to one of the themes I noted in the public comments relating to the vitally important issue of the transition to adulthood. There were several comments noting that it was difficult to find information about disabled adult child DAC benefits, which are Social Security Disability Insurance, SSDI payments to adults with disabilities that began before age 22 based on a parent's Social Security record. In response to your comments, SSA is going to revise the ssa.gov/youth webpage of transition resources to add links to make it easier to learn about these DAC benefits. In the meantime, there are some resources relating to DAC benefits, including information on ssa.gov/family. So just look out for ssa.gov/youth for those transition resources, and it will be updated. I don't have a time frame yet, but that is on the list of things to get fixed up. I do also want to recommend that people apply for a My Social Security account, and you can receive personalized information about any application, status of any applications, estimate future benefits, manage benefits already received, and it's available for people who, whether they receive benefits or not. Thank you.
Jennifer Phillips.
I would like to just point out that on the topic of regression, that it is not a fringe comment among the 259 comments that have been submitted. Nearly 1 in 5 commenters bring it up, and that it is heavily concentrated among the highest support needs and profound autism diagnoses.
Lisa Ackerman.
I really appreciate all the comments, and I want to echo when people are talking about waivers, profound autism, alternative communication, and support for caregivers. It's a crisis, and it's an honor to hear their comments and know they need the help, and we want to get that for them.
Scott Robertson.
Thank you. I'm Scott Robertson at the U.S. Department of Labor, and I just wanted to note that the written comments have about 81 mentions of employment or careers, and especially emphasizing, which particularly resonated with me, is the difficulties in sustaining employment and accessing employment that fits folks' skills, interests, talents. So we're hard at work at that, and we will continue to work on that, improving access and opportunity for all people on the autism spectrum and other folks with disabilities. And I'm really, really happy that folks continue to emphasize that in the written comments to the IACC, and hold us and others accountable, and our federal partners and other organizations we collaborate with, to continue to improve employment and career pathways for all people on the autism spectrum, and to have the opportunities that they should be able to access, that we should be able to access. Thank you.
Tracy Sutsovitz.
Thank you. I'd like to respond to Mr. Aaron Siri's comment in regards to a safety study being done on vaccinated versus unvaccinated individuals with autism. There was a study done out of Henry Ford in Michigan, and it was a vax versus unvax, but it was unpublished. But it did show a significant entry rate in regards to allergies, asthma, cancer, ADD, ADHD, autism, and many other conditions that were way more profound if the child was vaccinated. And this was taken over a 10-year period of time. And I do feel that this is a subject that deserves to be addressed. An actual study deserves to be done for these families, for these children, for the health and welfare of them, and to stop this epidemic. Thank you.
Dr. Mumper, online.
I want to express appreciation for the amount of suffering that was described today by parents and clinicians with regards to profound autism. Our chair, Dr. Foley, has identified this issue as something really significant for the committee, and I hope that by the end of the day today, we can actually move forward with some action so that these families know that we have heard their concerns and are going to address that as a high priority.
Thank you. First, Dr. Rossignol, and then Ginger Taylor.
Yeah, I was looking at the public comments. So 22% of the comments talked about etiology, causation. So I think one of the issues with autism is because we don't know exactly what causes it. It makes it hard to know what to do as far as treatments and testing and so forth. And a lot of the themes to the comments were calls for environmental, immune, metabolic, and gene environment research. So I think that's a high priority. The second most common comment was in 15% of the cases was profound high support autism. So I think that's very important, because I think a lot of people view autism as one disorder where it's a spectrum, of course, right? Where some people are very high functioning and some people have profound autism and need the support that they deserve. And the third most common comment was on adult services, housing, long-term care. So a lot of our kids are getting older, aging out of school. I see this all the time in practice for kids after 22. There's nothing for them. The parents don't know what to do. There's no really good support systems in place. I think that's a high priority as well. Thank you.
I want to thank Mrs. Harris for her comments because she has highlighted a kind of a glaring problem in that we have described my son's conditions were described in her list, and she's looking at it kind of backwards. The families have been looking at it like, here are causes of autism. If we treat these causes of autism, the autism goes away. And she's saying there never were autism in the first place. They were sick. They need to be treated. And part of that is that we've never defined autism. 1943, we've got an description of behaviors. The federal efforts have been a quarter century, but we still now have no biomarkers. We have no autism biomarkers. There's no blood tests. There's no, it's not an objective physical thing. It's a description of behaviors, which piggybacks on what Dr. Rosenthal was saying, that we need to actually know what's going on in the biology of these kids before we can move forward. And that has been done by parents and dissident doctors, but not by this committee.
John Rodakis.
Thank you to Ms. Harris for bringing that up. And earlier we heard from two other parents, Mr. Kalamajic and Mr. Beimiller, who both described treatments that profoundly helped significantly helped their children. You know, what Ginger says is right. Autism is a behavioral description. It's not a description of underlying biology and condition. And so, you know, from that perspective, it's not surprising that parents over here or over there notice that this thing helps their child. But secondly, it really just underscores the heterogeneity and the near impossibility of conducting valid clinical trials when you have children with vastly different biological underlying conditions and you're lumping them together under a symptomatic label and asking, did it help or didn't it help? So we have a system that works well for some conditions, but it's not working for autism. So I'm encouraged to continue to explore this hopefully with the FDA. Thank you.
Dr. Rosenthal.
Yeah, I want to follow up on the heterogeneity of autism. It's very heterogeneous, and there's a wide spectrum of not only symptoms, but also medical problems. And that's why a lot of autism studies looking at treatments have failed, because they take all comers with autism and study particular treatment and saying, let's study this group of kids and see what this treatment does for speech, or let's see what this does for this underlying metabolic problem, as opposed to taking all comers. So I think we need to be very careful with research and make sure that you're studying the group that you want to look at. If you just take all comers, it's very heterogeneous, and it sometimes makes it difficult to find what treatments are going to work. And plus, the testing is going to be a lot different in different individuals as well, because some kids will have a certain problem, the other ones don't. So that involves doing a lot of testing, laboratory testing, and so forth, that I think a lot of kids don't really get, at least in our healthcare system at this point.
I'm going to just speak in my capacity also as a member briefly. I think we hear over and over again, both in this room and also in the written comments that we received, and also in our work as either clinicians or advocates, that autism is a whole body disorder. And we have evidence that has emerged over the past few years that confirms that. We have immune system differences, mitochondrial functioning differences, cellular metabolic differences, increased rates of gastrointestinal disorders and other comorbidities. We have a situation, again, where autism is a whole body disorder. And I think our community is really craving for our medical system to catch up with that knowledge and to provide effective treatments for co-occurring conditions. And with respect to research, I will also add, we need cohorts. We need sub-cohorts in research. The heterogeneity issue has been raised over and over again today and in our community in general. We need cohorts, we need biomarkers, and we need to frame our research endeavors going forward in that framework. Thank you. It's a wider light.
I want to thank everyone who made comment public. It was really incredible to hear and to read. I've made public comment for many times here at the IACC before I was a member, and always wondered, I have to say, if the IACC members read it. I know from people who I've spoken with here, and I can speak for myself, it was enthralling and resonated with me as a parent. And again, thank you for your thoughtfulness. I wanted to comment specifically with Dr. Stommer and Dr. I think it's Lakes and Dr. Gassner. I really appreciated what you wrote specifically about research that also examines the experiences of autistic families and individuals that endure extreme administrative burden in navigating systems without effective or meaningful supports. And what really resonated with me was the part where you wrote, requests for non-essential information, particularly where the condition does not change, is important. Navigating these systems pulls parents from the workforce and from the simple gift of parenting. So many times I look at my son and I think, I just want to be his mother right now. And I have so many other things to do, and it breaks my heart. We should not do that to parents and other caregivers. We deserve to be parents, and our children need us as parents, not just administrators. So I want to thank you for that. I just want to be Joshua's mother and sit with him and watch TV or play games or take him somewhere. And so many times these things get in the way. I just also want to thank everyone who came here today. Obviously, there are things we need to discuss about Maryland, but then also not Maryland, the rest of the country that is experiencing issues with Medicaid and implementation. And again, also a person who spoke about seclusion and restraint. That is something that I put under public safety. We will not only be looking at wandering, which we should also look at, but also a larger umbrella of public safety. I had a similar situation, maybe not to the extent that you've described, but that's not something I'm letting go as well. So thank you everyone for your thoughtful comments. It means a lot.
Okay, that concludes our morning session. We'll take a break for lunch until 1:15 p.m. and then we'll come back and have a series of presentations regarding the proposals that were provided to the committee last week and were made publicly available on the IACC website. Please return promptly at 1:15 p.m. We have a lot of work to do for the autism community. Thank you.
Thanks, everyone. Sylvia, I'll hand it over to you to start the committee business.
Okay, thank you everyone for being here. The working portion of the day is going to begin. We have 3 topic presentations this afternoon. The first on medical comorbidity and addressing diagnostic overshadowing and diagnostic lumping, presented by Laura Salini. The second on a potential recommendation to adopt profound autism as a designation for policy and research across HHS, presented by me. And the final topic is a set of proposals to decrease the risk of death in connection with wandering and elopement, and to decrease the risk of those occurrences overall, presented by Crystal Higgins. Each of these proposals was spearheaded by the individuals presenting them. Laura Salini created and wrote attachments A and B. I created attachments C and D. Each topic presentation will be followed by a discussion period. This will be the work of the committee to discuss and further explore these proposals with the opportunity to express opinions and offer potential changes. Robust debate and engagement is crucial. To the federal members in particular, we need your expertise and we want your feedback, not only today, but going forward. After each of the topic presentations, we will vote together and we will vote on each of the attachments separately, and also depending on whatever additions or changes were suggested by the committee. After that period in the afternoon of the voting, we will shift gears and we will discuss the possible creation of working groups. So with that, I just want to check in and see if Laura Salini is ready virtually to begin the presentation.
Sylvia, I'm ready if you guys want to pull up the slides. Okay, the first page, please, of the deck. Great, thank you. Good afternoon. Once again, my name is Laura Salini and I'm a public member. Thank you for letting me join you today. This presentation focuses on co-occurring medical conditions and autism and the need for more consistent clinical recognition and follow-through, especially for individuals with the highest support needs. This theme was repeatedly mentioned in both public comments and during introductory presentations by new members this morning. In this presentation, you will see 3 shared ideas. First, the medical standard of care does not change because a patient has autism. Second, diagnostic overshadowing is a real patient safety and care quality problem. And third, certain clinical triggers may be more common in autism and should reliably prompt further evaluation. That is the framework for everything that is going to follow in this presentation. The basic point is straightforward. Autism can change how symptoms show up, sometimes referred to as atypical, but it should not change whether those symptoms are taken seriously by clinicians. In actuality, if an individual has autism, it should actually raise the threshold for careful and structured evaluation. Having a diagnosis of autism does not lower the standard for a clinical response. The recommended action under consideration in attachments A and B lay out a practical response through 2 complementary federal lanes. HRSA, which is the Health Resources Services Administration for clinician training, workforce development, and EHR prompts, and CMS, the Centers for Medicaid and Medicare Services, for early and periodic screening, diagnostic, and treatment, otherwise will be referred to as EPSD going forward, which is the Medicaid and CHIP benefit for children that requires comprehensive screening and medically necessary treatment. Both are grounded in existing care standards. Next slide, please. Okay, great. The CDC data does not show a lack of evidence. And as we see, these lanes are going to be color-coded going forward. This was developed by my son, who is on the spectrum and a digital media designer. And so you can see as you follow through on the deck, the HRSA lane will be in gold, CMS will be in light blue, and shared foundation will be with dark blue and gold. And so we can track which lane we're following in the deck. Next slide. These guidelines were developed and they have existed for sometimes many years. For example, the Bowie study from the AAP dates back to 2010 regarding GI evaluation autism and that co-occurring factors and those atypical presentations. As you can see, some of the organizations listed here for which these guidelines were drawn upon are the American Academy of Pediatrics, JAMA, the American Association of Neurology, once again, the GI domain from the AAP, and as well as the Joint Commission, which recently stressed the importance of cautioning against diagnostic overshadowing. Much of the data, of course, is called from the CDC. Next slide. The standard of care does not change because the patient has autism. Essentially, when we see that there are physical symptoms such as pain, regression, sleep disturbances, seizure-like events, GI issues, or significant safety risks, these findings still require a clinical attention. Put simply, the same symptoms that would prompt evaluation in another patient not diagnosed with autism should prompt evaluation here too, especially when the change is new, worsening, fluctuating, or otherwise unexplained. Next slide. Diagnostic overshadowing. The main patient safety failure we are addressing is diagnostic overshadowing. This was mentioned this morning, in particular by Caden, and I think that was really important to hear his account and how it was very clear that he needed the detection. So thank you, Caden, for sharing that with us today. Diagnostic overshadowing is attributing symptoms or meaningful clinical change to autism itself rather than evaluating for a co-occurring medical condition. In autism, pain, GI disease, neurological changes, fatigue, allergies, or acute illnesses may present as aggression, withdrawal, self-injury, food refusal, sleep collapse, hyperactivity, irritability, or neurodevelopmental regression. The practical rule is simple. Treat abrupt behavioral or physiological change as a possible clinical sign until evaluation suggests otherwise. This is a patient safety issue associated with increased emergency care, hospitalization, and sadly, premature mortality. Dismissing symptoms prior to evaluation may represent a form of medical neglect. Next slide. The key clinical signal in this population is deviation from baseline. First, establish baseline function as clearly as possible. Communication, motor function, sleep patterns, eating, behavior, seizure, and illness history, and day-to-day functioning. From there, 3 habits matter. Document baseline, take caregiver reports seriously, and consider competing medical, neurological, psychiatric, and safety explanations before defaulting to just autism. Caregiver observed change is the primary clinically relevant source of information, especially in non-speaking or minimally verbal individuals. Clinicians should not discount it. Next slide. HRSA, as I mentioned earlier, is the vehicle for which clinicians receive training, direction, workforce development, and it is really the best track and most appropriate for this specific initiative. Next slide. As you can see, there are multiple domains under what is called a review of systems. A structured review of systems is a standard clinical method for identifying symptoms that may not be reported directly. In autism, this is especially important because symptoms are often expressed indirectly. Slides 8 and 9 show the domains where clinically meaningful signals tend to cluster: gastrointestinal and feeding issues, sleep disturbance, neurological, and seizure-related concerns, function and regression, safety risks, immune patterns, metabolic considerations, motor findings, and psychiatric symptoms. Next slide. The practical value is consistency. Incorporate these domains into pre-visit tools, caregiver questionnaires, templates, and EHR workflows so important signals are less likely to be missed. This is not indiscriminate testing. It is a structured approach to recognizing when further evaluation is warranted and preventing missed conditions from escalating. I'm not going to go into these specific in-depth domains. I believe that some of our clinicians during the discussion period can do that. But if anyone is interested, there is more information specifically in attachments A and B. Next slide. HRSA is the appropriate agency for training side. The recommendation is to develop and disseminate CME for structured clinical guidance and practical tools, such as EHR prompts, that help frontline clinicians recognize and respond to co-occurring conditions in routine or emergency care especially. The framework translates existing evidence into feasible, scalable tools so care becomes more proactive rather than reactive or crisis-driven. Next slide. CMS EPSDT track. EPSD, you'll get the hang of it after a while, it just rolls off the tongue. On the CMS side, EPSDT already requires comprehensive screening and medically necessary treatment. Nothing we recommend here today is new. These are currently in place. There are just gaps and inconsistencies. The issue is inconsistent implementation and diagnostic overshadowing. Managed care organizations ready use a rationale to attribute symptoms to autism rather than evaluate them. CMS issued comprehensive EPSDT best practice guidance in September of 2024. The recommendation is to build on that letter by clarifying that autism cannot be used to narrow EPSDT entitlement or obligations. This is not a new mandate. It is a cleaner implementation of what the statute already requires. Next slide. A pre-existing autism diagnosis should not be used to defer, truncate, discourage, or deny medically necessary assessment, referral, follow-up, or covered treatment. Co-occurring symptoms and safety risks need to be documented independently. Next slide. Under EPSDT, clinical triggers that should prompt further evaluation include developmental regression, persistent GI symptoms or pain behaviors, severe sleep disruption, seizure-like activity, abrupt behavioral change, wandering risk, psychiatric deterioration, motor decline, and other meaningful changes in function or safety. These are common clinical realities and should not be dismissed solely because the patient carries an autism diagnosis. Next slide. Managed care organizations should not use autism as a basis to deny, discourage, or unduly delay medical necessary evaluation, referral, or covered follow-up. Documentation of symptoms, caregiver observations, functional decline, and safety concerns must support clinical reasoning, continuity of care, referrals, and access to services. As you'll notice, the Wander enlopement coding is something that we particularly wanted to highlight, as this is a issue that sometimes has sadly resulted in a high loss of mortality. Next slide. The bottom line is simple. These recommendations ensure that individuals with autism receive the same diagnostic thoroughness, safety assessment, and follow-through that any patient should receive for the same symptoms or risks. They operationalize existing standards of care. They do not invent a new one. HRSA's role is to equip clinicians with training and practical tools. CMS's role is to make clear that autism cannot be used to narrow existing EPSDT obligations. Together, those two lanes address a correctable implementation gap with real implications for health and safety. The authority already exists. The problem is uneven and inconsistent implementation due to lack of clear federal guidance. Thank you. I'm done.
Thank you, Laura. Is it possible to bring Laura up on the screen? Thank you. All right, I'd like to open up to the committee for discussion, questions, observations, feedback. Again, we particularly want to hear from our federal colleagues as well. And I will just say on that note, I can't see everyone's name. So if I gesture to you, if you could also just say your name when you speak. Thank you. Margaret Bush, virtually.
Thank you. Can you hear me okay?
Yes.
Okay. Thank you, Laura, for that presentation. I am here representing HRSA, so thank you for sharing all that. HRSA definitely recognizes that early screening, early diagnosis, these services, education can improve child development and symptoms and daily functioning and quality of life. And I wanted to mention and highlight HRSA's Leadership Education and Neurodevelopmental and Other Related Disabilities Training Program, the LEND. It has 60 training sites across the country and very strong bipartisan support. And I just want to update that the LEND Notice of Funding Opportunity is currently in process. So we definitely support the individual, the family, the clinicians, the educators, and hopefully we'll have an update on that process soon. Thanks.
Margaret, I have a follow-up question on that. In your current clinical standards and your training materials, is there training for a lot of these co-occurring medical-based conditions?
I am not sure, but I will get the answer and I will follow up with you.
Okay. If not, take attachment B.
Thank you.
Thank you. Dr. Lozano?
Yeah, thanks. I think the diagnostic overshadowing is really important. So my older kid with autism, when he was young, he was like 3 or 4 years old. He had chronic diarrhea 6 to 8 times a day, run out of his diaper. It was just horrendous. And we went and saw a GI doc. This is before I really knew much about autism. And I remember talking to him and he said, you know, this diarrhea is just part of autism. And I said, okay, well, do we need to do a stool test? He said, no. Do we need a scope? No. So we laughed and I kind of accepted it because I figured, well, I saw the doctor. He was kind of one of the better ones in the state, supposedly. And he said, it's part of autism. It's just what it is. And so we later found out that my child had other GI problems and so forth that we treated and the diarrhea went away. But I still see this in practice where patients come in and say that they're told by other clinicians that it's just part of autism. That whatever, fill in the blank, whatever problem you have, you know, rashes, part of autism, GI issues, part of autism. Even kids will have abnormal lab values or reports like abnormal EEGs, abnormal blood tests. Oh, you don't need to treat it. You know, you just have autism. So I think I don't know how to get around it because I think it still happens quite a bit that if a patient goes into the ER and they don't have autism, they get kind of a full court press, lots of treatments, tests. And if they have autism, it's like flips a switch and the doctor starts thinking it's just part of autism. And these kids I mentioned earlier, I had 3 kids that had appendicitis, sent home from the ER with constipation diagnosis, and one almost died because of it. So I'm not saying that, you know, we're going to pick up every kid that has that problem because it's hard to diagnose sometimes. But I think the diagnostic overshadowing is a big issue that I don't know what the answer is for it.
Tracy.
So I do see in my own personal experience that there's a huge issue in regards to getting these kids diagnosed early and intervention early, because early intervention is key. And then there is the concern that it seems as though unless a doctor falls under the broad spectrum of functional medicine, alternative, integrative, that they don't look at these as underlying conditions, as Dr. Rosenthal said, as that it's just a part of autism, that these doctors need to be properly trained, that they're not properly trained, they're not given this information. And I truly feel that in my own experience, it took me 2.5 years to get a diagnosis or anything for my son when my pediatrician just kept looking at me and saying, oh, that's normal. So we need to establish some form of care here in regards to getting them diagnosed, because regional centers, it's a year out for a full evaluation, at least in California. And I believe that's a little on the ridiculous side, but first the diagnosis and then establish care for these underlying conditions, because some of them are treatable. Thank you.
I'm going to turn it over to Dr. Mumper, who's virtually joining us.
Thank you so much. First of all, I totally second everything that my colleague Dan has said about the diagnostic overshadowing. We've been fighting this battle for 25 years at least now. And we do need doctors who can think as systems biology. I am concerned that for these guidelines to be implemented within a Medicaid setting, we're going to have significant barriers about funding for clinician time. The average pediatrician and family physician is expected to spend about 7 or 8 minutes with a patient. And these are not problems that can be solved in short, acute visits. They require coordination of care over time. And when I was providing care to children with autism in a Medicaid system and got audited, I was told that I had too many level 4 and level 5 visit charges. And that's going to be a barrier for a lot of pediatricians working within government clinics. So I think that I thought Laura did a spectacular job in laying out very complex information, and I applaud her son for doing the graphics in a way that was so easy to understand. But to translate that into actual action by clinicians is going to require an awareness of the time that it takes, and it's going to require federal support to change the pay structure so that those doctors can do the kind of in-depth analysis that these patients have deserved for decades, honestly. We are decades behind on this, and I hope that today we can take positive action to move these suggestions forward. So thank you so much, Laura, for working on this.
Dr. Rosendahl.
The other thing that comes to mind would be failure to refer. So parents will hear, oh, your kid is a boy, give them time, and the diagnosis gets delayed. So the average age of diagnosis in Minnesota right now is 5 years old. And we know early intervention works best when you start young. So that's another big area too, is just failure to refer or fail to get diagnoses. You mentioned the regional centers in California. California is the only state that has regional centers that I know of. So actually they have a better system than almost every other state. And they're still, a year behind. But I have patients been on waiting lists for over a year to get just an autism diagnosis done. Of course, what we do is say we don't need the diagnosis. We're going to move forward treating the comorbidities and testing for those things. But kids are just not getting diagnosed early enough, so they can't get the early intervention they need.
Dr. Fogel, we have another online, Bill Oldham.
Okay, let's do Bill Oldham, and then we'll go to Diana Diaz-Harrison.
Well, thank you. First of all, I'd like to say to Laura, thank you for that amazing work. That's fantastic, and I appreciate all the hard work that you did. I think one of the perhaps unrecognized or unapplauded benefits of that kind of diagnostic clarity would apply in the data side as well, right? We would have much greater opportunity to actually get to the phenotypes and actually get to combinations of issues that we can actually do some work in the data field on. Second, other comment I'd make is a suggestion. There have been in the past, in work I've done with HRSA, things called quality collaboratives, where those collaboratives are actual representatives from a number of the clinics and organizations that HRSA has around the country. And they get together and they take things like your document and figure out how to get that into practice. So there are mechanisms within these agencies that are on the healthcare delivery side in the federal space, which I'd love to hear from our federal members on how we can actually get some of those existing mechanisms to help cross this kind of translational gap that you so well and ably identified.
Hey there, I just wanted to mention how difficult it is to get the testing and even get blood work for our kids in order to find out if there are true underlying co-occurring conditions. In my personal case, when my son got a little bigger, and it was a little harder to get blood work, we got kicked out of 3 Sonora labs. And so I had to hire a phlebotomist privately to come and get his blood at home, because I really wanted to find out what this underlying new health concern was. And so we don't even get as far as getting lab testing or blood work, because some practitioners will say it's just too hard, or it's too traumatic, or you don't want to hurt them or traumatize, the young adult or the teen by getting this testing. But then you have to do it when they end up in the ER under sedation. So it should be easier. There should be appointments with accommodations to just be able to get that testing done and see what's really going on and what that underlying condition is. Yes.
Hi, I'm Kirsten Jensen. I'm sitting in for Caprice Knapp from CMS. So we just wanted to convey thank you for the proposal. We don't have an official response at this point, but given that we received it so recently, but we will take it under advisement.
Daniel.
I thought I might mention, my mom tried taking me to doctors when I was 2 years old, and they could not get anyone to help my stomach issues or vision problems because they said I was fine. And that was a big, big problem. And it still is. So. Thank you.
Lisa Ackerman, and then Ginger Taylor.
So there's a really good study that only 39% of U.S. pediatricians refer for an autism diagnosis. Often parents self-refer to get a diagnosis, still waiting 12 to 48 months. And besides, to echo the comments, and Laura, great job, families have to go to multiple physicians before they're heard. So I just want to echo that if this training was available and they could work to test and normalize labs, that just could be a huge gift for so many on the spectrum. Thank you.
I noticed very early on the phenomenon of it's just autism coming from doctors acts as a social contagion, because the medical community where you enter the autism world, their lack of curiosity about these cases, their lack of investigation, their acceptance of serious bowel problems, it teaches other caregivers and other disciplines, education, behaviorists, that's just autism, and it contributes to the less than aesthetic of our kids that we've been fighting against for half a century. So if we can get doctors to start taking each case seriously, that has downstream effects of they will teach just in their behavior, taking these cases more seriously, that everything needs to be investigated properly.
I'm going to just make a comment in my role as a member as well. Dr. Tim Bowie presented to the IACC about this topic years ago. And he, over and over again at conferences and in published literature, has really pointed out that gastrointestinal disorders are underdiagnosed in the autism population. leading to preventable pain and suffering and behavioral manifestations of that pain and suffering that are corrected with appropriate treatment. And he presented to this committee years ago. And I think we have an opportunity today to really, put forth some recommendations. These are just recommendations to HHS and the secretary. We are not making policy. We are just making recommendations, but they're recommendations that our federal partners and federal agencies can then consider in more depth. And I will say the issue of diagnostic overshadowing is one I see as a clinician over and over again. I am treating a 21-year-old man with minimally verbal autism with, gut-wrenching years of constipation who, really, really needs a colonoscopy. I think like anyone would really agree with that. And was told by the gastroenterologist that he went to see, his parents were told, yeah, that's going to be kind of difficult, and that was a couple weeks ago. So I really want to urge consideration of the proposals in these amendments that we could deliver to Secretary Kennedy and HHS, tomorrow. So I just urge our federal partners again, this isn't policy. This is just recommendations for consideration. I'm going to turn it over to Laura.
Thank you. And thank you everyone for sharing your comments and your thoughts. I just wanted to reiterate that these guidelines that are in these documents are actually taken from current peer-reviewed publications and consensus statements from major medical organizations. None of these are exotic. None of these are new. These are things that are supposed to be happening. And I appreciate Dr. Mumper's comments around reimbursement and the time that clinicians will need to spend. And maybe that is something that we can talk to with our CMS partners, because EPSDT is currently in place. It is a requirement. It is not consistently being administered across the states. And I want to clarify that it is the states through their Medicaid waivers or Medicaid itself or CHIP, which is the Children's Health Insurance Program, that are responsible for the delivery of these and for the implementation and surveillance. So, I'm hopeful that maybe we can figure out some more ways that we can make this work for both clinicians, our federal partners, our agencies, and the stakeholders as well. So thank you very much.
Jennifer Phillips.
So anecdotally, and also just in the name of bringing some of these clinical terms home and highlighting the time sensitivity of all of this, my daughter deteriorated very rapidly at the age of 2 from happy and healthy to all of these conditions that we're talking about. And the only recommendation we got from her pediatrician was behavioral therapy. Okay. After that, I took matters into my own hands. And my daughter ended up with an mitochondrial DNA depletion at only 30% in her muscle, hypothyroidism, primary immune deficiency, chronic diarrhea, and something called pseudotumor cerebri, which caused intracranial pressure so high that it permanently damaged her optic nerves. And so I think that just highlights Laura's statement that this, putting this off or not paying attention to this can really result in medical neglect and a really bad situation for some very deserving kids. So I hope that offers some context for our federal members to consider the time sensitivity of all of this. Thank you.
Dr. Rossignol.
Hopefully I'm not speaking too much. So, the other thing I see in practice quite a bit is kids come in with no tests ever done. Maybe a CBC, if you're lucky, maybe a lead level, but that's about it. So people are not testing for these things that have been pretty well identified in autism, the comorbidities and lab tests that are out there available for these things. The other thing that we know happens in some kids' autism is regression, right? Loss of skills. And so if an adult goes to the ER with loss of speech, they get a full court press, they get spinal tap MRIs, they get a whole gamut of testing. A kid regresses and we call it autism. No one seems to really do tests, try to figure out what's going on. It's just, it happens in kids' autism, they just regress. So I think we need a paradigm shift in medicine too, that if you don't do a test, you can't find a problem. You don't find a problem, you can't treat it. You don't treat it, you don't see an improvement. So if you're a doctor who doesn't test and never sees a treatment, notices a treatment, never sees improvements, you're not going to test because you just don't see that benefit. If you're someone like me who tests a lot of kids and treats a lot and sees improvement, not of course in every kid, but some, then you want to test more kids, right? So I think it's a self-fulfilling kind of thing where if you don't test, you just never test. And so again, educating doctors and providers is going to take a long time, but something that we need to think about as well.
I'm just going to make another comment also, just in my clinical experience, because of the communication challenges and because many individuals on the spectrum, even those who have more speech, more functional speech, aren't able to communicate their internal experiences. And so as clinicians, we need to have a higher degree of suspicion for the range of co-occurring medical conditions that are more common in autism, especially when there are changes. Behavioral changes, pain behaviors, sleep. I mean, Laura mentioned a lot of signs and symptoms that need to be considered. And I really feel like, my medical colleagues, we, at least in my training, I really wasn't adequately trained to think in terms of index of suspicion for co-occurring conditions in individuals with autism. And I think this is important not just for our primary care physicians, our pediatricians, and our family practice docs, but all subspecialists to really have a consideration for the ways that various body systems are mutually and reciprocally regulating and can lead to behavioral changes, psychiatric symptoms, a whole host of sequelae. So I just wanted to add that just in my clinical experience, I don't think we have a framework of having a higher index of suspicion and sometimes just having to proceed with a workup, even if you're not sure, simply to rule it out.
Just a question is, it's been a really great discussion about this particular issue. And a lot of compelling examples of what's happening in the day-to-day experiences of the individuals and families. In terms of the attachment that was included, and I think this applies to attachment B. Attachment A. A and B. Based on the conversation that we're having right now, and knowing that we have about 5 minutes, I think, until we go into the next topic, do you get this feeling that, or do you feel like what's in this document does reflect what's been discussed here? Anything that you wanted to particularly highlight in the recommendations that address any of the items that have been brought up in this conversation or in the presentation?
Is it on? Okay. I just want to kind of condense everything that we've talked about here to one talking point, which is autism should be a launch point, not an end point.
Daniel.
Thought I also might mention, have you ever thought of implementing a reporting system for caregivers when doctors do not listen? because a lot of non-speakers, well, I wasn't able to really advocate for myself in the hospital several months ago, and that was an issue for me as well. So.
Thank you, Daniel. I want to just circle back to what Jennifer Johnson raised, which is there any particular comments about the attachments and the particular proposals in the documents, which we will be voting on whether or not to send to Secretary Kennedy and HHS later this afternoon. Dr. Mumper, I see you have your hand raised.
So two quick things. Another is the payment issue, and this goes to my federal colleagues, and I do not envy your position having to deal with allocating funds, but some of the lab tests that I found most helpful to help my patients with autism included a sophisticated organic acid test that detects all kinds of metabolic abnormalities, and the FRAT test, which is the folate receptor antibody test, which is, if it's positive, that's an indication to use leucovorin, which can be life-changing for as many as 65 to 85% of patients with autism. These are classically not covered by most insurances, and families have to bear the burden out of pocket. So any way to make these tests more affordable or covered through insurance would be awesome. Second thing is I volunteer myself, and I'm going to speak for many of my colleagues at the Medical Academy of Pediatrics, that we are very committed to helping to train pediatricians, family docs, and specialists who take care of kids in these medical issues. And so we can work in the future on how to make that happen. It's going to be a long process, but I'm very committed to making that happen.
Can I just make one comment on that note? That my son that had these life-threatening seizures, this is Honey Renisella, sorry, I didn't have you call my name. My son that had those life-threatening seizures was seen by the pediatric neurologist at our local hospital at DuPont, and he was chief of neurology, and they dug and dug for the root cause. And again, we were given a Make-A-Wish trip saying, good luck, God bless, sometimes children die. And it was that simplistic test that she is suggesting to get covered, to test for cerebral folate deficiency, in which we identified through a spinal tap that upon proper treatment with leucovorin stopped the seizures in their tracks. So simplistic, covered by insurance, not a very expensive test. However, so many of our families are unable to obtain that. So to Liz's point, it's something that definitely needs to be brought into consideration. So I appreciate her mentioning that.
Elizabeth.
We need health equity for individuals with autism.
Thank you. Yes.
Thank you. I've been really moved by all the comments as part of this discussion. But, you know, to that important question about costs and reimbursement, I think it would be really powerful to understand the CMS response to this proposal, given that it directly impacts them and their operations. So I wonder if there is an opportunity to integrate that feedback when they've had a moment to review the proposal appropriately. I just wasn't sure how the discussion could be complete without that input, given that they're a member of the committee. So I would like to hear an understanding of how we move forward. Thank you.
CMS like a chance to respond to that.
I mean, I can respond that we would like to take some time to take a look at the proposal. We can provide a reaction. I don't know what the committee's process is for that.
Yeah, thank you. my view on this, and I'll let Laura have a chance, is that providing recommendations to the secretary and to HHS is an opportunity for CMS to more fully engage with what is in this document. And, I may have that wrong, but I also feel like this is an issue that's plagued the autism community for a couple of decades now. And we are not getting adequate medical care. And we want our federal partners and agencies to engage with common sense standard of care recommendations and to provide guidance to clinicians around the importance of considering medical comorbidities, especially in individuals who have communication challenges and behavioral challenges. Laura?
And my comments are, CMS's comments are not intended in any way. We recognize that the challenges for this community, and we are listening to the conversation here. We've had representation on this group over the years. I think the response that's being given directly from Caprice is that we were given this proposal last Thursday, and as an agency, we don't have an official response to it. As an aside, I am the person that led the EPSDT show that's referenced. I led that project. I have worked, CMS is doing extensive work in the CMS space. And I mean, in the EPSDT space, beyond that guidance. So I think that's, where the direction that we've received is that we would just like us to take a little time to look at this more in depth, given the lateness. We're voting on this later. So perhaps, that's where you follow your normal process, and that's where we are. I don't have much more to say. Caprice had to leave to make a presentation, but we do recognize the importance of autism. We recognize the importance of EPSDT. That is not lost on us. You have the person that led the project here and led the EPSDT work for 5 years. So that's kind of where we're at.
Thank you. Laura?
So I just want to clarify once again, and it's wonderful. Thank you so much for your work on EPSDT. Essentially, and I think everyone who's unfamiliar with EPSDT is we are not adding anything new to EPSDT. These are medically necessary conditions that co-occur in autism, but they're being missed due to diagnostic overshadowing or because there's an atypical presentation. So what we're really proposing is clarification and a structured review of systems so that clinicians don't miss them. One of the things, and I'm glad Bill Oldham brought up the ability to capture better data with this. We know that in the last 20 years, there's been more mandates and coverage around things like applied behavioral analysis. In my own anecdotal experience, when we treated underlying and co-occurring conditions in our son, we didn't need any services. So there may be also a cost shift that when we treat underlying and co-occurring medical conditions, we may see symptoms, even though we're not treating autism per se with those, we may see symptoms that are associated with autism ameliorate or severity reduction. So I just want to be clear to CMS and our other federal partners, this is not a new mandate. This is really just a clarification of what already is required under EPSDT. So thank you.
Okay, I think we do have to wrap up this topic for now and move on to topic number 2, which is consideration of a profound autism designation for research and policy, and I will be doing that presentation. Thank you. Perfect. So I'd first like to just start by saying that throughout this presentation, I will be using the terms nonverbal and minimally verbal interchangeably alongside the terms non-speaking and minimally speaking. I recognize that the latter terms are preferred by some members of the autism community, while the former terms are found throughout the autism scientific literature. And before I proceed, I would like to just add that the word profound was used in roughly 90 of the 259 public written comments that were received by this committee. So roughly 35% of our written comments. So a large proportion of the autism community and the autism academic and research community are already using this term. Many of the public comments that use the term profound autism or profoundly autistic share a theme of being underrepresented in policy, research, and the media. So the term profound autism is relatively new. It was introduced by Dr. Catherine Lord around 2021. And the term arose in response to concerns from researchers and academic clinicians that current diagnostic systems are incapable of accurately capturing the functional needs of some individuals with autism, who require near constant support or supervision, and most often include people with limited, minimal, or unreliable speech. Finding a term to distinguish this group of individuals from the wider autism spectrum was seen as especially important as diagnostic criteria have widened and individuals with vastly different profiles, needs, and abilities were included under one diagnostic term, autism. The Lancet Commission on the Future of Care and Clinical Research in Autism, published in 2022 with Dr. Lord as the first author, addressed this fundamental gap in autism policy and diagnostics, that individuals with the highest support needs remained poorly identified within existing classification systems. They noted serious issues with both DSM-5 and ICD-10, including that the primary domains that form the basis of an autism spectrum diagnosis, communication deficits and repetitive or restrictive behaviors, don't effectively capture real-world functional disability, including the capacity to effectively advocate or communicate one's needs or wishes. The Commission noted that with the expansion of diagnostic criteria, those with the highest support needs were at risk of being marginalized by a focus on more able individuals in media, research, and policy. They proposed the term profound autism to be an administrative designation, not necessarily a formal diagnostic subtype, similar to what the proposal is before you today. The Lancet Commission proposed 3 criteria for the designation of profound autism, which were anchored in functional needs. And those functional needs were requiring 24-hour access to an adult who could care for them if concerns arose, being unable to be left completely alone in a residence, and being unable to effectively take care of basic daily adaptive needs like eating and hygiene. They noted that in most cases, those needs are associated with very limited spoken language and or a substantial diagnosed intellectual disability with an IQ below 50. The speech criteria and the IQ criteria were an and/or designation, with the primary focus being on functional support needs. In parallel, at around 2021 and 2022, INSAR, the International Society for Autism Research, developed a Delphi process that culminated in a proposed framework for profound autism for individuals with the highest support needs. Again, their central and core anchoring criterion was profound functional dependence, that the person required adult supervision to ensure physical and mental health, safety, and well-being due to risks such as elopement, injury, or lack of environmental awareness, and that their adaptive functional skills led to an inability to perform most activities of daily living independently. They noted that these individuals also tend to have marked communication disabilities and limitations, and also had that same and/or criteria with significant cognitive impairment. About a year after the Lancet Commission Administrative Framework for Profound Autism was proposed, the CDC, via the Autism and Developmental Disabilities Monitoring Network, published surveillance data from 2000 that covered the years 2000 to 2016. And they found that roughly 26% of individuals met criteria for profound autism. Interestingly, the CDC criteria are operationalized primarily around speech and an IQ less than 50. However, the speech criteria used were very, very narrow in that study, and we can get back to this later if there are questions. But notably, even in this study where IQ was a criterion for the profound autism designation, almost 20% of their sample did not have IQ data available. And IQs were imputed using other criteria, many of which were functional criteria, such as adaptive functional scores, aggressive behavior, or self-injury. Oh, sorry, I'm going to go back. So, why is this designation important? I mean, obviously, we're talking about that those with the highest support needs really have fundamental differences in terms of what they require across the lifespan in terms of services and supports. But it's also really important from the idea of really being better able to understand risk factors or biological risk factors and underpinnings for this particular cohort. Those with profound autism or the highest support needs have elevated mortality. Those with autism in general have slightly elevated mortality, perhaps maybe 1.3 to 1.5 times the general population. But those with the highest support needs have a roughly 2.8 to 5 times mortality risk compared to the general population, and reduced life expectancy, 7 years for men and 15 years less for women. And certainly this group, as we'll hear from later, has elevated safety risks from a range of issues, including wandering and elopement. This cohort also has higher rates of co-occurring medical conditions. Epilepsy, which is found at roughly 1% in the general population and is present in about 8% of autistic individuals with lower support needs, is present at a much higher rate, 21% in those with the highest support needs. Likewise, gastrointestinal disorders are significantly more common in those with autism and the highest support needs, and symptoms are also more severe. And interestingly, in terms of motor impairments, and this body of research is very exciting to me because I think there's an emerging conception in the scientific literature of autism as a motor disorder, as a motor movement disorder. We know that motor differences in the autism spectrum as a whole are 22 times greater than in the general population. But the risk of motor differences and motor challenges and disabilities is even higher for those with the highest support needs, roughly 4 to 6 times higher compared to the autism spectrum overall. There's research that shows that those who have autism spectrum disorder plus a diagnosed intellectual disability also have significantly greater motor incoordination. And certainly this group, there's robust data that they have elevated rates of sleep disorders, feeding difficulties, and self-injurious behavior. So here's the central paradox. The individuals with the greatest medical complexity and functional support needs are the most excluded from the research designed to help them. Despite higher rates of epilepsy, gastrointestinal disease, sleep disorders, self-injury, 94% of autism spectrum disorder research participants have lower support needs. This is not a random gap. Studies show deliberate or implicit selection bias against those with higher support needs in 8 out of 10 studies, and the trend is moving in the wrong direction. Those with arguably the greatest need are the least represented in the research that could help them. Existing systems do not reliably capture individuals with the highest support needs, and it's why a functional designation of profound autism, in my opinion, is needed. There have been many criticisms of the DSM-5 diagnostic framework for autism, and the framework is largely based on social communication and restricted behaviors, not overall functioning. The severity levels, level 1, 2, or 3, were designed to reflect the level of support needed in those domains, again, with respect to social communication or restricted repetitive behaviors. Yet Mazurak and colleagues found in 2019 that clinician severity ratings were strongly associated with measured IQ, suggesting that measured cognitive function was being folded into severity determinations, contrary to DSM-5 intent. Other criticisms of our current diagnostic framework include the idea that autism is not a single spectrum running from mild to severe in a straight line. It is a highly heterogeneous condition along multiple dimensions: social communication, language, motor functioning, sensory processing, adaptive functioning, and co-occurring conditions. And these domains do not necessarily neatly correlate with each other. A person can be severely affected in one dimension and not in another. The issue of co-occurring conditions such as anxiety, ADHD, epilepsy, and other medical conditions deserve special mention, as they can have a tremendous impact on the daily functioning of autistic individuals. Yet, as Weisbard and Bartov and colleagues noted in 2023, there is currently no formal way to designate the combined effect of these aspects of autism on a person's capacity to function in day-to-day life. That gap is precisely what a profound autism designation, grounded in functional capacity and functional language, would begin to address. If autism is not a single linear continuum, but a multi-dimensional heterogeneous condition, then treating everyone under one label for research and policy purposes is simply inadequate. And those with the greatest support needs risk being invisible within the very category meant to represent them. So what are the proposals in Attachment C? They're really pretty simple. The proposals are minimally speaking or non-speaking, and the requirement for continuous or near continuous supervision. This would apply, similar to the Lancet Commission and INSAR, to individuals over the age of 8 years or older. This would be for research, policy, and program planning, and it does not in any way affect DSM or in eligibility determinations for programs either at the state or federal level. And notably, in the proposal before the committee, minimally speaking is really aligned with a functional communication definition. So at the most basic level, the designation proposed in Attachment C is really framed around, is the person's communication ability enough to assure safety and get basic needs met? The functional definition is crucial because the term minimally verbal or minimally speaking has very different meanings across different research studies and context, including in the CDC surveillance data that I mentioned earlier. It's not word counts that matter or whether a phrase has 2 words or 3 words. It's whether speech can be used to convey someone's internal state, their needs, or their wants. Can a person express pain, a medical issue, or a direct need? Many individuals with autism, even who have many words or even 2 to 3 word phrases, can't do that. I think from a practical level, I think about, can an individual call 911 and get help? Not necessarily explain the whole situation, but say enough to get a first responder to come to their home or wherever they are. Can they tell a medical provider that they have a headache or abdominal pain or a toothache? We need to focus on functional criteria because that's what really matters for individuals and their families. Oh, sorry, I was on the wrong slide. Thank you. Okay, sorry. Here are the criteria. In our proposal for the profound autism designation, we are specifically recommending that the criterion of intellectual disability not be used in this functional definition of profound autism, as it is unreliable, unnecessary, and potentially exclusionary. The Lancet and INSAR proposed frameworks that included ID had used it, as I mentioned earlier, in an and/or option with speech disability. The primary focus was on continuous support needs and 24/7 care. IQ was used as an and/or criteria with being minimally speaking or non-speaking, but notably, again, in those models, used very narrow criteria of what was meant by non-speaking or minimally speaking or minimally verbal. IQ testing is a resource intensive and not always available. Indeed, in the CDC surveillance study, as I mentioned, roughly 20% of children did not have measured IQ. And as I mentioned before, the method used to estimate IQ included a number of behavioral and functional factors. We know that IQ is unreliable. There's a large body of published research that supports that idea, and references are noted in attachment C. Answering an IQ question requires speech or reliable and consistent motor functioning and motor planning, including initiation. And yet motor impairments are well described in autism. Again, a growing body of literature and interest in this idea. And crucially, some non-speaking or minimally speaking individuals demonstrate average or above average intelligence with appropriate assistive and augmentative communication, and yet may still require continuous support. Having a reliance on IQ as a criterion for profound autism might exclude individuals who meet functional or communication criteria but lack a formal intellectual disability diagnosis. It may misclassify individuals due to known assessment limitations, and it reinforces systematic underestimation of cognitive potential. So, as I mentioned, functional criteria are central to many policy proposals and supports. The core criterion of the Lancet and INSAR proposals for profound autism were functional, the requirement for continuous support for safety and well-being. We need this designation so we can have consistent identification across systems, improved research designs and planning. This is crucial. Better resource planning. I think having a term for individual with the highest support needs that is more descriptive, I think supports interagency coordination, and it aligns with the Autism Cares Act priorities. We need to recognize those with the highest support needs and begin to correct the systematic and unequivocal exclusion from research and design policy with their lifelong continuous support needs in mind. The term is already being widely used. Let's operationalize it along functional criteria around speech and support needs so that we capture the lived and clinical experience of this cohort and correct the underrepresentation in research and policy. Thank you. So I'll turn my hat over now as chair. Dr. Rosenell, I saw your hand first.
Yeah, so in clinical studies, generally you try to pick kids that you think are going to do well. So you exclude high functioning kids because maybe they don't have as much room to improve, and you exclude low functioning kids because they are severely affected and may not improve much. So you try to get the medium affected kids. And so a lot of studies are doing that, and even going further and selecting out like, okay, let's take kids just with speech delay who meet this criteria of moderately affected and so forth. So I don't know how you fix that in research because there's no incentive to have profound autism in your research study because it might screw your study up, so to say. So for example, we oftentimes exclude kids with seizures from the studies because if a kid has a seizure, that's an adverse event. And you don't want adverse events in your study, so you're trying to prevent those type of things. So there need to be research set aside for we're actually going to study profound autism, or maybe they're in the study, but they're kind of analyzed a bit separately, or if they have a seizure, it doesn't ding your whole study, if that makes sense. So it's a big problem in research because the clinicians don't want the profound kids in the studies.
I think our collaboration with our FDA partner is is in our future. Dr. Beckel-Michner.
Thank you. I first want to applaud you for highlighting this community. And we heard many comments around the table early on that there's a really
a great need to do more research and provide more services. I just want to, from a research perspective, representing one of the NIH institutes that supports a large number of autism studies, I just want to raise a couple of items for consideration, and I would appreciate hearing from my other NIH colleagues as well. Definitions matter. We've heard a lot about the heterogeneity of autism and autism spectrum disorders over today and for our lifetimes. I do have a concern that if we too narrowly define profound autism, we will end up excluding unintentionally a number of individuals from studies as well. So it can actually potentially backfire and have the opposite effect on our research portfolios. Dr. Rossignol's comments are well taken. This really comes down to sort of an inclusion-exclusion criteria as researchers are determining what their clinical endpoints might be. So I do have some concerns that we may not be seeing the full picture with the definition that has been proposed. I would love to see more expert opinion on this and to raise with other subject matter experts. So from my perspective, I would support additional information gathering and people like Dr. Lord and many others who have experience in this to really understand the full spectrum of what we might be voting on and what would be best for the research opportunities that lay in front of us.
Dr. Ellen Monarch.
With regard to what Dr. Rossignol brought up about the highest functioning and the lowest functioning, those would be important for outcome studies if we were doing interventions. We have a lot of other research to do for people with autism. We need to figure out what is causing autism. We need to understand their bodies better, their GI systems, their immune functioning. There are many, many studies to do. And I would argue that we need the profound group in order to understand that, because their gap in their health markers may be wider and more easily detected.
Kaiten.
I want to start by saying that I support the intent of this proposal. It matters to me that people with the highest support needs, especially my non-speaking peers, are seen and better supported. That is important to me. At the same time, I have some important concerns. The term profound autism does not come from a neutral place. It was originally used to describe people like me with the assumption that we also had intellectual disability, that profound meant low cognitive ability. Many of us were also labeled nonverbal, but that is not accurate. Spellers are not nonverbal. We are non-speaking. We have language. We have thoughts. The issue is not a lack of understanding. The issue is getting our words out. So, I don't identify with the term profound autism as it is commonly understood. I do have profound motor challenges, including apraxia, and those affect my ability to speak. But that is different from having a low IQ. When people confuse these concepts, we are underestimated. I also want to speak for my brothers and sisters in the autism community who have fluent speech. Some of them have high support needs and profound challenges in daily life. I don't support the definition of profound autism that leaves them out or makes their needs less visible. Another concern I have is about how this term is already understood by the public. Profound autism has been widely used to mean low intelligence. That perception is out there and would be hard to change. I worry that adopting this term, even with a more careful definition, may reinforce those negative assumptions rather than correct them. So while I support the goals of this proposal, I want to be clear. I support it to help my non-speaking peers get the recognition and support they deserve. But the term itself, as it is commonly used and understood, does not represent me and my non-speaking community. Intro.
Thank you. Laura.
A couple things. I just want to reiterate, we're highlighting the need for profound, which is exceptional. There is still level 3. So what we've come to realize, and I think this was expressed in public comments and in comments today, and I know many people on the committee do live with this reality, there is an exceptional population for which they cannot be left alone for any amount of time because safety is a very serious risk. So we haven't really captured that in our current descriptions under the DSM for levels 1, 2, and 3. So there has been a momentum to adopt this, and this is actually being currently used now in research papers. And I believe INSAR just had this focus regarding about getting input from experts outside of the committee. Of course, that is something that the federal members can do. But at this stage for this committee, these are recommendations. These are not the same as like a Federal Register rule that is being finalized in which we are soliciting outside comments to make a final rule. So I just want to make sure that we're clarifying that this is only a recommendation that would go to Secretary Kennedy and that would then be determined by him. So thank you.
And if I might ask Andrea, asking that question or suggesting the bringing in additional experts to speak to this, I took it as part of the deliberative process that the committee would engage in to consider whether this is a recommendation that the committee would vote on to move forward to the secretary. Is that part of, or were you seeking something different?
I think the language of the recommendation really matters in terms of how constraining it might be for future research. I don't know if it's appropriate to actually propose a change in the language for us to consider, but I would suggest, Diana, maybe in your role as NAC, for example, convening experts to include members of this committee, I think also, because I think the perspectives that we've heard today are really important. I'm just not sure if me personally representing my agency right now would be comfortable voting for this definition in this form, even as a recommendation to the secretary at this point. I feel like I need more information to be able to vote on that.
I would like to, because we do have, and I, take this recommendation as one that's directed specifically at HHS agencies. And we do have a number of federal partners on the committee who are from different parts of HHS. And as I read the recommendation, it would apply both to research and policy, and that if I'm following the recommendation correctly, HHS agencies could potentially be asked to follow this definition when considering any policy or research. Is that, I just want to make sure that the committee understands the recommendation and what, for their federal agency they would be, I guess, voting for in terms of the recommendation and moving that forward. And if there's questions from any of our HHS representatives on that. So actually, I'm sorry, if we could just get the clarification that I asked about in terms of the recommendation for both research and policy, and that HHS agencies would be asked to apply.
So this is a recommendation for HHS to consider. We are not a policymaking body. We are a body that can make recommendations to HHS for consideration that then our National Autism Coordinator can follow up with. And HHS is free to come back to this committee and tell us, if what works and what doesn't. But how I see this committee's role, and particularly the public members, is taking the lived experience and the urgent concerns of the autism community and translating them into policy for HHS to consider. We are in no way charged with creating policy that is mandated to adopt. Judith, thank you.
Good afternoon, everyone. I wasn't here in the morning. I'm Judith Cooper. I'm the Deputy Director at the Deafness and Communication Disorders Institute. I have to say that both my director and myself were thrilled to see the focus on non-speaking, because our institute has tried to be a small leader in bringing attention to non-speaking. We've done workshops, we've done initiatives, we've encouraged research. So I think shining the spotlight on the needs of this population and the research needs, we are very supportive of that. I, for one, though, am concerned about this controversy and the voting, but I will say that the applications that might come in that are focused on non-speaking individuals, they'll go through peer review. The science will be judged. So I think there's a spotlight, and then there's the process of the impact of the spotlight on how we define a profound will be viewed in the applications that come in. So I think we are very supportive of anything that can encourage research with this population. We've been trying to do that for many years. And so thank you for the document. And I'm hoping that, hi, Scott, yeah. Some of us have been on the panel and have talked about this before. Yeah, so thank you.
Thank you very much. We'll take just 3 more comments. Dr. Elaine Hubal online, and then Bill Oldham, and then Kaden and Katie Sweeney. So we'll go in that order. Elaine, Bill Oldham, Kaden, and then Katie, and then we'll have to move on. Oh, okay, and then Elizabeth. Okay, and then we'll have to move on. Okay. Okay.
Okay, so can you hear me?
Yes.
Okay, I was gonna say you might not have to take my comment. Okay, so I will just say, because this topic has come up before and it is beyond critically important. And sort of I've been hearing and really taking to heart the comments that come sort of from people who appreciate the really extreme needs of this population and the caregivers, and then people who have important concerns. So I would just say, from like the perspective of an agency outside HHS, so Environmental Protection Agency, and sort of understanding the importance of having categories based, that knowing the complexity of the factors that we're trying to incorporate into classifications that are going to be meaningful for making decisions that are most health protective, health promoting of the most vulnerable groups, whatever those may be in whatever context. I would just say that I think it would be important to really take advantage of newer, more recent methodologies for evidence-based synthesis and data-driven classifications that could help us protect and the intent of this recommendation. So maybe alter the recommendation. So what we're wanting is really evidence-based, data-driven classifications that will meet the needs of the most vulnerable in a really in a way that helps both on support and on research and on regulatory actions. I guess I'll leave it at that. But that to me is something that takes some real good work, and I think I would love to see a working group focus on that.
Thank you, Bill Oldham.
Yes, thank you. First of all, I'd say I applaud you for a couple of things. One is that, as I understand our responsibilities as a committee, we're looking to suggest exploration for the general direction of travel for our community. And I'd encourage us all to not make the perfect the enemy of the good. We need to advance. I think if for all of us who took the time and the energy, and I hope it was all of us, to read the public comments, this is clearly an issue that needs action. So we're not here to make policy. We're here to suggest a direction of travel. And I applaud you for what you've got in this document. I think it advances us down the path that we need to go. There was a particular comment in the public comments on there are different autisms. And I agree wholeheartedly the definitions matter. But we have to start making progress towards what some of those new definitions actually are, rather than the debating, because the time and the struggle is now. I'd also applaud you for one more thing: the differentiation in the document about intellectual disability. As the father of two minimally verbal and nonverbal boys, there's a lot going on in their head every day. They're a real human being with a brain and capability, and they deserve this kind of distinction. So thank you for your good work.
Thank you. Kaden? I'm going to ask you to restart that and put the microphone closer, please, if you can. Take your time.
Oh. Want to be clear. I will vote yes, but wanted to speak my mind on it.
Thank you, Katie. Let's do Katie Sweeney and then Elizabeth, and then we're going to move on to our next topic.
Thank you. I heard in this discussion in the last phrases like want more time to review, leading the project for 5 years. This is not new. Language is concerning for future research. Convening experts. I need more info. From reviewing the 25-year history of IACC, I think this committee is notorious for kicking the can down the road. That diminishes the lived experience of both families and individuals affected. And the reality of our autism children, young adults, families, and caregivers. I ask, as a parent, how much more time and info do you need?
Thank you. Elizabeth?
This recommendation impacts me and the millions of non-speakers in America. I wish that non-speakers didn't have to contend with another label, but I appreciate that this definition explicitly excludes intellectual disability. Tens of thousands of non-speakers now type to communicate. The vast majority are like me, diagnosed with an intellectual disability before being able to show how capable we are. I would prefer not to use the term profound autism because its definition has historically conflated non-speaking with intellectual disability, an assumption that is harmful to understanding our capabilities. With this recommendation, I hope the autism community can come together and presume competence for non-speakers. I am generally supportive of this recommendation because it will focus research and policy on helping families that have the greatest support needs. However, I would highly recommend one sentence be added to Section 6, Person-Centered Considerations. The sentence is, providing services and supports for robust alternative and augmentative communication are essential for maximizing the health, safety, and potential of individuals with autism. And one final thought. My sincere hope is that these efforts will help change the way the world sees non-speaking autism. Our support needs may be high. Our thoughts are profound. Thank you.
Thank you. Would it be possible to read again the sentence for the proposed addition? Sorry, I'm going to just try to type it.
The sentence reads, providing services and supports for robust, alternative, and augmentative communication are essential for maximizing the health, safety, and potential of individuals with autism.
going to read it back to you. Providing services and supports for robust assistive and augmentative communication are essential for maximizing the health, safety, and
potential
of individuals with autism.
And it's AAC, alternative and augmentative communication.
Thank you. So we have to move on. I'm going to propose that we add that sentence to attachment C, and later in the afternoon, that will be added to that proposal. So we are going to move on now. We're a little bit behind schedule.
Sylvia,
Yeah.
sorry. I think because you've made that proposal, I'm looking to my colleagues here to the right, that we might need to, as a committee, vote on making that change to this document. Would that be committee protocol or?
I mean, we could potentially vote to accept the document, including the proposed change.
Okay.
But we would probably need to send that exact language out just so everybody's clear on what it is.
Okay. Can we do that during the break, which is now shortened? Yes. Okay. Thank you. Okay. I'm going to turn it over to Crystal Higgins. We're going to start at topic 3, wandering and elopement in autism. Thank you.
Thank you. Is there a clicker for the presentation? Thank you for your attention to this issue. I know several of you here have lived experience with this, and I'm grateful to be able to present on the topic and possible solutions today. I will say this is one of many urgent safety topics, and my hope is that we can continue to bring additional safety issues to the table as we work together in the future. Nearly half of children with autism will wander or bolt from a safe environment. When we use the CDC's most recent autism prevalence estimates based on the 2014 birth cohort and US Census information, that means we're looking at over 1.1 million families in the US affected. These families are living with a level of risk most people could never imagine. We have, oh, sure, great. We have several peer-reviewed studies on this issue. This problem and supporting data have been presented at previous IACC meetings many times, including in 2010, 2013, 2016, and 2017. This has been an ongoing and consistent crisis that has not been adequately addressed. Right now, we're experiencing an average of 8 fatalities per month in the US, and Lori McElwain at the National Autism Safety Council recently reported that in 2026, we are already outpacing last year's fatalities by 30%. As I mentioned, the data has been comprehensively presented at previous IACC meetings, so I'm just going to briefly summarize the main trends here that demonstrate the pathways to effective prevention. On the left are causes of fatalities in a 5-year study that analyzed over 800 media-reported wandering and elopement cases from 2011 to 2016. On the right is an analysis from media-reported incidents in 2025 that show the trends have not changed. By and large, these individuals are going to water, with traffic fatalities coming in second. It's important to note that in the 5-year study, 76% of drownings were in natural bodies of water or drainage waters. This is unique to this population, and responses should be appropriate and specific to address this pattern. Fatalities happen fast. You can see on the left here, the lighter blue represents fatal incidents in the same 5-year study, the highest amount in an hour or less. Every case is critical. You can see the majority of rescue components were first responders and Good Samaritans. This underscores the need for consistent first responder training and for the public to be immediately notified and directed to search nearby water when a person with autism goes missing. This graph is from the 2025 review by NASC. Fatalities spike in warmer months. We've seen this consistently for over 15 years. Recommendations to combat this issue should be urgently adopted and implemented. Multi-layered preventative measures are most successful. Home safeguards like alarms, fencing, and locks, personal safeguards such as tracking devices and personal identification are prudent measures. Swimming lessons are critical, and clinical counseling should include risk education and options for families to consider, as well as informing families on trends such as heightened risks during times of transition, family gatherings, warmer months, and increased risk overnight. Most families report they were never counseled about wandering at the time of diagnosis. We would never, for example, send a patient with epilepsy home without medication or a seizure safety plan. Why have we continued to leave autism families to learn about wandering risk through a close call, or worse, a tragedy? Safety counseling should be standard at the time of suspected or official diagnosis. These are the most common barriers to preventative measures cited by parents. Many families living in this constant heightened state of alert and experiencing persistent traumatic events face barriers that limit their ability to keep their loved ones safe. It's possible to eliminate most, if not all, of these barriers with sufficient support. Parents noted that the #1 barrier was lack of funding. Right now, Medicaid coverage remains uneven where it does exist, and it's still completely non-existent in many states. Medicaid routinely covers non-medical preventative interventions across multiple conditions, including home modifications and monitoring systems where they reduce risk of serious harm. Autism-related wandering and elopement meets the same thresholds of risk and should be treated consistently within this framework. The most recognized similar alert system to FEMA's missing and endangered person or MEP alerts are the Amber Alerts or Silver Alerts. We're talking about immediate notification of a missing person via wireless emergency alerts, including descriptions and specific directives to the public within geographic proximity. MEP alerts already exist, and autism fits squarely into this category. No new legislation is required. Some states are adopting their own alert systems to address these incidents, but there is no consistent framework that states can readily adopt to capture each missing person with autism. As we've seen, time is critical in these incidents. Drowning accounts for the vast majority of wandering fatalities, and most of those are happening close to home or the last known location and in natural bodies of water. Alerts must be issued immediately upon report without delay, eligibility barriers, or waiting periods. Any delay in public notification reduces the likelihood of rapid recovery and increases the probability of a fatal outcome. Every reported incident should be presumptively classified as critical from the outset, triggering immediate activation of MEP alerts. It's simply a very effective way to trigger an appropriate response, reduce search times, and save lives. Responses and directives should reflect the known risk pattern, search water first, and traffic corridors, known behavioral attractors, and nearby terrain. Even in states where autism training is required for first responders, it doesn't always specifically include training on missing persons with autism or wandering and elopement prevention. These are key critical things for responder awareness, that individuals may not respond to their name, may flee or hide from responders, may not recognize danger. They may be silent, not splashing or calling for help. This drowning can look very different than typical drownings, and they may not be aware or be able to control their body in traffic risks. We can take action now. We can standardize MEP alerts to expedite proper search responses with autism-specific criteria and guidance. We can expand first responder training that specifically includes unique risks and appropriate response to missing individuals with autism. We can support coverage under EPSDT, as well as home and community-based services, and we could utilize HRSA and EPSDT to standardize safety counseling for families. Last, as an additional consideration, we must address a gap in our understanding and research. And Amy, I really appreciated your comments earlier on this. What's happening biologically to our loved ones in these moments? For some, bolting may reflect an acute neurological stress response rather than intentional behavior. Differences in autonomic regulation, Sensory processing and threat perception can push the nervous system into fight or flight or impulsive motor, during which inhibition or stopping the body is challenging. If we expand our understanding, we can design effective treatment, trauma-informed care, and response to stressors. This is essential to providing what could be one of the most useful pathways to reducing wandering cases, as well as other critical safety issues. The next slide is a video because I really want everybody to see what this looks like in real life. This incident in the video will show you how the trends that we just highlighted: elopement under supervision, repeated incidents, tendency to go quickly to a natural nearby body of water, and most importantly, how critical immediate and informed response is. Can we get that back up? Sorry, guys. There we go.
Pardon the interruption. We still can't hear that online or through the video cast.
I will highlight what happens in a moment for those who can't hear online. For those of you watching at home, obviously this child was rescued. Kudos to the Gwinnett County Police Department, who knew immediately to search water first. Almost a year ago to the day, after a 20-hour search, they recovered the body of 5-year-old Indy after he stacked furniture, they suspect, on his balcony, jumped off, and went to a nearby body of water. It should never take a trauma to inform response. Again, more than 1.1 million families in our country are living with this level of risk every day. We have a long enough record of fatal outcomes to use the information and provide families and first responders with the tools they need to keep these individuals safe.
Every single time.
Oh, there we go. Some families are not as lucky. Just as we were preparing to finalize this presentation, these are 4 of several fatalities that occurred. Alex, at 32, had some independence and enjoyed cleaning the trash out of the canal behind his home. He went missing for an unusually long period of time, and his family mistakenly believed they had to wait 72 hours before filing a missing persons report. The investigation is still ongoing, but his body was found in the canal. 25-year-old Dustin and his twin brother were both diagnosed with autism. This month, Dustin opened a window despite the furniture in front of it, left home, and in the very early morning hours was hit by a bus on the highway. Matthew, who was 9 years old, got through 3 different types of locks, one of which was a mechanical lock that, according to his father, was difficult to figure out. But Matthew did, and he was quickly killed by a car. And Maddie, 13 years old, wandered from home in the dark and fog in the middle of the night and was walking down the highway when she was hit and killed by a dump truck. After submitting these slides, a 55-year-old devoted father, Juan Andrade, drowned in LA after jumping in the lake to save his 14-year-old son, who had wandered into the water. This is a public health crisis, and it is preventable. Thank you to the full committee and to the Department of HHS for hearing this issue. I am so hopeful that we can support meaningful, life-saving resources becoming readily available to our community together. Thank you.
Thank you, Crystal. So I'm just going to go through, well, first I just wanted to say, as noted in attachment D, the IACC sent a letter to then Secretary Kathleen Sebelius about this issue in 2011. There's more to do, and this is a public health crisis with 7 to 8, just based on media reports, 7 to 8 deaths per month in the autism community, and that's not with active surveillance. Those are simply advocacy organizations following media reports. So just to review the recommendations in attachment D, which I hope you all had a chance to review. The first one is for Secretary Kennedy and HHS to clarify and promote consistent use of the missing and endangered persons alert category within the integrated public alert and warning system, IPAWS, for autism-related wandering and elopement incidents. And I listed, with Crystal's input, a number of operational guidance implementation considerations for the Secretary. The second proposal is for the CDC to update its wandering and elopement webpage to emphasize drowning risk and the prioritization of searching nearby water sources and high traffic areas. That's not currently clear on the CDC elopement and wandering webpage. And we if the committee adopts, would recommend also creating downloadable safety information sheets for first responders and for providers and caregivers directly from the CDC website. The third proposal is to reevaluate and expand ICD-10 coding for wandering to potentially capture clinically assessed prospective risk, because right now the code is typically only used for a history of wandering. And we are proposing that if this we would need evaluation from the National Center for Health Statistics, but the recommendation is really for them to look at this issue and see if a prospective wandering code risk would be appropriate. The second would be update early EPSDT and Bright Futures guidance to include risks of wandering elopement. And the fifth would be to encourage consistent coverage of safety supports under HCBS waiver programs, so things like locks, door alarms, fencing, related safety equipment. And the sixth is to promote clinical adoption of wandering and elopement risk guidance, again, through the CDC in conjunction with updating their webpage and providing downloadable materials. I believe these are common sense, actionable, easily implementable recommendations. And again, they are recommendations to the Secretary and to HHS for consideration. I open the floor to discussion. Tracy.
So this is an issue that's very near and dear to me. At the age of 5, my son in kindergarten, he had a one-on-one aide. After school program in which I was arguing with the regional center or your developmental disability systems, whichever that may apply to in your state, in getting him an aide as they drug their feet, they lost my son. So when I went to go pick him up, I was told that my son was not a good boy today. And when I asked the caregiver what had happened. Sorry. He had told me that he said, they didn't contact you. I said, no. They said, we lost your son. And I said, what do you mean you lost my son? He said, yes, he was gone for 2 hours and we had every known adult looking for him. As they went to the playground, my son went to the adjacent park and was there by himself, severe at the time with his symptoms, and playing on a hillside where he could have fell off near a busy street where he could have got hit. Like I said, I feel very blessed and very lucky. And I was told that my son wasn't a good boy today. So there are many levels in which this deserves to be addressed. Also, where my son's paraeducator was constantly pulled away from him. And luckily, one day I just happened to be volunteering in the classroom, and Noah walked out of the room, headed towards park again. And I brought him back as his paraeducator was passing out papers. And I truly believe that paraeducators and most aides, most of them just having high school diplomas, are not educated on how to care for an individual with autism, especially one that elopes. And a teacher who told me I could never volunteer in her classroom again. So this is definitely an issue. I feel very blessed and very lucky. I had to resign from working, putting us in a financial bind, but for the health, welfare, and safety of my son. And
Thank you,
Thank you.
Tracy. I'm sorry, I want to just make sure we're a little bit behind time, so I want to make sure other people have a chance. Lisa Waiterlight.
Thank you. When Kevin Devante's law passed, and we have a committee member, I think, who can speak to this, who I think is virtual, shortly after one life was saved, like shortly after, you may know at NAA, like almost, I don't know how many days. This is a problem with easier answers than other problems that can save lives. This is a discussion that should have happened years ago, that could have saved lives years ago, and we have a chance to do it now. We're all on this committee because we want to make a difference, and this is an easier decision than others to make, in my opinion. We don't really have a choice, and we've got subject matter experts here. We've got parents here, parents of children with autism and parents with neurotypical children. Nobody wants this to happen. Nobody wants to be looking for their child. Nobody wants to, God forbid, find their child no longer around. This is an easy one. I hope we don't have much discussion and we can vote for this and move on. Thank you.
Okay, Matthew Maynard from the CDC.
Hi, thank you. So thank you for the presentation. Obviously, this is an incredibly important topic. I just wanted to comment that after reviewing the CDC's specific recommendations with looking into including ICD codes into surveillance systems, if we're talking about autism surveillance, that seems that's within our grasp. Updating websites and disseminating guidance, these all seem like practical things that are worth exploring and considering. So thank you.
Thank you. Hayden.
I'm concerned that the current language references surveillance, but doesn't specify who is responsible, what exactly is monitored, and how accountability is enforced. Given the seriousness, including preventable deaths, I would ask for ownership and clear lines of reporting.
Thank you so much. Just for clarity, I think our CDC member brought up the possibility, I think, that they would explore more active surveillance, although that is not a proposal in this attachment or one that we will be voting on today, but I'm glad to hear that potentially could be a consideration. Crystal.
Yes, also if MEP alerts were to be autism specific as other similar alert systems operate, there is a surveillance component there. Again, we're not writing the policy, but my hope would be that there would be similar surveillance to capturing these incidents through that means.
Yes. Thank you, Laura Salini.
I just want to also stress that absent any alert system specifically, we do have currently the missing endangered persons, which is what we are leveraging here. However, police departments, first responders are taking this on themselves, and some are trying to access training. So I think that they are actively looking for this kind of direction, and that many would appreciate it. So I think this will definitely help them. And just what I've seen on social media, many are trying themselves to seek it out and are anxious for this. So I hope we support this. Thank you.
Lisa Weyerle.
Sorry, I just wanted to add, some states are taking this on as initiatives. In the public-private partnership that we have in Maryland, it's called the Maryland Autism Coalition. I encourage everyone who's interested to Google this information. We have PSAs about wandering to search water first, call 911 immediately so there wouldn't be these miscommunication. And it's really very good information. We have worked with NAA, we've worked with Lori McElwain's new organization. There are examples, but I think we've got to lead the way in saying that this is something that needs to be national and not on a state by state basis. This is a national initiative. Thank you.
Dr. Rosnell.
I think it's been brought up before, but just to reiterate that the mortality rate in autism is about 3 times higher than general population. A lot is related to drowning, accidents, car wrecks, getting running from a car and so forth. So I think that we can reduce mortality risk hopefully by having this system. So.
We are a little bit behind schedule, so I'm going to just sort of make one last call for comments, debates, opinions. I would love to hear from our federal members as well. Thank you to Matt from the CDC for commenting.
Thank you. Yeah. Hi, Christina Chacon from ARC. I know you said you wanted to hear from the federal side, so I will be brief because I know we're running up on time. But I think all of us here recognize the importance of this. And I think Matt really answered my question because my biggest thing was confirming, I think from the federal side, just making sure that we're promoting accurate information because we want to do our best to help the community and help the caregivers and also help not just the caregivers, but the family members and your friends that are also, it takes a village. And so just ensuring that the information that we're going to be creating as a federal government is accurate is very important. And I think Matt confirmed that. So I think from a federal standpoint, that is something that was very important on our end. And so thank you, Matt, for doing that.
Again, from the CMS side, we appreciate these recommendations and we'll need some more time to take a look at them internally, given that we just received them.
Okay, so we're going to adjourn for a break. Now we're going to have our break be slightly shorter. It was originally scheduled for 15 minutes. So we'll take a 10-minute break and return at 3:25 for brief further discussion and then voting. Thank you.
federal official. The products that come out of this committee are really meant to be deliberative, which means that they should have the participation of the federal members as well as the public members. So when we talk about having conversation and when our friend from the CMS says that they need to go back to their federal agency, I think a lot of people in the room would also say that they would need to go back to their agency, that they can't speak for their full agency. So that puts the federal members in a slightly challenging situation in that they also recognize the urgency. And I think many of the people around the table would say that they feel even more urgency because we're responsible for all of these, the laws, not the laws, but the ways that things get put into place. And everyone in this room is just as passionate as each other and really wants to see change. So I just wanted to put this out there that if we go forward with a vote as is presented now, there's a good chance that the federal members will have to abstain, and that might not look great from the public. It may also cause some FACA issues because there hasn't been the deliberation that's required to come out of this committee. So I just wanted to put that out there. Is there anything else? Oh, go ahead.
Is there a way to take a vote between meetings to expedite things? Like if we determine that they need 6 weeks or whatever for discovery or to gather information, can we hop online and take a vote?
I think the votes would need to happen out in the open. We could potentially schedule a brief Zoom meeting or something, like
Right.
1 hour meeting. Yeah.
Okay. Yeah. Thank you.
And we are also looking to have the next IACC meeting probably before the end of the fiscal year. So we're not talking, early next year. We're there. That's a really fairly quick timeline. But yeah, I mean, again, I think it was Katie made the point that we don't want to not be a productive body. Just want to make sure that we're not getting in trouble with the law or on the front page of the Washington Post because we haven't done things the proper way and have to go back and redo them again, right? So are there any questions about that on the federal rule on the FACA?
I have a question about that. I think we've had ample time for deliberation in a public setting today, and all the members have had the material since Thursday. And I think the suggestion that this is not somehow compliant with FACA is not accurate. And I reject that. Ginger.
I also wanted to say, I've been kind of thinking about this, how to say this well. My comments date back to the times and the years that the thing should have been done. Everything considered at this meeting should have been done in the first IACC meeting in 2006. And the fact that we're still having people saying, even if you're a substitute, even if, why did Caprice leave? What's so important? Our community, the parents are like, we are in crisis. To ever hear 26 years later, we haven't had enough time to deliberate. All the parents on this committee have deliberated. We've lived it. We have decades of experiencing and knowing the value of what we vote on here. So I just don't want to hear that anymore from federal members, because if you're a federal member, this should be your specialty within your agency, and you should already know what these issues are. So I also reject the ethos of we hadn't had enough time. It's been 2 decades.
I'm just making the point that the product that goes forward from this committee per FACA rules has to be a deliberative product that is deliberated by this body. So it shouldn't have been written really before coming to this body, and without any chance to edit based on the feedback from other federal from the agencies that these federal members are representing. I can promise you that at my institute, I might be able to get the director of the institute to review it within 3 days, but I couldn't get Matt probably to review it within 3 days. So I'm just making the point about the product. I'm not arguing about the science or about the situation. I'm just saying that per FACA rules, that's my job here, is to talk about the FACA rules. That's what is required.
And then that, to me, that says that the agencies need to figure out how to fix that problem.
For clarification, can you repeat what you said about the paper shouldn't have been presented? I mean, I've been to IACC meetings for a very long time. There were always presentations made specifically on wandering and elopement for years. I mean, that's what got me to know about the IACC and the importance of what we do here. I didn't even hear anything from the CDC saying that they were asking for an extension. So I don't know that the presentations shouldn't have been given before. Like, there would be a work group to put that together. This time there was no work group because this is our first meeting. So I'm just trying to get clarification. Like, would we have just talked about it and then put together, like, who would have put together a document beforehand, number one? And then number two, if there's no disagreement about a specific, let's call it recommendation or what was provided in the papers, can we at least go paper by paper or like recommendation by recommendation and see if there has been enough deliberation that we can vote on it? I don't know FACA, but it seems to me, at least on one of these, there's no deliberation that needs to be taken further than we've already talked about it. And frankly, this organization has talked about it for years. So that's my point of clarification.
It's not speaking in an official capacity as the designated federal official for the IAC, but because this committee has as voting members federal representatives from the different federal agencies, it's that deliberative process that they need to also be a part of. So it is really remarkable, the documents that were prepared for today and the amount of work that went into the documents. And I think what's being suggested, if I could go that far, is to give the federal agencies an opportunity to review these before they're voted on, because as written, the letter does say that the committee is putting forward these recommendations, which for the federal staff, that means that they are among those that are making these recommendations for these specific actions. And while it might not appear as if it's making policy, it is in a way putting the agency in a position to do that. And so they just need to, in their role, do their due diligence to have the time to review what has been proposed here. I would also suggest that there's probably some things in here that may not be considered in terms of other agencies that might have equities in them. And that can also be identified and some other things clarified if they are able to have the time to review them before voting on anything.
Bill?
So thank you for the opportunity to comment. I mean, I guess this is directed towards the federal leadership. I've been doing work with the federal government off and on for 3 decades. And generally speaking, when there's a deliberative body, there's kind of a rules of engagement process. That was not included for any of the public members in our onboarding beyond just a cursory PowerPoint presentation that, in spite of all best intentions, still got press coverage. So from my perspective, when we put a kind of a dialogue in place, we ought to at least know as public members what the actual process is so that our voices are not stifled by delay and a desire for further deliberation that may or may not be necessary. So, from my perspective, I'd just kind of like to know what the rules of the road are and get proper direction on that so we can make sure we're as constructive as possible.
Dr. Member?
I wonder, sorry, let me get my video up. I wonder if the public members, and I know that many of my colleagues have studied these issues, are able to vote today so that our voices aren't delayed and the autism community understands that we are working actively for them. And then if the federal agencies, for legal reasons, need more time, that could be facilitated later. But I would hate to leave this meeting today without being able to vote on these issues, especially the wandering issue. Thank you.
Gilmore?
This is my first day here, and we did not, at least I didn't receive any statements, information about what the decision-making policy is within the committee here. So, I find it hard to believe that there isn't a standard operating procedure for doing this kind of thing. Is there a standard operating procedure for doing this kind of thing? And if there is, I would assume we should follow it. And if there isn't, I don't see why we can't go ahead and vote. And if federal members believe that they should abstain, that's fine, abstain.
My understanding is, and I have not run this type of FACA committee before, I've run review meetings in the past. So, but my understanding is that generally the FACA committee would meet and come up with, for instance, a topic that they're interested in, like wandering, form a work group, and then come up with recommendations during that work group that includes the federal members. In this case, the federal members were not included in that deliberation, like Jennifer pointed out. And so it makes it challenging for the federal members to vote on something that they haven't had a chance to fully consider in terms of going up their ranks, and then will be responsible for. So it's, I mean, if it were me, I would recommend tabling this until the very beginning of the next, I don't think we can take two separate votes on the same issue. Do you know, Winnie?
I'm not really sure how we would have half of the members vote on a particular topic and then the other half vote later. But we can check with our Office of Committee Management.
Why don't we have a vote on whether or not on each specific issue, we should take a vote? Because at least on one, there doesn't seem to be much disagreement, especially by the agency who would be tasked to do it.
Laura. I just want to clarify that under FACA, there is no minimal time period for deliberation. Basically, the requirement is that we publicly deliberate and we consider these things, which I agree with Sylvia, we have done here today. And it's, yeah, as John Gilmore said, if the federal members need more time, they need more time. But I propose we vote.
I second that. Lisa Ackerman.
I agree and wish we could vote on these very important issues and show the community we mean business to move forward for the community. And these issues have been discussed. I've watched them and have thrown things at my computer.
So I'm speaking now as a member. I understand if federal members feel they need more time, and they should either abstain or vote no in that case. And my hope is after this voting process, we're going to turn to hopefully the formation of several working groups that will include federal members, is my strong hope, so that we can have a process of working together for the future. And if particular attachments or particular proposals don't pass today, we can take them potentially to working groups that we form and bring them up as, kind of a first order of business at the next meeting. Again, I do understand that our federal colleagues are in potentially a different position. But I also agree with my public colleagues that we represent the larger autism community, and this community has waited 2 decades for action. And I think we have a responsibility to that community. And well, that's my thought. Thank you. John?
Yeah, can someone explain to me how the process works? I'm under the impression that all the deliberation is supposed to happen basically in the committee meeting here or in a working group. Yet, if I understand correctly, discussions, the federal agencies are essentially requesting to deliberate committee work in their agencies outside the bounds of where we're supposed to be doing this. Do I have that correct?
I think the point is that the federal members that are in this room I'm projecting, don't feel like they've had a chance to take the information back up to their leadership. And so they don't feel like as individuals representing their agency, they have the correct information. So they haven't come to the table with adequate representation.
Yeah, if I could offer, in terms of Federal Advisory Committee that we administer and oversee and support in the Administration for Community Living. That committee does not have federal members that vote, but in the deliberative process, as Megan mentioned, there are topics that are proposed, and the committee decides what topics they're going to focus on, and then they work with the federal members on proposed recommendations, and it allows time for the federal members to take a recommendation and then give their feedback until and that feedback is discussed in the public setting, so that it is deliberative as part of the committee business until the committee decides to ultimately vote on recommendations. Just an example of how that works.
Dr. Marcella Roniak, sorry, I don't have the full name in front of me. Thank you.
Thank you. I appreciate that. Yes, and it's Dr. Roniak, but it's fine. I just wanted to say that, I am kind of in dual role because I am here representing our agency. And I do understand that it's a very frustrating process in regards to what the federal agencies can and can't do and what kind of decisions can be made for those of us that are at the table. But I also understand from the private sector as a parent who would want to ensure that there are pieces that we're looking for our children and for safety within our communities. So I would like to just also propose, is there a possibility of walking through the recommended sample proposed letter and maybe identifying as a group which items that federal partners and our public sector feel ready to vote on, because there could be some pieces that we could vote on, and others we would put in another bucket, if you will, because I work in buckets, sorry about that. We would put those that have other federal implications. And so part of the reason we need to go back to our leadership within our agencies are that there are policy implications that may need to be changed. There are funding implications that may need to be changed or adapted. And in the presentations that we've had this today, there are also other implications within each agency that may be impeded by some of the workforce changes that we have gone through recently. Some of our agencies are running even slimmer than before. So ensuring that we have somebody that can do the work, and I'm going to kind of call out our last one with attachment 3. A lot of that is internal work within an agency that could possibly be done, but it would behoove us to allow that agency to go back and look at their workflow process and develop a timeline of when those guidelines could be updated. What's reasonable to have that action done? Those are the kinds of things that happen in the work groups. Like if we normally would have a work group and we would deliberate, the work group members, including the federal members, would come up with a strategic action plan and a time plan for the timelines of deliverables. We kind of are missing that piece since we are kind of going from presentations today and wanting to do a vote. So maybe there's something that we could do to kind of find ourselves in the middle so we can make some positive movement today and have a vote, and also be able to then move things into the other bucket as to here are our priorities for work groups in the next meeting. Thank you. Appreciate it.
Thank you. Laura Sweeney.
Yeah, I just want to clarify some things here. Thank you so much for that previous comment. Couple things. Number one, we are a little bit different than some advisory councils because we do have the Autism Cares Act. The Autism Cares Act specifically directs us to take action in recommendations to the Secretary of HHS on certain topics. So that is, all of these that are being considered here today are directly tied to the authority in the CARES Act. The other thing I want to point out is, you know, as our federal members, you guys have different processes and different stages of policy development in which you are soliciting public advice or hardening things for final drafts. This is not that stage. So what we are attempting to do is we're attempting to fulfill some of the directives in the CARES Act by making urgent recommendations around issues that are particularly concerning for clinical care or safety needs to the Secretary. That does not mean that these are going to necessarily be implemented, and these are non-binding. So also for our public that is listening, what we do and recommend here does not necessarily mean that these will be incorporated or adopted by the federal government. For those federal partners, I understand my husband is a bureaucrat in the state, and so I completely understand the need to go back to your agencies to get other consideration. That can also happen if the Secretary receives our recommendation. You can go back and let him know if you have workforce shortages, if there are other agencies that you think that this can be applicable to. All of that can happen after we make these recommendations or not. Actually, it might even give you more flexibility to have those conversations outside of the FACA requirements for this body. So I just want to make those clear. Thank you.
Thank you. Just one quick point that although they may, first of all, again, that would not necessarily represent the federal worker, sorry, the federal member thoughts on the proposed text, which is the product of the committee. I just also want to point out that HHS will likely be required by GAO to indicate how they respond to these recommendations. So it would end up likely being binding for the federal members.
I'm sorry, Megan, are you?
When the IACC makes recommendations, GAO asks us as HHS how we are implementing these recommendations. So they're not exactly non-binding.
Tracy.
So first of all, there's a huge divide here between the public members and the federal members. And that's been like that for a while. And secondly, Sylvia stated as earlier, she sent these documents out. And if you are going to go over them, take them back to your departments and vote on it that way or make your decisions, when will that be? Do we get a solid date? Do we get an answer, or do we have to wait another 10 years?
Ginger.
My understanding again that the autism community has been sitting on these recommendations for decades. So this committee is finally taking them to the secretary and say, this is what we recommend. I don't understand your explanation that you would have to justify that to GAO, because we're not making policy. We're just saying this is policy that we would like you to start on the journey to becoming reality. So I don't think you're accountable to GAO because it's not the secretary's policy yet. Wouldn't that be the stage where you would go back and go, we've got a funding problem here, we've got a staffing problem here, we want to change these 3 words around. Why is this a blanket recommendation to send us along the road? And if the fact that the wandering piece is involved in this, I think it is dark if there's anyone in this room, in this building, who would have a problem with it. My family is affected by this. My son is in 1st grade. He was in an autism classroom of 3. There was 2 by the end of the year because the only girl in the class lost her life to drowning. So it's baffling to me that people wouldn't be rushing to, summer's coming. This is the drowning season. What's going to change between now and then about these recommendations that you can't go back and go, oh, we have a new consideration. We would like you to change that tree to a 7. We can amend this at the policy-making level. This is the beginning stage of, here's the problem. Here's the needs of the community. Please, Secretary, let's start fixing these problems.
Thank you, Deirdre Assay on virtual.
Thank you. So I just want to flag that many of us do not have we're the sole representative from our department, and we do not necessarily have the autonomy to move without approval from maybe our secretary or our leadership or the immediate deputy under that person. 3 days is not enough to get eyes on something that I would need to vote on. In all cases, like there are some things that I feel like I can, but they're not all things. If there's going to be conflict within my agency, I will not be able in 3 working days to get eyes on it from anyone outside of my building, let alone the number 2 in my department. And it is unfortunate. This is a new scenario for many of us where there is a lot more oversight for federal workers and a lot less autonomy than for those of us who had been on previous had served previously that we had at that time. Unfortunately, that's the reality, and my department is represented in some of this. Very little. But we're not charging my department. But if this moves forward, my department would be on the receiving end of the secretary's action if the secretary of HSS chose to take our recommendations. I feel really confident in doing that today, but I just want to voice what some other people may be experiencing, that they are not showing up here today with a level of autonomy that they may have been able to show up with in years past.
Thank you. Laura Salini.
I just want to make sure we're not conflating for clarification, and I appreciate Megan and Oni's comments around the GAO. That's really good to know. However, the request from the GAO to answer is not the same as a binding requirement legally. So I just want to make sure we're not conflating things with, you got to justify a reason for GAO as opposed to this was a shall and you have to do it. So just legal clarification there on wording. Thank you.
I'm going to do Bill Oldham online and then Lisa Weiderlight.
So I have a great degree of confusion as to what the process actually is, because it sounds like public and federal are talking past each other. And if there is a process, then the public members need to be informed on what that process actually is, so that we can actually begin to move forward. I would like for us to move to a vote on these issues, and if federal members have to abstain, then abstain, and we can come back to it, as Sylvia suggested, in working group sessions to make these documents better. None of these documents are intended to be perfect today. We need to make steps forward, or else we're not doing our jobs as committee members, from my perspective, let alone honoring our community.
Lisa.
I'm going to apologize if I seem gruff right now. I don't mean this. I'm very frustrated, to be honest with you. None of us here who are parents have time for this sort of thing. Our children in our community need us to protect them. I'm looking at this agenda, and mind you, I've seen agendas for 30 years in my career, and it clearly says public comment section done, all of this done, lunch break, committee business, and we talk about all of these things that we've been talking about for hours, and it brings us to a vote. Did no one see this prior to this, that we were going to vote? I know, again, I apologize, but I work 2 jobs. I've got a kid who's one-to-one 24/7. I'm up 18 hours a day, and I was up till 2 o'clock in the morning reading these things. And I understand that the federal agencies may need to go back, and I respect that. I worked for a federal government for a while, so I understand that. What are we talking about right now? Are we refusing to have the vote? I'm trying to understand what this conversation is about. Is it about stymieing what we're trying to do? Do we have to wait? Can someone move to have a vote anyway and the federal agencies can choose to abstain? Because we keep talking, but we're not doing. And this IAC committee is going to do things and good things, and we're going to protect people, and we're going to make a difference, and we're going to be effective. That's why we're here. That's why we lose sleep. So
I don't think Robert is. I think there's a call for a vote. There's been a second. If you would like to call for a vote, I'll second it again, and we can proceed and try to move this forward.
yeah, but I just don't understand what we're doing. So, I mean, I would like to call a vote if we could on piece by piece, because again, it appears that we could pass at least one of these things, but we have to do something because I see the agenda and I saw the agenda and I read the agenda and I read all these things and I don't understand what's happening.
Caden, and then I'll make a comment.
I want to vote, that's why we're here.
Amen. Tracy, and that'll be the last comment.
Just real quick. So the public members are very clear that for the most of us who have spoke up that we want to vote today. If the government members cannot vote at this point, can you give us a timeline as to when you will get those votes back to us, please?
My understanding is that we're going to vote today, and if the federal members or anyone wants to abstain or vote no or vote yes, whatever it is, it will stand for today, and potentially we can bring proposals to working groups, which we also still have to discuss and vote on. I'm going to make the difficult choice to have us move on, vote on all the proposals as written, except with the addenda, the addition that was provided by Elizabeth Bonker earlier. I understand, again, if the federal members need to abstain, we get it. But then let's come together in the working groups and revise and move forward. This is opening a door. This is not final policy. We are making broad recommendations for HHS to consider. They are not binding. And I'd like to, do I have a motion to take a vote? And we're going to vote in reverse order with voting on attachment D first, which is the wandering and elopement. Do I have a motion for a vote?
I motion to make that vote.
Do I have a second?
I second.
I believe the voting is going to occur through Zoom links that were sent the other day. So, sorry.
Yeah, so
there was an email sent from, it's actually, the link is from
it's from One Source Event.
onesourceevents.com. I received my link on April 24th at 5:14 p.m. in case that helps.
So mine popped up in the meeting. Is
Yep,
that
as did mine.
Yes.
appropriate? Was it the top?
Yes. So, yeah. No, everyone has their own unique link.
Well,
So you have to find it in your emails. I'm sorry, that wasn't.
it came from Amy Osowski.
So what we're going to try to do
Well, at least
is
to the public
count the
members.
votes in the room for people that don't have access to the Zoom, but you're going to need to give us some time to make a note because we need to record who voted for and against. For anybody who wants to use the Zoom, you're welcome to do that. If you're not using the Zoom, we'll count you in the room. Please don't vote in both places. And also, if you are a federal member and there's a member and an alternate here. If you are a federal member and there's both a member and an alternate here, please make sure only one of you is voting. It's one vote per agency, please. Dr. Hines, you would be the member. Yes.
I believe Margaret Bush virtually has her hand up.
It popped up on my screen. So is that my vote, or do I need to go into the other link that you were referencing?
Same with me.
If it popped up on your screen, you can use the Zoom to vote.
Okay, thank you.
Excuse me, what do I do if I can't find it?
If you can't find it, we'll get votes in the room. So I guess anybody who hasn't voted in the Zoom already, raise your hands and we'll just get a yes or no or abstain from you.
So we can vote now if we do have it.
If you do see it in Zoom, yes, you can vote now. This is yes on attachment D, and this is to adopt all 9 recommendations within that attachment.
This is Amy from tech support. If it's not popping up on your screen, you can look in the more under polls and see if it's there on Zoom.
Judith, you have a question? Okay. Just give us a couple seconds to make sure the people who are trying to access it on Zoom are able to, and then we'll see who else needs to vote. All right, if you're in the room and you did not vote on Zoom already, please raise your hand and we'll record your vote. Elizabeth Bonker?
Yes.
Ginger Taylor? John Gilmore? Judith Cooper? Honey Renicello? Luke Hall? Anybody that I missed in the room? Rick Lambert?
Yes.
Yes. I can't tell who's down at the end. I'm sorry. Dr. Zarodny? Yes. Daniel Keeley? You put it in the Zoom? Okay. Anybody that I missed? Anybody on Zoom who did not see the poll come up for them? Somebody say something? No. Okay. All right. It looks like we have 7 abstain and 26. 6 plus 8 is 34 yes and 0 no's. We'll need to go back and confirm that everybody who voted in the Zoom is appropriately voting, but I think the yeses have it.
Thank you. Do we have a motion to vote on attachment C, the profound autism designation?
I motion to vote.
Yes, second.
Second.
Okay, so there should be a new poll that launched in Zoom for those of you who are able to access it. We'll give people a few minutes to, or a few seconds to vote, and then we'll go around the room again. All right, Elizabeth Bonker?
Yes.
Others in the room, Ginger Taylor? Yes, was that? Okay. Others in the room, Judith Cooper? Yes. Honey Renicello? Yes. Rick Lambert?
Yes.
Yes. Any others in the room or on Zoom?
I did.
Okay, so we have 13 abstain, 26 yes, and 1 no.
And proceeding in reverse order, do I have a motion for a vote for attachment B, proposed HRSA clinical guidance on structured review of systems, reduction of diagnostic overshadowing, and clinical safety assessment for individuals with autism spectrum disorder?
I make a motion to vote.
I second.
Give me 1 second. I'm sorry. I'm trying to pull it up in Zoom.
This is just for attachment B regarding HRSA.
Is that Rec 5?
Should be attachment B, adopt all. I don't see it. So what we're gonna do is, let me, could we go to attachment A while I modify the poll for attachment B? Sylvia, is that all right?
Do we have a motion to vote on attachment A? Sorry, I just want to read it out. Proposed CMS guidance, EPSDT clarification regarding clinical assessment, co-occurring conditions, and safety risks for children with autism spectrum disorder. We're skipping B for now.
Yeah.
We have a technical issue, and we're going to go to A, and then we'll come back to B. So this is for attachment A. Do I have a motion to take a vote?
Yes, I have motion for vote.
Do we have a second?
Second.
I apologize. My Zoom seems to have. Okay, let me go back. Okay, attachment A. All right, you should see it now. All right, we can go around the room. Elizabeth Bonker.
Yes.
Others in the room, Ginger Taylor? Yes. Judith Cooper? Abstain. Honey Renicella? Yes. Any others in the room? Rick Lambert?
Yeah, it's yes.
Yes. All right. So we have 12 abstain and 27 yes. All right, and you'll have to give me 1 minute. I'm sorry to fix the poll for attachment B. That should have launched for you all for attachment B.
I'm just going to clarify that attachment B didn't contain EPSDT guidance. So I'm fine voting the way it is, but I just want to be clear for all the members that attachment B was proposed HRSA clinical guidance on structured review of systems, reduction of diagnostic overshadowing, and clinical safety assessment for individuals with autism spectrum disorder. This attachment did not contain EPSDT recommendations.
I apologize for that.
Okay. Are you okay just continuing the vote?
Yeah,
Okay.
that's fine,
Okay.
as long as everybody's clear.
Everyone's clear
Voting
on
on
that?
attachment B. I can rename it later. In the room, Elizabeth Bonker,
Yes.
Ginger Taylor,
Yes.
Judith Cooper, abstain. Honey Renatella, yes. Rick Lambert,
Yes.
yes. Anybody else in the room I missed? All right, we have 13 abstain, 27 yeses, and 0 nos. I should have said that for the others.
Okay, so that concludes this portion of our afternoon. Thank you to everyone who expressed their opinions and participated, obviously. And I'd like to move on now to working group proposals and discussions to shape the strategic plan. I think as has been obvious here today, I think many members here have expressed an interest and the importance of having working groups. What I imagine is that our working groups would be able to function as many FACA working groups do outside of a public meeting, so that individuals could collaborate with each other, ask questions, work on proposals, engage subject matter experts. My hope is, and this has been in discussion with Diana Diaz-Harrison, our National Autism Coordinator, that perhaps we could have some public virtual meetings that the working groups would sponsor from time to time, especially if we wanted to engage multiple subject matter experts in discussion. And I would also envision that perhaps those public forums could also include listening sessions that would allow our public to engage with this committee more. I think there are many more people who would like to engage with this committee. I think especially that they understand that we see their lived experience and are responsive to that. I first would like to just open up some general comments to just the ideas of working groups and what people are interested in. I have some ideas that I'd like to share, but this is, a participatory process. So I'm just going to open the floor for discussion initially. Crystal.
I think one of the resounding topics we heard today throughout public comments in person and here on the committee was about communication rights and access. I would love to suggest a communication working group. And as I mentioned in my presentation, there is an array of safety needs that are really critical to address. Wandering and elopement is one of them. So I would love to see those topics addressed consistently in this committee. Thank you.
John.
I'd like to propose a working group that focuses on epidemiology and also perhaps definition of autism. You can't do one without the other.
There's a hand online, Bill Oldham.
Bill Oldham.
Yes, I mean, a couple of comments. One is, I think if our session today proves anything, it proves that there is a passion for making progress I think that is shared by the federal members. I don't discount that for a moment. I think that if we don't have working groups, I don't understand how we make the substantive progress that we need to make. So I think, to me, this is a critical evolution for the work of both public and federal members, and welcome participation across a range of working groups. Thank you.
I'm just going to make a quick comment that I'm excited to support the working groups and facilitate conversations between public and federal members to make the working groups robust, actionable, and will really be the meat of our work together.
I'm just going to make a brief comment. In your packet of proposals, this is getting back to the vote, there was also a proposed sample letter to the secretary. I do think we should go back and vote to see if the committee votes to send that letter. Hopefully you could take a quick minute to review it. I think Oni will work on setting up that vote, but in the meantime, we can continue our working group discussion. Dr. Mumper online.
I'd like to propose a working group addressing underlying comorbid conditions associated with autism.
Thanks, Tracy. I'm Dr. Mumper online.
I am. I just don't have video. I was going to propose a working group on the medical evaluation, workup, treatment, with the goal of getting those guidelines to providers of medical care. So essentially ditto. Thank you.
Sorry, Scott Robertson.
I think it would be good to explore the possibility of something on adult life issues. It was emphasized heavily today at times that folks spend the majority of their time in adult life, and so issues around housing have come up today, employment on our end, transportation. So maybe a working group that can explore, and a lot of those issues touch upon each other too. I know, for instance, us at the Office of Disability Employment Policy, I also work on transportation to work issues, and we look at housing because these things intersect together. So maybe I could explore these big picture issues that where you see a lot of major barriers and challenges for autistic adults and autistic youth as they're transitioning into adult life.
Lisa Ackerman.
Thank you, everyone, for this discussion. I would love to have a work group for wait lists for diagnoses and waivers.
Katie.
Yeah, just to build on your comments. I'm sorry, I don't remember your name.
Robert
Scott's comments. Just I was going to say something similar, but I would like to make sure it includes adult services, safety, and supportive housing, because the house part, the physical structure, doesn't speak to the comprehensive needs that our adults have. So adult services, safety, and supportive housing. Thank you.
Just make it just quick. Yeah, when I say housing, we mean like full connection to services. So we have regular. That's one of the reasons I wanted to sit next to ACL is where there's a housing interagency initiative called the Housing Services Resource Center that looks at these types of focuses. So yes, we are thinking of focused supports and services. I don't mean just housing, just folks who have an apartment and everything's wonderful. I mean, and the same for transportation too. Like transportation would be travel training, right? It would be, so all these focuses obviously would come with the support needs for folks with the major challenges to address, and you need better services for that. So I agree.
Thank you. Dan online.
Sorry, I had to go to Zoom. So medical comorbidities and potential treatments, and some of the comorbidities are things like mitochondrial dysfunction and folate metabolism and stuff, including also seizures.
This may encompass what Dan was suggesting, but I'd like a working group, or at least a subgroup of a working group around biomedical research priorities. So from primary research, we saw etiology was the #1 most commented or in the public comments. So, the kinds of things that NIH is allocating its vast budget towards. Thank you.
So I'd like to, as chair, I'd like to make a proposal that I think would encompass a lot of the topics that are brought up today. So I would propose 3 broad working groups. One would be a working group dedicated to issues around communication and safety. The second would be to medical care and research. And the third would be kind of broadly speaking, lifespan issues, but from suspicion to geriatric concerns, sort of across the lifespan that would focus on services and supports access. I think there would potentially be overlap in some concerns in different working groups. My only concern about having too many working groups is that people are busy and not everyone can dedicate a lot of time. In terms of those 3 working groups, my proposal would be that they be chaired by our public members. And so for the Communication and Safety Working Group, I would propose Elizabeth Bonker and Crystal Higgins as co-chairs. For the Medical and Research Working Group, I would propose Dr. Zarodny and Laura Salini as co-chairs. And for the, I'm going to just call it lifespan supports, for lack of a better word, maybe we could come up with a better title. But for that, I was going to propose Lisa Ackerman and Lisa Weiderlight as co-chairs. And as I said, I think it's incredibly important that we have robust collaboration between public and federal members in these working groups. And I'm so thrilled that Diana, that you are intending to actively support that process. I welcome comments or other suggestions. Scott.
Is it possible perhaps to split the adoption of the worker groups into 3 separate votes? I think we could be supportive of the one that pertains to our agency mission, but I didn't have a prior access to know in advance. There was no way of knowing, because this comes up dynamically, the other 2. So I think I may be only able to focus in terms of our ability to engage on the one that pertains to the agency mission. I'm sorry if to put the complexity, but yeah.
Thanks. I didn't consider that. Do other federal members have that concern about voting for a working group that doesn't pertain to them or that they may not participate on?
I think we could just abstain from that.
Yeah, I think CMS would have the same position.
I think the question would just be, would that impact if we abstain the votes?
Maybe we could just take up what the concern would be for voting for a working group that you wouldn't necessarily participate in. Well, maybe I could understand that further.
I know on my end, so I'm not the decider at the agency. Like, leadership is above me, and I just don't want to make a decision that they haven't had the knowledge to be able to since I'm the alternate and I'm standing in for our assistant secretary and leadership at the agency. It doesn't mean it doesn't mean any focus on it. I just, it's just better for me to be able to inform leadership on things, so I don't go back to the office, and our leadership doesn't like surprises. So yeah.
Thank you, Dr. Beckel-Michner.
Yeah, I think that the breadth of the working groups just makes it really hard to know what specificity, what will be covered based on some of the specific ideas that came up. So from my perspective, abstention is not a no. I want to be supportive. I just don't know, it's hard to vote for something when you don't have a firm definition of what it is.
Christina Chacon.
Is it possible that, I know in previous discuss, as we were talking about voting earlier, is this one of the things that we can vote on maybe online via Zoom, where we have a proposal of the working groups and maybe a brief description, who the chairs would be, and a brief description, and then maybe we could meet via Zoom all together and vote on it? Is that possible? So that way we have enough time? Would that seem like a fair compromise? Katie?
I just want to say that we are all very anxious to get to work. And so to once again kick it down the road for another vote impedes progress.
I mean, my conception was like whoever wanted to be on a particular working group, that working group could decide what they take up. For example, the medical and research group could decide to take up things related to NIH funding or FDA drug trials. I mean, that the working group itself would decide what order and what the primary topics would be, and then bring that information. Obviously, all working groups bring their information and recommendations back to this primary committee. So, for example, medical evaluation and co-occurring medical conditions could be taken up in the medical and research working group, should that working group decide that was what they wanted to prioritize at that moment. Or epidemiology, I would imagine, would be, in that research group. So I know it's a little fluid, but I think that's okay. The working groups themselves, if they are adopted, could decide what their primary focus would be in collaboration, public and federal partners.
Sylvia, quick question. Can you explain your rationale around having public members chair the working groups as opposed to having federal members having the opportunity to co-chair with a public member?
I feel like, we could explore that. I think if federal members wanted to chair a particular working group, I didn't mean that to be in a negative way. I feel like the passion and lived experience to the IACC is, being provided primarily by the public members. And I know we are all eager to get to work and don't have the opportunity to influence the federal response, in our daily jobs and life. So, but certainly, I apologize. I didn't mean that to be offensive to any of the federal members. And if there's a federal member who wants to co-chair a working group of any kind, it doesn't have to be the ones that I proposed. Here.
I think it's a good plan to have the public members chair the groups because they have the urgency and the understanding. The federal members are working for institutions who could have done any of this at any time. This legislation didn't need to be passed for you to do these things. This committee doesn't have to exist. And you haven't, not you personally, but your, CMA has not done their due diligence in seeing what we need and doesn't have a decision maker. And I have nothing against you, but I invite Dr. Ross to come and sit with us so he can make a decision so we can advance. The Trump administration is behind this. Bobby has been advocating for our kids for decades. What is happening here is really important and impressive. So I with respect to the federal members, I'm glad you're here, but you're not the leader in these topics. You're not, you're not looking at your mortality saying, how is my child going to be taken care of? And you live in bureaucracy. Everything has a great decision. And so I don't want that to be the guiding principle of the way this committee works. We have the urgency and we have the experience and lived knowledge. We have the resources. We have the kids who have recovered. We have the kids who have died. We're the story. The federal government has sit by since 1943 and let this be whatever. So I don't have the trust there. And if we are trying to rebuild the trust with the community to serve the community, I want to support Sylvia's idea to have this be community led.
Thank you, Ginger. Laura?
I think one of the advantages of having public members direct the committee is actually related more to FACA. While we do need and want and really will benefit from having federal and public members both serve, FACA does, there is a line for which we want to make sure that it doesn't look like there's too much federal influence on any sort of decision making from a public body. So I just wanted to put that out there as a consideration. Thank you.
Becky Hines, Dr. Becky Hines.
I just wanted to acknowledge that as a new person in the federal government, I feel, and what I've learned is there are a lot of people from the federal government here who do care and who are here spending their day working on this. So it feels a bit dismissive and a bit of an attack because many of us have never, some of us at least, haven't been here before. So I think that the way forward for us all is to think of this as a true collaboration and try to resist the urge of dismissing either group.
Thank you. Katie Sweeney.
Based on that, could we, or could I propose, or we propose that they are co-chaired by a public member and a federal member, that each of the three working groups? Is that a fair proposal?
I like that idea. And again, you know, I didn't think that through. I wasn't sure that federal members would want to co-chair, and I think that's a great idea. So I think as we move forward, maybe we can hone in a little bit on whether these three working groups kind of capture the issues that have been raised, and then would love to hear from federal members who may want to co-chair a committee. Not committee, it's not a committee, it's a working group, sorry, a working group.
I like that idea. So can we move forward with what would be the next step, a vote on those three committees?
Well, maybe what we could do is have a vote on three proposed committees, again, broad topics that encompass a lot of what has been raised here today, with the specific agenda of those working groups being determined by the co-chairs and members at this juncture. Scott.
And did you say, can you clarify whether you'll be able to split that into three separate votes it up? Because I checked with my manager and he said that would be our preference, so that it would make it easier with the one that's related to our agency mission being the one that's easier for us. Yeah.
Yes, so I have three different votes, three separate votes prepared.
Thank you.
Okay, let's try that. But I think if your federal role doesn't particularly conflict or with the possibility of a working group in which you won't participate, I hope that you could just vote however you want to. Okay, thanks. Do we have a motion to vote for a communication and safety working group with the co-chairs to be determined a bit later?
I am for that vote.
Votes in the room. Elizabeth Bonker.
Yes.
Ginger Taylor. Yes. Judith Cooper. Yes. Honey Renicella. Yes. I forgot my last person. Rick Lambert.
Yes.
sorry, we have 35 yeses and 3 abstains and 0 noes.
Thank you. Do I have a motion to vote on a proposed combined medical and research working group?
Hi, Lisa again. Yes.
Do we have a
Second.
In the room, Elizabeth Bonker,
Yes.
Ginger Taylor, yes. Judith Cooper, yes. Ani Renacella, yes. Rick Lambert,
Yes.
yes. All right, so 36 yeses, 4 abstains, 0 noes.
Okay, do I have a motion to vote on a working group that would encompass lifespan issues?
Motion.
Second.
In the room, Elizabeth Bonker,
Yes.
Ginger Taylor, yes. Judith Cooper, yes. Ani Renacella, yes. Rick Lambert,
Yes.
yes. All right, 37 yeses, 3 abstentions, 0 noes.
Before we continue our discussion on working groups and co-chair, well, I don't know. Should we go back and try to vote on the letter, or should we? Are you ready for that, Oni? Okay. I just want to go back. So in the packet that you received was a proposed sample letter to the secretary with all of the proposals that we voted on today. If they hadn't moved forward, we would have amended the letter. But given that all of the proposals moved forward or were voted yes, the question would be to vote to send this letter to the secretary. Do I have a motion to send this?
Motion. Second.
What's in the room? Elizabeth Bonker,
Yes.
Ginger Taylor, yes. Judith Cooper, abstain. Ani Renacella, yes. Rick Lambert,
Yes.
yes. All right, we have 13 abstentions, 2 noes, and 24 yeses.
Okay, thank you. So it looks like we've adopted 3 working groups. Again, communication and safety, medical research, and lifespan supports. So I open the floor for discussion about those who would like to either propose or themselves or propose someone else as a potential co-chair of each of those committees. Scott.
Just a question on logistics. Are we going to have to vote on the co-chairs, or does that not need a vote?
That I don't know, actually.
Okay, I just wanted to I'm filled in my, I can't do anything without my boss, sorry.
I'm in favor of voting for that, but Lisa Waiterlight.
On a similar type of committee, we had people pick their committees that they wanted to be on, and the committee chose the chairs and the co-chairs. I would
That's a good
suggest
idea.
that as a good thing because
Okay, great. Okay, so let's do it that way. Maybe we could start with the communication and safety working group. You can be on more than one working group if you want to be. And maybe, I don't know, should we do that by show of hands? Like who wants to be on each working group? Logistically, what's...
Sylvia, can I make another suggestion that can we actually go back and consider and send you give us a date like a week from Friday or something, because yeah, we may be able to find really enthusiastic experts and people that will want to serve on those committees outside of the members of the committees that would be representing, broader interests. I think we can do that on a working group. Is that correct? I'm going to look at our federal partners.
Yes, we can have
Because they're-
outside members
Yeah.
on working groups or
Okay.
working group members do not have to be members of the full committee.
Oh, okay, great. I didn't realize that, so that's perfect. So maybe we could just, Ginger.
Is that true of the private members as well? We have experts on all of this. Okay.
I mean, one thought would be that the public members today could declare which working groups they would like to be on, and then we would await follow-up from our federal partners about who might be. I just don't know how we would do that sort of publicly.
Publicly in terms of
Like just finalizing, do we need to finalize the members of the working group in this public forum, or could that be done
No.
outside?
no, we don't need
Okay.
to do that. I don't
Okay.
think so.
So what I would propose is that the public members today indicate which working groups they would like to be on. So we're going to start with the communication. Sorry. Okay.
Can we establish a target size of these working groups? Because if we're going to open it up to public and federal, they could get very large and unmanageable.
John.
Continuing on Katie's point, there's 43, 46 total public and private members. Does somebody know?
There's 43 total
43.
members of the
Right.
committee.
So, maybe we should limit the total pool of people who can be at 43. So if a federal member doesn't want to be on, well, their spot could be taken by somebody within their organization they would feel more comfortable with it, but not necessarily have 10 people show up from that same organization representing that one voting spot. That's so
I'm
sorry, just to continue from that standpoint, maybe a federal member could or would like to go ahead and commit, and they feel, empowered to do so here, but there's still an open period where they could be swapped out or that role could still be filled by somebody, just as a process point.
Thank you, John. Amy Adams online.
Thank you. I just want to acknowledge that there's a lot of ways to manage a federal advisory committee and its working groups. So we've seen a lot of variations on that theme. But I do just want to reiterate my understanding that the public members and the federal members could potentially suggest experts who could participate in working groups. And I could imagine that there are members who might have important perspectives to add to more than one working group. But I appreciate the point about the size. I do. But I feel, for example, my colleagues at the Deafness Institute would be relevant both to the medical research and to the communication working groups, right, in really substantive core ways. So I do think, giving folks like a week, not that long, I appreciate the urgency, but just to let people really think about the right expert voices that they want to include in these discussions, and think through sort of the right collection there. And then the public piece would be once the working groups are decided, then you would publish the rosters of those just so that there's transparency on who would be on each working group.
Laura?
So I'm just double checking FACA and maybe some of the federal members. So I understand that with our working groups, we can solicit membership that are not appointed to the committee. However, I believe that they cannot act as voting members in the working group, if I read the act correctly. Does someone have clarification on that?
So
I'm hearing from our committee management office that that is correct.
Thank you.
Is there a way also for the federal members, you could, when you send out the request for the membership, can you put something in around depth and breadth of what that group might represent from your perspective? So we have a little more information around it to make choices. That'd be helpful.
Thank you. So I'm with that clarification from Laura Salini that non-IACC members would not be voting members of working groups. Does that change anyone's perspective about having non-IACC members named as part of working groups rather than being able to simply solicit their input during the working group process? Scott.
I was just going to say that we didn't use working groups in the last iteration, but I was on the committee a long time ago as a public member back in 2012 to 2014, and we did have working groups then, and we had a similar one on quality. And folks were there just for their expertise, basically. Like it was researchers and service folks, et cetera, that had a lot of expertise in that specific area, right? So I think I just want to say this aligns with historically what the committee has often done with having work groups. Having SMEs would be similar to what it's done in the past, who aren't on the. I mean, that's one of the purposes of having them, right? Is there may be expertise beyond the folks here, right? There's a lot of folks out there beyond who's in this room. Yeah.
Dr. Beckelmich.
Yes, my experience with working groups, similar to Scott's, is that they are there as getting information together so that they bring it to the full committee and the committee votes. There's not that many votes that happen in a working group. It may be an informal vote, but it's non-binding because it's the work of the committee and the committee members where the votes happen.
Laura Salini.
I personally think that maybe for clarity, because I can imagine that there will be a lot of interest from non-appointed members to serve in working groups. As we know, there's no shortage of stakeholders and opinions. So I personally would prefer that we solicit stakeholder input from various experts. I agree. I think that is absolutely necessary to bring in researchers, people in the not-for-profit sector, other areas that can be very helpful to us. But I want to make sure that that it is actually, in understanding what FACA does state, it is actually the members that are appointed on this committee who are the ones driving these decisions. So just for clarification, I wanted that to also be a consideration, that even if we didn't have them as official working group members, that they could maybe just come and present and ad hoc information from them, and we could solicit their advice and input. Thank you.
Any other comments? Lisa Waiterlight.
I just wanted to add, I mean, I know it's been a long day, but as a parent who's seen many iterations of the IACC, like it's heartening to see this level of interest from federal partners who not only want to participate, but lead, and not only lead, but bring subject matter experts. It means a lot. So thank you. And I hope this is the beginning of like a really, really good sign for all of us to make urgent change very quickly. That's really great. And maybe some innovations that haven't been thought of before. So thank you.
I would just like to make a comment as a member. I appreciate Dr. Beckel-Mitchner, your proposal about having non-IACC members on the working group. I think my preference in the way that I personally had envisioned them was that they would be IACC members and that we would solicit input from subject matter, even regular input from subject matter experts, researchers, academics, stakeholders. So maybe what I would propose is for us to take a vote now about whether we want non-IACC members to be officially part of working groups. And then I think in terms of just committee business, I will provide the federal members, all the members, with a sort of an outline of what the committees might take up. And then we could receive a response within 1 week about which federal members would like to be on which committees. And I would also like to proceed today in the few minutes we have left with identifying which public members would like to serve on which committee. So do I have a motion to vote on whether or not we would include non-IACC members in the working groups?
I make a motion to vote.
I second.
So, but all in favor of which one? Okay, all in favor of including non-IACC members on working groups, please raise your hands and
Yes.
Sylvia, as official members versus bringing in people as needed. There's a difference.
This is as official members. Non-IACC members as official members of the working group rather than just being brought in for subject matter expertise from time to time.
If you're on Zoom, you can, I mean, if you're attending virtually, you can raise your hand in Zoom as well, and we will count you. None, no hands virtual.
Dan Rossignol and Bill Oldham, are you voting to allow non-IACC members on working groups, or are you raising your hand to make a comment?
I'm okay to have them as members, but not as witnesses is how I think of them, rather than expert guidance, but not full members.
Okay, so this is full members of working group. So is your
No.
no? Okay, Dan Rossignol.
I would say no.
Okay, everybody else in the room who vote no, please raise your hand.
Those online who are voting no, you also need to raise your hands.
Voted twice.
Voted twice. Christina Chacon, are you voting yes for, or no? You're voting no. Okay. Yeah. Yes. Okay.
Dan, you had expressed that you were a no, Dan Rossignol. Can you just officially vote if you can, if you're not going through security or something?
I'm sitting outside of security, so no.
Okay.
Okay.
All right.
I think I just needed clarity on official versus unofficial because they have no voting power. So I'm trying to understand that.
I think that they would be, sort of regular attendees at all working group meetings, as opposed to coming in from time to time, or even from periods of time to give subject matter expertise. That they would be kind of full members of the group, and that their, availability would be taken into consideration, that kind of thing.
All right, then I would vote no. Misunderstood.
Any abstentions? One.
I didn't. Yeah. Okay. It seems like there's a little bit of confusion here, and we do need to get out right at 5 o'clock, or else they will kick us out. So maybe we should try to sort some of this out by email or something.
Let's try one more time. We have a couple more minutes, okay? We are now voting for whether you want non-IACC members to be full members of working groups rather than just occasional participants for subject matter expertise, that non-IACC members would be full members of working groups. So everyone who votes yes.
Full non-voting members, right?
Full non-voting members. But as was pointed out, there aren't probably going to be very many votes, but we will be voting on who's co-chair, for example. So, so everyone in favor of allowing non-IACC members to be part of working groups, please raise your hands now. Including those online.
Anybody online in favor? Looks like no, so 10 in favor.
Everyone who is voting no, who is not in favor of having non-IACC members as full members of working groups, please raise your hand.
We have 17 in the room plus 8 online, so 25. Just 25 opposed.
Okay, so since we're out of time for today, I think what we should do is that we should follow up with each other in a group email about who would like to be on which working groups, both public members and federal members. And we could do that. It's going to be a big, long email chain, but we'll do it that way. And I would like to propose a deadline for that Tuesday, May 5th by 5 p.m.
The federal members are going to get a breakdown, correct, beforehand?
Yes, okay. I will send that out by start of day tomorrow.
Thank you.
Thank you to everyone who made the trip here, who participated. I look forward to working collaboratively with all of the members and all of our federal partners. And thank you to all those who participated with public comments. Our day today is adjourned. Thank you.